सांस रोक ले, सांस ले लें।
बातें करें प्लीज।
अमन है।
Are you okay? अच्छा। जल्दी बैठिए, जल्दी बैठिए। ऊपर चले, ऊपर चले। इधर आइए, इधर आइए, जल्दी भागे, इधर आइए। साइड पे चले, टेबल के साइड, टेबल के साइड।
रवि आपका फ्रेम आ रहा है पूरा?
अभी और आ रहे हैं दरवाजे कीजिए। अमान जल्दी आओ। अमान जिब्रान जल्दी आओ।
अरे बात करो।
किसी से उनके बैटरी क्या कर रहे हैं?
आ जाओ, जल्दी बैठो, जल्दी बैठिए, आगे बैठ, आगे बैठ। चलो रेडी,
चलो भाई।
1 2 3।
यस यस। और दूसरा
पाकिस्तान जिंदाबाद। मैंने क्या चीज
शुरू।
Assalamualaikum everyone. Assalamualaikum and a very good morning to all of you. Let us begin with the session 9 of the second day of our scientific day 3. And the first session is obstetrics and pediatrics anesthesia. To moderate this session, I would like to invite Dr. Anila Fazal from SIAG.
Assalamualaikum everyone. I am Dr. Anila Fazal, working as anesthetist at SIAG. I warmly welcome all our prospective guests, speakers, faculty members and dear participants to this session on obstetric and pediatric anesthesia. It is truly an honor to have such a gathering with us today. Your presence reflects your dedication to learning, professional growth and academic excellence. We are especially grateful to our chairperson for taking out their valuable time to share their knowledge and experience with us. I would like to request our chairperson, Madam Saida Haider, to kindly come on stage. And Madam is a veteran of PSA Karachi and professor of Emirates. Madam, please. May I request Dr. Akhtar Aziz, sir, is a senior anesthetist and CEO of the Kutiana Women Hospital. Sir, please come on the stage and start the session, please.
Okay, a very good morning to everyone, and I believe you people, all of you have enjoyed a wonderful breakfast session. It's unique to our society that we gather so many people so early in the morning on a Sunday. And to start our session today on obstetrics and pediatric anesthesia, our first speaker would be Dr. Liaqat Ali from Lahore. He would be telling us about controversies in pediatric pain management, bridging theory to practice.
Assalamu alaikum. Good morning. Thank you very much, madam, and special thanks to Dr. Azhar and Dr. Asma for giving me opportunity to talk about this topic. I will present a review of literature and then I share our department's way forward, what we adopted from in this area. So I have no conflict of interest. In my talk, I will talk about controversies in pediatric pain management regarding drugs and different regional anesthesia approaches and concerns. Then we will talk about barriers for gap between theory and the practice. And lastly, we will talk about strategies to bridge theory to practice. Why we are so much concerned about pain in the kids? As a father, you all can, most of the parents can understand. The pain in the care, if a child have a pain, it is more distressing as compared to adults, because this is most of the time they can't share their feelings, and that is very distressing for the family. So if pain is not adequately managed, and that can lead to the serious consequences, among those are the conversion of acute pain into chronic pain, behavioral issues, immediate behavioral and long-term behavioral issues. Then there's a delayed recovery and increased hospital stay, and then increased stress and anxiety disorders, which can lead to the long-term problems. In adults, regional anesthesia is a very essential component. What about looking at the pediatrics evidence, how it is being helpful, because it is a lag significantly in pediatric population as compared to adults. So this is all literatures from the pediatric review of literatures. It leads to enhanced recovery, shorter hospital stay, and early mobilizations. It provides prolonged analgesia, so lesser rescue analgesia and other analgesic requirements, leading to the lesser postoperative problems, particularly opioids related. It has reduced stress response, better metabolic, and immunological outcome. Regarding the controversies, while we were making our department protocol regarding the pediatric pain management, I found a lot of these issues which are very concerning, particularly regarding the drugs. Paracetamol, less than 3 months, we should decrease the dose to the 50%, or in neonates. Then there's the guidelines regarding at less than 10 kg, you should reduce paracetamol 50%. But Association of Pediatric Anesthesia of Great Britain, Ireland, they recommend less than 5 kg, then you have to reduce dose to the 50%. And then again, issues of the frequency. The majority of the data showing that 6-hour paracetamol is not adequately building levels in blood in pediatric population, particularly in infants less than 6 months. They advised around 4 to 6 hours per day doses. And then in prematures, there is the concerns about the problems, and then certain recommendations are around 6 hourly, and then certain recommendations are around 12 hourly. So this is the area around in neonates and prematures, paracetamol can be a tricky, and we have to be very clear what we are doing. Regarding ibuprofen suppositories have been associated with a lot of erosive case reports. So normally, there are a lot of talk about that, लेकिन कुछ लोग comment कर रहे हैं, कुछ लोग कह रहे हैं कि इसको avoid किया जाए. Regarding ibuprofen intravenous, recommendations mainly it should be used more than 1 year of age, but some literature saying more than 6 months, it can be used something about more than 6 months, more than 3 months. So less than 3 months, ibuprofen IV should be most generally avoided. Regarding the ketorolac, it is not FDA approved less than 17 years of age. Frequency in adults, usually it is recommended around 8 hourly, but in children populations, some literature says 6 hourly, some says 8 hourly. And regarding the age, again, concerns in less than 3 months, there are a lot of literature showing increased incidence of bleeding, GI bleeding in these patients. And above 3 months, reasonably safety, but in between 3 months and 6 months, there is some controversy whether we should use it or avoid it. Regarding regional anesthesia, particularly in infants, there is some serious concerns about failures. It might be because of lack of training or inadequate experience, but generally, failure is a major concern in spinal anesthesia when we talk about infants particularly. Higher loss in neonates with particularly epidural and peripheral nerve blocks. Again, a lot of case reports, but again, mainly was calculation of drugs were the problems. Thoracic versus caudal epidural catheterization, again a controversy कि जी कैथेटर ऊपर जाएगा कि नहीं जाएगा, कुछ केस रिकमेंडेशन है कि आप caudally डाल सकते हैं इन्फेंट्स में, और कुछ में आके सर लिमिटेशन है कि thoracic तक नहीं जा सकते doses. Then again, local anesthetic doses in 50% in neonates are in less than 3 months. Majority of the literature shows that local anesthetic doses should be decreased to the 50% in neonates, but a lot of literature saying as well that in less than 3 months, local anesthetic dose should be decreased to the 50%. So let's see what you know, what you think. Is there a gap between theory, practice, to the myth or reality? आपका क्या ख्याल है? को हाथ खड़ा करके बताएंगे. कितने लोग ये सोचते हैं कि इस वक्त जो प्रैक्टिस हो रही है पीरियाडिक एनेस्थीसिया कि उसमें there is a serious gap between the theory and the practice? One hand, huge gap. Okay. Is it a local or universal issue? Majority saying local. It is a universal issue, very serious universal issue. मैंने अपना ऑडिट किया तो मुझे बड़ी शर्मिंदगी हुई, लेकिन फिर मैंने कुछ और ऑडिट्स देखे तो मुझे तसल्ली हुई कि मैं अपना ऑडिट प्रेजेंट कर सकता हूँ. देन आई विल प्रेजेंट इन माय टॉक. करंट स्टेटस क्या है यूटिलाइजेशंस का? वर्ल्ड हेल्थ ऑर्गेनाइजेशन स्टैंडर्डाइज गाइडलाइंस फॉर हाई क्वालिटी पेन कंट्रोल इन चिल्ड्रन. पेन रिलीफ इज़ अ बेसिक ह्यूमन राइट. और जब बेसिक ह्यूमन राइट की बात हो और बच्चों के बेसिक ह्यूमन राइट्स अफेक्ट हों ज़्यादा एज कम्पेयर टू एडल्ट्स, तो दिस इज़ अ सीरियस प्रॉब्लम. And acute pain management, this is happening. Kids are not being looked after the way seriously we look after adults regarding pain management. Infants and younger children receive inadequate pain control versus older patients. It is all evidence-based. Practice gap persists despite significant development in the guidelines. Up to 80% of the children report pain perioperative period pain. 2/3 of these kids complain moderate to severe pain. Despite proven safety, regional anesthesia use is significantly lower than in adult population. This is a review of 21 papers focusing on mainly barriers and facilitators in acute pain management. And among the barriers, they found that it is mainly the deficit in the provider knowledge, training, organizational and structural issues, and then communication gap between different specialties and interprofessionals. Among the facilitators, professional initiatives by healthcare members, structural and organizational enhancement, then family engagement, and then targeting educational and training interventions. Another review, actually a survey, which was done in 21 different professional specialties, emergency physicians, anesthetists, pediatric surgeons, nurses. What they found, two things most importantly. One thing is that there is a serious deficiency of leadership that is leading to the inadequate pain management. Second is when there is not a consensus that lead to the incomplete coherence with the guidelines. These two things are the main component. If there is a person who is leading from the front in a department, in institutions, then situation is totally different. And then when consensus is made, engaging the all partners like nurses हैं, आपकी pediatric surgical team है, या different surgical units हैं, pediatrics, and then anesthesia, and among the anesthesia also consultants and residents as well. In Aachen, they did a wonderful survey in 2024 in KPK and Sindh, and they found that 66 of the respondents use pediatric pain scales in post-operative care units. Only 72% had no guidelines in their respective departments. 5% had access to the 5 different analgesics available for the perioperative pain management in the children, and around 32% had only access to 2 analgesics. In our department, we did a retrospective evaluation of perioperative analgesia prescription intraoperatively, in PACU, postoperatively, and at the discharge. So intraoperatively, opioids used in 35% of the patients only among 200, and only 54% dose was adequate. That was minimum 0.05 milligram per kg. Nalbuphine was mainly used. Then paracetamol, in 95% of the patients was being used, and dose was inadequate 78% time. Only 22% time dose was adequate as per kg recommended doses. No answer was used, no ketamine was not being documented, and our department members claim that they used to give a lot of local infiltrations or some blocks, but there was no documentation in the paper, so we made it a negative. No analgesia documented in the PACU as well. In post-operative wards, paracetamol was used in 65% and only 10% of patients has adequate prescription according to the dose and frequency per kg. Again, NSAIDs was used in 42%, 40% adequacy of the dose, and 60% was dose inadequate or frequency was not adequate. In discharge, only 33% received paracetamol and 68% received NSAIDs, and there are serious issues regarding prescription of the dose and the frequency.
5 minutes.
Yes, sure,
You've
sure.
got 5 minutes.
I will do that. Regarding the literature review, analysis of more than 100,000 blocks have shown no permanent neurological deficit in the children. Spinal registry in confirmed infants, more than 1,500 patients, there was no significant issues, serious issues regarding the spinal anesthesia. Complication rates are comparable to the adults. Integrated regional anesthesia into the practice ERAS program, because adults may have, pediatrics may usually nahi hai. Training for non-pharmacological techniques and then society-led training attachments and courses can lead to the significant improvement in the regional anesthesia and acute pain management in the children's. Participate in a registry like pediatric regional anesthesia for benchmarking and quality improvement. Collaborate and communicate with the family. These are the different organizational strategies which we adopted in our department, other than invest in the pediatric population in a public hospital, and then we don't have a designated block. The other things we are using to make more appropriate usage of regional anesthesia and acute pain management in the children. This is the guideline, this is the paper which mainly I was focused on when we were developing our department's protocol. This is the European Society of Pediatric Anesthesia Pain Ladder Pattern Initiative, and they focus only 3 areas: basics. These are two different type of surgeries. They targeted basic, intermediate, and advanced levels. Analgesia, basic is it meant for every institution, whatever the resources are. Then depending upon your resources and better equipment and better human resource, you can go to the advanced levels. This is a fantastic paper. It is not a guideline, but actually it shows you patient-related, age-related dosage of different drugs and local anesthetics and surgery-related analgesia, minimum level and advanced level. That's a case example we implemented in our department. Before we reviewed into this issue, caudal block rarely offered, local infiltration was occasionally done, and no formal communication with the surgical team. Then we engaged the pediatric surgical department. We started one research paper ordered from our department, one from their department, significantly changing their behavior and significant increase in block. Intraoperatively, we are giving now TAP, femoral nerve block, popliteal, electrospinal, hypogastric, pudendal, and dorsal penile nerve blocks. We are also giving blocks to the infants as well. I think for yes. This is our protocol for intraoperative analgesia, then PACU analgesia, ward analgesia, and discharge analgesia. This is a consensus document which we made with the pediatric surgery department, including our consultants and our senior residents. So there's a consensus with all the, okay. And these are the precautions I will share with you. And these are our departmental paper regarding the use of regional anesthesia in pediatric populations, local anesthetics, volume, and dose required in different blocks. Central axillary blocks, facial block, peripheral nerve blocks, spinal anesthesia, maximum local anesthetic requirement, and then precautions. Avoid Zolpidem less than 3 months. Local anesthetic dose should be decreased less than 3 months of age. And this is the international exposure regarding regional anesthesia in pediatric populations. These are 33 experts representing 12 pediatric regional anesthesia societies across the 6 continents. And this is one of the areas where I look into to develop my regional anesthesia practice. These are my references. Thank you very much. Questions?
2 questions. If anybody wants to ask any question. Dr. Fauzia.
It's not really a question. It's a compliment that you've done it in your own department after doing an audit and standardizing the pain relief for children. What I would suggest
Thank you very much.
that you publish it in one of the local journals, because it will be helpful to many other departments as well.
Madam, we did our first phase, and now I joined Services Hospital last year. This is our initial part, and then is the second phase. Then we will do after interventions. Then we will share, inshallah.
No, I was just talking about the protocol.
Sure, sure. Yeah, that's okay. Okay.
And a little summary. How did you reach this protocol?
Okay. That's fine. That's fine.
That will be
I will definitely, and I will share your platform as well. Dr. Shamim, the question.
Fear of parents has been a big barrier. कि पेरेंट्स की बहुत डरते हैं कि यार टीका लगाना है कॉटल स्पाइन में नहीं तो पेरेंट्स की काउंसलिंग भी ज़रूरी है बड़ी सरनी साथ उनका जितना ज़्यादा लगाएंगे उतने उनकी ज़्यादा होगी.
Absolutely agree with you, and in that context, I think using a surgeon as your support for convincing the family is a very essential component. I remember that we used to ask Dr. Mahmood Shaukat. Actually, he used to convince already family that the caudal will be there. And again, now at present, instead of caudal, we can go for pudendal nerve block, very safe and very easy, ultrasound guided in kids. Lesser time required as compared to caudal. I think that's another way we'll look into. Another question? I think there was one question more.
Sir, you said that you are performing all the blocks regional except caudal analgesia. So why have you excluded this block, although it is most common in the world?
No. We are using caudal anesthesia. No.
Except?
No. I think there might be some error in presentation, but actually we are using caudal. What I mentioned that it was offered occasionally in our department, and with interventions in our environment and with the pediatric surgery, we have increased significantly numbers of the blocks, blind as well as ultrasound guided. And in infants, the only block we used to offer caudal epidural. But in infants, now we also give ultrasound guided blocks. And last we did 2 months baby ilioinguinal because family was not convinced with the caudal. So we gave ultrasound guided ilioinguinal. And we are using 5cc syringe in the kids mainly. 5cc syringe, that's enough, that's it. In plain blocks.
Thank you, Liaqat. Thank you very much.
I think एक question है.
Dr. Naila has
वो सबसे पहले उन्हें हेड किया था. फैसल आपसे बात कर लेता हूँ मैं अभी.
ये चौथा क्वेश्चन है, वैसे चीटिंग हो रही है.
2 कमेंट्स थे मैडम.
Thanks, Dr. Liaqat, for presenting your audit. So I just wanted to know using for peripheral nerve blocks.
If we target plexus, if we talk about plexus, then again 50 mm Bipron needle. But yet now, I think I have given only very few blocks, 4 or 5 blocks maximum. Regarding facial plain blocks or individual nerve blocks, simple 5cc syringe is enough. As we use cutting needles for individual nerve blocks, and for plexus, short, blunt needles.
Sir, just a small question. The audit you did in your perioperative analgesia, did you select the surgical type of surgery or a certain age group?
What we were focused in our survey that adequacy of prescription of analgesic drugs.
It was all a
yes.
large...
Retrospective file review की हमने और हमने देखा कि जो drugs हम दे रहे हैं intraoperatively, पाकू में, ward में, discharge पे, वो ड्रग्स की प्रिस्क्रिप्शन की जो वो कैसी है हमारी कि फ्रीक्वेंसी ठीक है, डोज ठीक है पर केजी के लिहाज से और क्या क्या यूज हो रहा है. That's it.
Paracetamol, that was the only paracetamol was given.
Yes,
no other drug
yes.
was given. But you didn't have a type of surgery or certain age group.
देखिए again, we did not look into the pain. We only look into the prescription, adequacy of the prescription. कि जो हम प्रिस्क्राइब कर रहे हैं ड्रग वो एडिक्वेटली दे रहे हैं कि नहीं दे रहे हैं और क्या क्या प्रिस्क्राइब कर रहे हैं.
डोंट यू थिंक एज ग्रुप को डिफाइन नहीं हमें करना चाहिए, क्योंकि इट्स अ पेन तो परसेप्शन है ना, with a certain age group different diagnosis.
We were looking at, not looking at the pain. We did not assess the pain. We only assess the adequacy of prescription. Prescription of the drugs. क्या prescribe कर रहे हैं और जो prescribe कर रहे हैं वो ठीक है या नहीं. That's it.
Thank you, Dr. Liaquat. Our next speaker is Dr. Faraz Shafiq from Aga Khan University Hospital. We'll be talking about fluid therapy in pediatric anesthesia, rethinking our current practices. Dr. Faraz Shafiq.
Assalamu alaikum everyone. Thanks for the invitation and thanks Dr. Akhtar for the introduction. So the topic of my presentation today is mechanical ventilation in patients having pregnancy along with the respiratory. They have got respiratory failure.
Faraz, sorry, it was my mistake. I read the line below.
Sorry, say again.
It was my mistake. I read the line below.
That's fine, that's fine. So the topic of my presentation is mechanical ventilation in pregnant patients having respiratory failure. So before the start of my presentation, I just want to ask from the audience, how many of us have ventilated pregnant patients? Can you please raise your hands? How many of us have ventilated pregnant patients? Yes, so I think we usually do in our daily clinical practice as a part of cesarean section and at times, post-operatively for a shorter period of time. How many of us have ventilated pregnant patients having respiratory failure in the ICU? Can you please raise your hands? Okay. So if I'll recall, my medical career, so I think I've ventilated only one patient in the ICU as a part of my residency and nothing beyond. And that might be the conflict of interest of my presentation. So what is well established about the topic? So we all know the pregnancy causes some sort of physiological changes, especially we are concerned about the respiratory changes in the mothers. Though the ventilatory strategies are pretty same as compared to the other population, but there are certain differences which we need to explore as a part of this presentation. And at times, early delivery might be indicated if we want to improve the ventilation. Fetal monitoring is definitely required. And we'll see the presentation, as we see in the hall also, it's very rare. So the area of uncertainty, which we want to explore through this presentation, we'll see the impact of physiology on the mechanical ventilation in the pregnancy. We'll try to identify best mode of ventilation, role of non-invasive ventilation, is prone positioning is valid for these patients, and optimal sedation and paralysis. So that is the, that would be the, the learning objectives of my presentation. So the available literature on the topic, if you'll go and find, you'll start searching the literature, which I did also. It's mainly on the basis of certain case reports and the case series. And if you'll go, the incidence of having respiratory failure in the pregnancy is only 0.1 to 0.2%, and less than 2% of these cases landed up in the ICU for the need of mechanical ventilation. Morbidity in the earlier study was like 9%, but so like up to 39%, and in the recent study it's reported somewhere between 9 to 14%. Getting nowadays more common. Why it's more common? Because of the recent outbreaks related to COVID, SARS and H1N1 related infections. So we are getting a lot of patients. If you'll see and go to the literature, it's full of the case report and the case series related to the COVID-19. So the common reason behind are infectious causes, non-infectious causes, asthma, COPD, but they are mainly related to the infectious causes. And amongst the infectious causes, COVID-19 is at the topmost. And the incidence is very low, like 0.1 to 0.2%. The risk factors for having severe respiratory failure in the pregnancy itself, obesity, age, hypertension, and the diabetes and the preeclampsia. So we all know there are certain physiological changes related to the pregnancy and which are known to the pregnant female. It's a state of compensatory respiratory alkalosis. They have got their low FRC, which ends up in having increased oxygen consumption, early tendency to desaturate, and they have got airway edema, which causes the intubation a bit more difficult. Diving deep into the literature, if you do the deep literature search, I was lucky enough to have 3 articles, 1 narrative review and 3 editorials in the recent publication of the British Journal of Anesthesia. So one can go through the the recent edition. So I came across these very relevant thing to our topic, and you'll be really lucky to have these things as a take-home message. So diving deep into the literature tells us there are certain sex specific consideration. What are these considerations? Female patients have got smaller lungs and they have got low compliance. Besides, they have got increased chest wall elastance, especially which works as a part of having gravid uterus there. Besides, very importantly, they have got certain hormonal changes which leads in alteration in the vascular tone, their response to the inflammatory stimulus as a part of respiratory infections, and they have got altered pharmacokinetics and the dynamics. Besides, very importantly, mechanical power. By definition, the power is energy given to a respiratory muscle. They require much less as compared to the normal female population and as compared to the like male gender. So they are at the higher risk, and the risk increases with the with the presence of pregnancy. So they are having the greater risk of ventilator-induced lung injury. The mortality is like they are at the high risk of mortality. So mortality in these patients increased by around 52%. Besides, they are more sensitive to neuromuscular blocking drugs, and they are more sensitive to opioids. So the requirement of both of these drugs, would be lesser. And we need to consider the effects on the fetal circulation, which we'll discuss in our upcoming slide. So there was a famous study that it was conducted in 2019, lung safe study. So it concludes that higher mortality in the pregnant females due to related to the the tidal volume related to the higher tidal volume during mechanical ventilation. So the lung safe study. So the editorial which I was talking about, so this says the female are at the higher risk of having mechanical ventilation, and they concluded their editorial by saying 3 things, and the 3 things are related to the triple burden of sex disparities in mechanical ventilation. The first one, the available formulas which are available, like the predicted, the basis of which is predicted body weight, they actually overestimates the lung volume in the females. Besides, females are underrepresented in critical care research, and hence in most of available databases. So the analysis is also not performing on the basis of sex related disparities. So these were the 3 main reasons which also increases the risk of mechanical ventilation in females. The last editorial, so it's about the lung protective ventilation in females. So the lung protective ventilation is also not a sex neutral. So what they say is the female are at the higher risk because will not provide them with adequate lung protective ventilation, and there are certain differences, so which we have discussed. So differences are not only in the respiratory system but also in the extrapulmonary biology. So it's very important to look at those factors also. So the ventilatory management, so the basics are basics. It starts with adequate history, physical examination, and the laboratory evaluation. We need to consider about the gestational age, status of the fetus, and more importantly, right from the start, the multidisciplinary team involvement needs to be there. So we know and the best mode of the ventilation, the mode which you are familiar with. So in my opinion, the best mode of the ventilation is one you are familiar, one which you are using for your most of your patients. So the effect in terms of hypoxia and hypercarbia are there on the fetal circulation. So anything less than 60 millimeter of mercury of PO2 or PCO2 of more than 45 has got adverse effect on the fetal circulation. So the role of non-invasive ventilation, it increasing nowadays. It's getting more common. Just having sort of infections which we have discussed, COVID and H1N1, can be used if you want to prevent the intubation and the intubation related side effects. But it's very important that, so whenever you are thinking to start the non-invasive stuff to your patient, the insult needs to be temporary and the reversible. Besides, what we have seen in the literature, high flow oxygen has been used successfully for COVID-19 patients. And remember that with the non-invasive stuff, the risk of aspiration would always remains there. So this was a famous study, COVID-PREG study, published in 2022. So they have shown that their data shows the successful use of high flow nasal oxygen and the non-invasive ventilation for their COVID-19 patient. And this was a study which was published in Chest 2023. Similarly, they have shown with their results that the successful use of both of these, non-invasive and the high flow nasal oxygenation, amongst the survivor women which comes to the ICU with COVID-19, and they were pregnant. So the current standing in the literature, it provides better oxygenation and it's an effective rescue measure if you want to gain some time And in my opinion, it should be used, the high flow nasal oxygenation should be used for intubating any patient if you are anticipating difficulty. So that makes sense of using that thing. So for intubating these patients, just anticipate difficulty, considerate about the size of the tube, and don't delay the intubation. We don't want to intubate the tiring patient having pregnancy, difficulty airway edema. So we don't want to intubate them in a rush. So better to intubate them, early. And use of video laryngoscope over here in this scenario is logical. So the mechanical ventilation, so the goals of oxygenation, PO2 of more than 70 or saturation of 95, and for ventilation, the target goal of CO2 is around 35 to 45, but literature has shown that the level up to 45 to 50 has been tolerated well both by the mother and the fetus. So avoid permissive hypercapnia. If it's really required, then you have to be logical in terms of thinking the higher level, which we have discussed. Low tidal volume, plateau pressure needs to be monitored, and remember to maintain left lateral tilt and avoid aortocaval compression. Consider the effect of your ventilation on the fetus. So both hypercapnia and the hypocapnia are deleterious. So with the permissive hypercapnia, it has got effect of the fetal circulation in terms of hypercarbia and the acidosis, and ultimately it causes interference in the delivery of oxygen to the fetus. Besides, hyperventilation causes alkalosis and the vasoconstriction and ends up in having fetal compromise in terms of the circulation. The PEEP is generally considered to be controversial for the pregnant patient because it has been associated with, I'm talking about the high PEEP. It has been associated with significant hemodynamic changes, especially in the late trimester. Prone positioning, though our experience is quite limited, technically feasible. A lot of literature is there in terms of managing these patients with the prone positioning. It's been tolerated well by the patient, even in the last trimester of the pregnancy. But specific attention needs to be given in terms of offloading gravid uterus and preventing aortocaval compression. So that two things needs to be done. And we have discussed the pharmacological effect, 30% less requirement of opioids and the muscle relaxant. So besides those effects, the effects are also there on the fetal circulation. And the fetal and the neonatal paralysis and the weakness has been reported for those patients who've been on, for the sedation and the paralysis for a longer period of time. However, if the purpose is to improve the ventilation and oxygenation of the patient, we have to use it, considering, taking care of those pharmacological changes. Besides, the overall recommendation is of, limiting its use like any other patient population. So delivery is very important. Just make sure whenever you got these patients in the ICU, make a plan. And the basis of that plan is on the basis of multidisciplinary approach. So facilities of delivery needs to be there or needs to be arranged in the ICU. Early delivery might be helpful in terms of, for say, if you are getting worse with your ventilation and the oxygenation, and decision should be individualized, has to be shared, especially if we are talking about the delivery before 32 weeks of pregnancy. Fetal monitoring, it's a part and parcel. Why fetal monitoring? Because maternal condition is often reflected by the status of the fetus. So fetal monitoring needs to be instituted as soon as your patient landed up in the ICU, and we need to consider the effect of radiology on the fetus, for which the options like abdominal shields are there. So this is just a diagram. So that was a review article in which they have discussed the prone positioning and the related stuff as a part of managing these patients for COVID-19. So this is my take-home message. It's a 10-point summary. So starting from the point 1, the incidence is very rare. So we have to be really thoughtful about that. We might never come across these patients, but yes, the incidence is increasing as a part of outbreaks. Besides, the predicted body weight formulas which are there, so they are not actually covering, they are actually not considering the, the actual physiology of the females. So we have to be considerate about the sex-specific variations. Target of the ventilation, PO2 more than 70, PCO2 between 30 to 35. The option of non-invasive ventilation is there for a pathology which is temporary and the reversible. Besides, early intubation is required if you are seeing your patient is getting deteriorated. So early intubation with the use of video laryngoscope, that makes sense. Prone positioning is feasible, especially in the last trimester, but yes, you have to see the effect on the gravid uterus, and you have to prevent aortocaval compression. Sedation and paralysis, you have to adjust your doses. Early delivery might be possible, but for that you have to take multidisciplinary approach, and that is all about my presentation today. Thank you. Thanks.
Excellent, Faraz. You finished a minute earlier. Any questions? We can entertain two. Dr. Khalid Shah, please introduce yourself.
Dr. Khalid Shah.
आप कर लें, Dr. Khalid
कमेंट ये
Bashir.
कह रहा हूँ कि ये प्रेगनेंसी की बात है तो ये सेक्स का बीच में आ गई, सेक्स स्पेसिफिक में.
So all the things would increase. So we need to consider.
नहीं, मैं मेल कहाँ से बीच में आ गए?
Sorry?
मेल का मेंशन कहाँ से बीच में आ गया? मेल्स का सेक्स डिफरेंस.
So so we need to look at those changes which are being aggravated as a part of pregnancy and being a female sex. So that is very important to look at.
मेल का लिखा है ना, मेल का लिखा है.
नहीं, फीमेल है. मेल कहाँ लिखे हैं हमने? लिखे हुए? नहीं, it's about the females.
Khalid Shah. Faraz, thank you so very much for such an entertaining and such informative presentation. Really thorough, very nice. Thank you so much. Can I just ask a simple two-part question? In your experience, did you come across the incidence of ECMO in these pregnant, difficult to ventilate, difficult to manage patients? And is there any possibility of ECMO in Pakistan at present? Thank you.
So ECMO is a logical option for these patients. I am not aware about the facilities of ECMO in the Pakistan, because what I want to deliver the message on this forum, that everybody sitting here should manage these patients. So my presentation is specifically not covering. So I intentionally didn't cover the aspects related to ECMO. It's beyond the scope of this topic.
The mortality rate that you have suggested is about 50%. Is that your finding as well? Is your experience as well?
So to be honest, I've never managed these patients, and that's I declare as a part of my conflict of interest. And we don't have data either at our institute.
Thank you very much. Just to answer, in these patients, VV ECMO is the recommended because of the lung problem. We are not using the obstetrics, but we are using V and the VA ECMO in NICVT.
Thank you, Dr. Amin, for your comments.
Thank you, Faraz. Thank you for
everyone.
an excellent presentation. I would next invite Dr. Arsalan Jamil from DUHS, who would be telling us about fluid therapy in pediatric anesthesia, rethinking our current practices.
Assalamu alaikum everyone. I am Dr. Muhammad Arslan Jamil from Dow University of Health Sciences, and the topic of my today's presentation is fluid therapy in pediatric anesthesia, rethinking our current practices. So we will start with the name of Allah, Bismillahir Rahmanir Rahim. And the fluid therapy in the pediatric anesthesia has undergone a major shift over the last 2 decades, because the traditional concepts were that we were used to use prolonged fasting periods, hypertonic maintenance fluids, and the liberal deficit replacements by the Holiday-Segar formula. That is, we all know the 4-2-1 formula. But now these days, these practices are increasingly being replaced by the physiology-based, goal-directed, and a more of a balanced fluid strategies rather than the hypertonic ones. And the modern practices now emphasizes that one should be keeping euvolemia while avoiding both the hypo and the hypervolemia or the fluid overload. So what were the key aspects of the traditional models that we were using initially? And that was we were using hypotonic fluid, and the patient were being asked to get NPO from after the midnight, and the deficit replacements were done in a more liberal manner with the more liberal fluid therapy strategies. So in my eyes, that PSA has given me a really good talk today, that this is really the time to rethink. And the time to rethink is because that why pediatric fluid therapy is different, because children are not the small adults. Many people think that half the volume of the adult will do the job, 4:2:1 might guide you well in the initial hours, but if the surgery is prolonged, then the things are different. So we must go through the pediatric physiology, and that is pediatric patients have high total body water and a high metabolic rate, and their kidneys are immature, so that they do not have the more good concentrating abilities, and they have a high ADH response. So why we should rethink our fluid practices? Because the old strategies are leading to hyponatremia, and which may lead to cerebral edema, encephalopathy, fluid overload complications, and the outdated formulas are still being used. They may be used as a guide, but not in the routine, and now is the time to shift to the physiology-based care. So it all started when people were using hypotonic fluids, and the isotonic fluids were the new were being started to be a new norm. So it was a meta-analysis in 2014 that compared the isotonic versus the hypotonic maintenance IV fluids in the hospitalized children, and a meta-analysis was done that was in which 10 RCTs were included, and all the population of the study was the hospitalized children, and isotonic versus hypotonic fluids were compared. So the primary outcome of this meta-analysis was to see that the fluid therapy is developing hyponatremia or not. So the key conclusion of this meta-analysis were that when isotonic fluid were being used, they were safer in the hospitalized children. They reduced the hospital-acquired hyponatremia and the chances of severe hyponatremia. And when the isotonic fluids were being used, they do not significantly increase the chances of hypernatremia. So what was the clinical impact at a decade back of this meta-analysis? That it helped change the pediatric practice worldwide. And later on, this was the meta-analysis that was the base of the guideline and the recommendation formed in the 2018 by the American Academy of Pediatrics, that isotonic fluids should be the choice of IV maintenance fluid in the hospitalized children. Then as we came forward, and a decade later, I found another beautiful meta-analysis, and this time it was from the efficacy and the safety of the isotonic versus hypotonic intravenous maintenance solution in the hospitalized children. And it was again a meta-analysis, and it was published in June 2023, and it involves 33 randomized controlled trial, and it included 5,049 hospitalized children, and the conclusion was again that isotonic fluids are superior. Initially we were finding, are they better than hypotonic? But now this meta-analysis is proving us that they are superior to the hypotonic fluids for preventing the hospital-acquired hyponatremia in children, and should be considered the preferred maintenance therapy in most pediatric inpatients. However, electrolyte and the acid-based monitoring remains an important, and especially in the neonates and the critically ill ones. So what was the clinical significance that this meta-analysis brought to us was that it supports the use of maintenance fluid, that we should be using isotonic as a maintenance fluid. Again, it was consistent with the American Academy of Pediatrics recommendations that were formed in 2018, and balanced isotonic solutions are now being used as safer than normal saline as well. So the bottom line that this meta-analysis brought to us was that again isotonic fluids are the fluid of choice and safer than the saline. Then again a study, a meta-analysis that is more of a recent time, that is balanced crystalloid versus saline for resuscitation in pediatric septic shock. This was from the critical care, but it really helped us guide in the fluid therapy, and it was published on 31st January 2025 in the BMC Pediatrics, and it includes 8 studies and 12,231 pediatric patients, and it includes RCTs and observational studies as well. So the main finding were the balanced crystalloid solution reduced hyperchloremic metabolic acidosis, and possible renal complications when the fluid is given to the children, and no signal of harm versus saline was observed. And the author concluded that balanced fluids may provide physiological advantage over normal saline in children. And the practical takeaway that this meta-analysis brought to us was that better acid-base physiology was being observed, and less hyperchloremia was there, and renal protection was there with the isotonic solutions when used in the pediatric population. So the modern day shift is hypotonic to isotonic fluid, and that prevents hypernatremia, and isotonic is now the new standard. So there was a Korean journal that formed the pediatric perioperative fluid management, and it is this study is now being used as one of the major studies that for the fluid therapy in most of the patients undergoing pediatric fluid therapy in perioperative period. So this study tells us that glucose strategy in the fluids, that initially we were using the high dextrose solutions, and one should not be using dextrose till the time it is not being required. And if one want to use it, use 1 to 2% glucose, especially in the neonate and the infant population, and the reason is to avoid hyperglycemia and the complications associated with hyperglycemia. And this study shows the fasting guidelines that are being now part of many algorithm and protocols of different hospitals globally, that clear fluids up to 1 hour can be given to the patients. And if we are not being confident enough to anesthetize, we can go to the gastric focus, and the fundal gastric focus can be done, but the fluid therapy should be continued of the cleared fluid 1 hour before surgery. And this leads to less dehydration and a better patient stability. Replacement deficit, avoid overestimations. Initially there was a thing that, and nowadays this is also being used, that minor surgery scar incision, moderate surgery scar incision, and a major surgery scar incision, then 2 to 4, 4 to 6, and 6 to 8 mL per kg were being used. But these days, avoid overestimation and replace the actual losses only. That is the main goal. So the maintenance, that is the Holiday-Sagar formula, 4:2:1, should be used only as a guide, and not in the entire long procedures. And use of isotonic fluid should be promoted, and individualized therapy for every patient should be selected. And whenever the condition arises for the fluid boluses, means there is a time of resuscitation, 10 to 20 mL per kg of isotonic solution can be used to improve the perfusion. As far as the colloids are concerned, there is a limited role of colloids these days, and they can be used in instability when there is a dire need, and this should not be a routine practice. And the therapy should be goal directed using the clinical signs, the perfusion markers, and the lactate monitoring. And we have to avoid overload, because it may lead to pulmonary edema, delayed recovery. So that's why the study promotes the use of minimal required fluids. And the local practices still that are being observed these days in some setups are hypertonic fluid are still being used, and now is the time to rethink, and we need a practice change. So the management algorithm is the clear fluids continue till 1 hour, intraoperatively isotonic fluids, and when the time of resuscitation arrives, 10 to 20 ml per kg should be the answer to these risky questions. So what are the key takeaways? That one should avoid hypotonic fluid. Number 2 is that we use balanced crystalloids, and third is stop deficit replacements, and only do the actual losses replacements, and individualized care should be given to every patient. So this is a comparison that I found out that between the traditional approach and a modern day approach, and it is almost telling all the things that we have currently discussed in the today's talk. So the current practice prefer the isotonic balanced crystalloid solutions should be used. The common choices are plasma light lactated ringers and the balanced crystalloid solution like sterophundin, and these reduces the hyponatremia, hyperchloremic metabolic acidosis, and the chloride load. So these were the references that I took to make today's talk possible. And the closing remarks is that fluid therapy should be physiology and the patient specific and the patient specific, physiology driven and the patient specific. So that was all from my side today, and I would like to again thank PSA to give me this platform to have a talk with so many elegant and elite anesthetists of my country. Thanks a lot. Thank you.
Thank you, Arsalan. We can take questions from the audience. Abbas. We need the mic.
Assalamu alaikum. My name is Abbas from SIUT. You said this fluid therapy 4-to-1 formula has been changed or replaced. So it is replaced with what? And how much fluid should be given?
It is replaced with more of a kind of the POCUS these days being used for seeing the IVC or any other thing. What you do normally is they allow the patients to being observed in the pre-op area, and then intraoperatively they use ultrasound and an abdomen in a sterile way, and they keep continuing. So initially they use these things, and then other than that they allow the patients to have a control heart rate in a controlled manner. But what they observed was initially the meta-analysis that were involved in finding out that isotonics are the best ones, and 4:2:1 is overestimating. They do a electrolyte test every now and then after the procedures. So the 4:2:1 formula, when it is used, most of the times it lead to mild hyponatremia, and sometimes it was leading to the severe hyponatremia that was totally due to the overload or the hypervolumic strategy or the liberal strategy that were being used. So when the studies were done on isotonic solutions not using Holiday-Segar formula and IVC POCUS or something like that, or a more dynamic strategy, goal directed, and other strategies, so patients were not having those problems. So that proves that 4:2:1 really overestimates the fluid in long cases or in patients who really are short and very low weight. So it is much safer to go as an individualized approach and not calculating 4:2:1 and giving it blindly to all the patients.
It doesn't seem to be very the focus on
there are multiple
getting the, say for example, you get a
it is one of the things that it is one of the things that we can do. There are other methods of doing things as well, that clinical signs, the hypotension, the tachycardia, the things other than that, the well hydrated status that demands that is the thing. Other than that, yes.
Can I ask a brief question? Thank you so much, Dr. Aslan. Very nice presentation. It's a very controversial topic, so you will have a lot of resistance, unfortunately, convincing people.
Sure.
Just a quick one regarding the SIP to till SEND,
Yes.
which are
Yes.
you practicing in your institute, and what facilities have you provided for the children to be?
It is SIP still SEND are being allowed, but for only the clear water and the liquids. But in our setup, we are allowing till the last hour, but not SIP still SEND is being there for the adults as well. But because sometimes the lower volumes can also cause problems, so in pediatrics, last hour should be used, and in adults, SIP still SEND can be easily used because
so
lower
my question
volumes
was
can.
quite specific. What facilities have you provided in your center, because you are now the main person leading on this?
We are currently using the old school practices as well, but the fluid has been changed to the isotonic ones, and they are not causing any trouble, and they are better than the saline. These things are being observed, but other than that, no any other intervention we are doing, but the hypotonic ones are being replaced by the isotonic ones in our setups.
Thank you.
Sobia, I think, has a question.
Thank you, Dr. Aslan, for your talk. I just wanted to ask that so far, as of now, all of us are using ASA practice guidelines for NPO. And still, before I heard your presentation, I am using the same 6 hours and 4 hours and 2 hours for the clear liquids. I am asking, am I supposed to, or are we supposed to take this message to our homes that now we are supposed to, decrease the fasting time period to 1 hour for clear liquids on the basis of one meta-analysis, given the fact that most of us do not have focus in our setups. Maybe I have at AQ, but not all hospitals have. So what is your standpoint on this?
As far as things are concerned, that people who are using focus in their setup, as my talk is really that, is it the time to rethink? So I think it is the time to rethink, and whatever setup has a focus, they should do their researches, publish the local papers, and then we can form a guideline. But now I think there really is a time that we should be reducing the fasting times, because not every patient, but many a patient cannot withstand with such long fastings, and it really has a direct impact on the initial hemodynamics that we get immediately after induction of the patients. So I think less than 1 hour clear liquid can be a thing that we may get a better induction vitals and a good thing, but local practices that are being if we modify the local practices and then further studies are there, then we can have a perfect plan for our setups.
Dr. Zahid Akhtar Rao.
Thank you very much, Aslan. Very good presentation.
Thank you, sir.
And it has increased our knowledge also. As concerned the guidelines of NPO, till now it is the 2 hours before the surgery for pediatric clear fluids. That's my concern. And second question is that you said that there is no need of giving the deficit fluids. But in our local practice, we keep in majority of the hospitals this more than 6 hours NPO. In those patients where you are not following 2 hour guidelines, I think there must be a replacement therapy.
Sir, thank you for the question, and that is the main thing, that if we reduce the fasting time, then we can reduce the volume of the replacement as well. No? But the thing is, for that we have to practice both the things simultaneously. Narrower the fasting period, the lesser will be the replacement fluid required, and broader the fasting time, the more will be the deficit will be there, and then we have to replace it. So I think if somebody is implementing, he or she has to implement both the things simultaneously: reduction of the fasting time and then reduction in the deficit volume. That will, I think, the right thing to do in these sort of situations.
Thank you very much, Dr. Aslan, for a wonderful presentation. One comment and one question. 1 hour's NPO guidelines are not meta-analysis. European Australian guidelines, they have recommend 1 hour NPO in healthy kids, not sick kids, but healthy kids, 1 hour NPO. Second is, what about in neonates and premature babies? Intraoperative and postoperative fluid selection.
That is the main thing that I come across after reading the meta-analysis, that 1 to 2.5% of glucose or dextrose can be added to the isotonic fluids. Other than that, they may end up with hypoglycemia due to the high metabolic rate. So you had to give isotonic fluids containing 1 to 2.5% solutions of dextrose, but not like previous practice that half strength or 5% dextrose solutions should be given to the patient.
No more. Thank you very much. Thank you, Arsalan. I just wanted to make 2 comments. One is that हम लोग guidelines की तो बहुत बात करते रहते हैं, but do our surgery, because pediatrics is not just pediatric surgery. It comes in orthopedics. It comes in so many, and the surgeons are so insensitive to the requirement of their child having how much fluid and when to stop. दो जो मुझे major problems मैंने face किए हैं, when I was dealing with children, was that NPO कर दिया उसको 12 बजे रात से और उसकी सर्जरी हो रही है शाम के 4 बजे. So you know, I mean ये जुल्म है. और दूसरी बात अगर उनसे कहो कि खुदा के वास्ते ये नहीं करें और please clear fluids at least can be given to the child till 2 hours before surgery, as I remember, 2 hours before surgery. So they would say कि if we tell that to the mother, then she उसको बनाना भी खिला देती है, उसको पराठा भी खिला देती है, and she doesn't realize. So the practical problems that we have, I think, is to train our surgeons and our nurses and our ward people that what can be done and what should not be done. I feel that's the major hindrance. And anesthetists तो फिर भी sensitized हैं to you know कि कितना fluid देना है, कम देना है, ज़्यादा देना है, जो भी करना है. And most of the surgeries are bread and butter surgeries like you know inguinal scrotal hernias and this and that. और उनको बेचारों को 12 बजे रात से वो भूखा प्यासा रख के और फिर दोपहर के 12 बजे करते हैं. I mean, these are the things I think we should address where fluid therapy in pediatrics is concerned, because I've faced all these things.
Exactly.
Thank you. That was a wonderful talk.
Thank you.
And concluding comments. And that was we had three real nice talks from our you know upcoming budding consultants. And Liaquat, you dealt with pain very beautifully in children. Faraz is always very good with his talks. I've heard him on neurosurgery and he's an excellent speaker. And Arsalan, you did a very good job, except I think you should train your surgeons and your people, because हम जितनी भी बातें कर लें यहाँ पे, because eventually बच्चा वहाँ से आता है.
Exactly.
And thank you very much for attending this session. Thank you.
Pleasure, thank you.
Now we move toward the certificate distribution for our speakers in recognition of their valuable contribution and insightful presentations. May I request our Honorable Chairperson, Dr. Saida Haidar and Dr. Akhtar Aziz to kindly present the certificate to our speakers. Dr. Liaquat Ali, please come forward and receive the certificate. जी जी आपने देना ये पकड़ लें आप नाम नहीं लिखा किसी का भी ठीक है
अगला कौन
डॉक्टर फराज शफीक Dr. Faraz Shafiq, please come forward. Dr. Arsalan. इसके बाद मेरा वाला. अच्छा ठीक है छोड़ देते हैं ठीक है ओके डॉक्टर अरसलान तीन रहते हैं
आप चले दिलवा देते हाँ सर अच्छा वो कर डॉक्टर
Anila and for me Dr. Anila Fazal ANWLA
चलिए सर इनको तो दे दें हाँ फैसिलिटेटर सर आपका लैपटॉप पीछे रखा हुआ थैंक यू सर वेलकम थैंक यू एवरीवन बाद में नहीं ज़रूरत नहीं Moving on to the next session, which is the research and anesthesia, the session 10. To facilitate this session, I would like to invite Dr. Hoba Ahmed from Dow International Medical College. Dr. Hoba, please.
Assalamu alaikum everyone. I am Dr. Hoba Ahmed from Dow International Medical College, and I welcome you all to the most exciting session of our conference, that is Resident Free Paper Contest. For this, I would like to introduce our chairs. I would like to invite Dr. Fawzia Anis Khan, Professor Emeritus and ex-chair, Department of Anaesthesiology, the Aga Khan University Hospital. I would also request Dr. Maqsood, Head of Department of Anaesthesiology, Surgical ICU and Pain Management in Ghulam Muhammad Meher Medical College and Hospital, Sakhar, to please join Dr. Fawzia.
Assalamu alaikum, everyone. Welcome to this session on research in anesthesia. It's a pleasure to see so many papers in this session. मुझे अभी भी याद है कि बहुत साल पहले हम मिन्नत कर कर के अपने रेजिडेंट्स को कहते थे कि भाई कुछ तो प्रेजेंट करो, लेकिन this time oral presentation में we've got 12 presentations in addition to the poster session. So that's very encouraging. We have those who are presenting. We have 8 minutes for presentation and 2 minutes for question answers. First, I would like to invite the judges for this session, and I'll ask them to come forward on the first row. Judges are Dr. Fawzia Ali from SIUT in Karachi, Dr. Ameem Anwar from Liaquat National Hospital, and Dr. Liaquat Ali from Allama Iqbal Medical College from Lahore, and Dr. Muhammad Ashraf from Shifa International. Please may I request you to come to the first row. Dr. Ashraf, I can't see. Udhar hi the, lekin Acha. Okay, so we've got 3 judges instead of 4. Okay. Right. Just to let the participants know that there are 3 prizes for this session. The first prize is a gold medal and 25,000 rupees. Second prize is 15,000 rupees. Third prize is 10,000 rupees. So it's an incentive for you to present. What I'll do is, it's an 8 minutes presentation. I'll ring the bell 1 minute before finishing so that you can conclude your presentation. And then the second bell would be the end of your presentation. We will invite questions. I'll invite 1 question from the judges and 1 question from the audience. If there is no question from the audience, the second question can be asked by the judges. So, thank you. Before starting, I think there is an announcement.
I have an announcement for parallel session at Ballroom B for residents e-poster, and for which I will request judges to please proceed to Ballroom B. Dr. S.M. Abbas from SIUT, Dr. Faisal Khan from AKUH, Dr. Muhammad Asif Salim from PNS Shifa.
Thank you.
Dr. Sayyid Talal Ahmed from Indus Hospital, Dr. Asma Abdul Salam from Ziauddin, and Dr. Sohaib from AKUH. All the residents who have to present their posters, and those who are interested, please proceed to Ballroom B.
Okay, so we'll start with the first presentation. The title of this presentation is Comparative Study between Dexmedetomidine versus Tramadol as Adjuncts to Bupivacaine in PEC block in Postoperative Analgesia in Modified Radical Mastectomy. And our presenter is Dr. Amna Ahmed from Jinnah Hospital, Lahore.
Thank you so much, ma'am, for the introduction. So my name is Dr. Amna Ahmed, postgraduate training anesthesia department, Jinnah Hospital, Lahore, under the supervision of Professor Dr. Ashraf Zia. So the topic of my study is a comparative study between dexmedetomidine versus tramadol as adjunct to bupivacaine in PEC2 block for postoperative analgesia in modified radical mastectomy. So why PEG blocks matter? As we all know that breast surgery causes moderate to severe pain. So if we have poor pain control, that will lead to chronic pain, delayed recovery, and a longer stay. So PEG-1 and PEG-2 blocks are ultrasound-guided, simple technique that avoids sympathetic blockage of parasympathetic and epidural blocks. So if we inject the local anesthetic alone, that will lead to shorter duration. Adjuncts are needed to prolong the analgesia. So why the study was performed? As we all know that dexmedetomidine and tramadol, both are used as adjuncts, but there is no local data comparing them in PEG-2 block for modified radical mastectomy. So the goal of the study was to find the better adjunct for longer and safer analgesia. So the objective of the study is to compare outcome of dexmedetomidine versus tramadol as adjunct to bupivacaine in modified PEG-2 blocks for postoperative analgesia in modified radical mastectomy. Hypothesis of the study is that there is a significant difference in analgesic outcomes between dexmedetomidine and tramadol used with bupivacaine in PEG-2 blocks. So in this study, there are two outcomes. One is the primary outcome and the other is the secondary outcome. For the primary outcome, we will see the time to the first rescue analgesia that was calculated in minutes. And in secondary outcome, we will calculate the NRS pain scores at the rest and at movement at 1, 3, 6, 12, and 24 hours. We will also see the 24-hour rescue nalbuphine consumption, the patient satisfaction score, and the adverse effects. So the design of my study was prospective randomized, double-blind randomized controlled trial. The setting was Jinnah Hospital, Lahore. The duration of the study was 6 months, and the sample was 60 patients that are undergoing modified radical mastectomy. So we divide them into 2 groups according to the randomization technique lottery method. So in each group we have 30 groups. So in every study, as we all know that we have an inclusion and an exclusion criteria. So in the inclusion, we included the females 25 to 50 years of age, ASA score 1 to 3, undergoing modified radical mastectomy under general anesthesia. So we excluded the patients having chest wall deformity, the body mass index greater than 40, bleeding disorders, hypersensitivity, pregnancy, and drug abuse. And we also did the blinding, that is double blinding, which is that patient and the assessor both are blinded. So the technique we use is the ultrasound-guided modified PEG-2 block after induction of the general anesthesia, as we have divided the groups into 2 groups, Group A and Group B. In Group A, we injected 30 ml of 0.25% bupivacaine along with the dexmedetomidine 1 microgram per kg. And in the Group B, we have we have 30 ml of 0.25 bupivacaine along with the tramadol 1 mg per kg. The block was given in the facial plane between the pectoralis minor and the serratus anterior at the 3rd rib level using 6 to 13 megahertz linear probe. And the patient was followed 24 hours in the surgical ward, and the pain was assessed at 1, 3, 6, 12, 18, 24 hours at rest, and with arm induction using NRS score 1 to 10. And the rescue analgesia was IV nalbuphine, which was also recorded and was given if the NRS score is equal to or greater than 4. So the analysis and the data collection, the data was collected in the demographic section. I recorded the patient age, the body mass index, and the comorbidities. Intraoperatively, I see the time and the blood loss. For the analysis, I have used the software SPSS-V29, and for the normality, I have the Shapiro-Wilk test. Quantitative data is assessed via the independent t-test, and for the significance, we have considered the p-value less than 0.05. So the first of all is the primary outcome. For the primary outcome, we have already seen the last slide that we have calculated the duration of the analgesia, which was collected in minutes. So I have analyzed my data in a bar chart. As we can see that on the x-axis we have the drugs, dexmedetomidine and the tramadol, and on the y-axis we have the duration of the analgesia in the minutes. So we can see that for the dexmedetomidine group, the minutes is 780 minutes, and for the tramadol group is 650 minutes. So the duration of the analgesia is prolonged for the dexmedetomidine group as compared to the tramadol group. And the p-value is less than 0.001, that means that it is statistically significant. Coming to the other outcomes, the pain scores and the analgesic consumption, we have another graph for the postoperative pain score. We can see that there are 2 lines. One is the red line and the other is the blue line. We can see that until the 3 hours, both lines are at the same level, and after that, we can see that the tramadol group has increased pain scores. So what's the conclusion of this? That we can see that at 6 hours, 12 hours, and 24 hours, the pain score has lessened for the dexmedetomidine group. So lastly, we have seen the patient satisfaction for the dexmedetomidine group. We have the 83% satisfaction, that is good to excellent, and for the tramadol group, that is 60%. Adverse effects for the both group, we have seen minor side effects, but no major adverse effects seen in either group. So why this study was clinically significant, why this study matters in Pakistan? So there is no local data. This was the first randomized control trial comparing these adjuncts in PAC block for post-radical mastectomy in our population. It is according to the ERAS alignment, that is means that early mobilization, shorter stay, lower chronic back pain risk. So it is also cost effective. Both drugs are economical and easily available, and identifying the better one directly impacts the practice. So it is also safe. Both drugs are safe with no respiratory depression and any other adverse effect. So what's the impact? These results will guide regarding best postoperative analgesia in the breast surgery across Pakistan. So the conclusion of my study is that dexmedetomidine and tramadol both are viable adjuncts to bupivacaine in PAC2 blocks. In our study, I have dexmedetomidine provided superior analgesia with longer duration and lower opioid consumption. So this trial provided high quality local evidence to optimize postoperative pain management in modified radical mastectomy. So the take home message is, if we change a small change in adjunct, that is, there is a bigger change in patient comfort and recovery. So that's are the references I have used, and thank you so much. Any questions?
Thank you, Dr. Amna. We'll first invite questions from the judges. I see Dr. Ashraf has been replaced by Dr. Nasir. So from Shifa International from Islamabad. So first question from the judges. Dr. Fawzia, can you hold the mic near your...
For 24 hours. Yes.
Sorry, can't hear you. Can't hear you, sorry. This is better.
Is it okay? You have assessed pain score for 24 hours.
Yes.
So it is there was same observer, or for 24 hours a single person observed the pain, assessed the pain score, or multiple persons who were involved for the pain assessment?
No, ma'am. It's a single observer. Single person observes the patient in the post-surgical ward for 24 hours.
For 24 hours.
Yes, ma'am.
So the patient usually they are shifted in the ward and...
Yes, yes. Afterward, we observe the patient for 24 hours for their pain score, and we rate them into 0 to 10. And then after, according to if they have greater than 4, we can give them the IV nalbuphine, the rescue analgesia, and we can then calculate the dose, that how much we have given that dose.
You have observed bradycardia in a dexmedetomidine group.
Yes, ma'am.
So at how much heart rate dropped? To which level?
Ma'am, heart rate dropped, but not significantly dropped. Like it was not less than 50. It was a minor drop.
No intervention was required.
No intervention was required.
They were monitored continuously with ECG.
Yes, that was only mild bradycardia.
Okay, does anyone from the audience have a question? If not, we can ask, go ahead.
Thank you very much. It was a nice idea. Just wanted to confirm that normally these kind of observation, it's not possible that one person 24 hours doing that. So normally there's a person which is trained कि ये objective है number 1 का मतलब ये 10 का ये तो ये किया था, या एक ही बंदा हर दफा 24 घंटे बैठा रहता था?
No, ma'am. It is a trained.
I think Dr. Fawzia wanted to ask that, ना? Because this is like अगर आपने कोई को train कर लिया है, कोई research trainee है, ये खुद कर रहा है तो because 24 hours one person and all these seems difficult. So that was just my comment.
Okay, ma'am.
Okay, thank you. We'll move to the next.
Thank you.
The second speaker is, topic is comparison of the time of intubation and measurement of mouth-to-mouth distance using Macintosh laryngoscope versus video laryngoscope in the aerosol transmissible diseases. So it is a randomized control trial and it will be presented by Dr. Nazia Shamim from AKUH.
Assalamu alaikum everyone, I am Nazia. My topic of study was comparison of time of intubation and measurement of mouth-to-mouth distance using the Macintosh laryngoscope and a video laryngoscope in aerosol transmissible diseased patient. It was a randomized control trial. Okay, so airway management is a highest risk taking procedure, and especially during an outbreak. History has shown us that Spanish influenza, SARS-CoV-1, H1N1, COVID-19, all of them have brought anesthesiologists at a higher risk, and intubation becomes difficult since it's an aerosol producing procedure. Now during this time, an anesthesiologist usually asks themselves two questions. What are those? How quickly and safely can I intubate my patient? And how can I protect myself while I'm intubating the patient? So the objectives of my study were to compare the time to successful intubation with both the tools, Macintosh laryngoscope and video laryngoscope, and to compare the mouth-to-mouth distance between the patient and the anesthesiologist while they are intubating. So this is an AI-generated image where I'm showing an anesthesiologist is intubating the patient. The dotted line tells us the distance, and there's a stopwatch that shows that the time was recorded in seconds. So the methodology, the study design was a prospective randomized controlled trial conducted in one of the operating rooms, in the operating rooms of one of the university hospitals in Karachi. These were my inclusion criteria. I had taken electively planned patients, ASA 1 and 2 only, none of the difficult airways. I had recruited 160 patients and 80 in each group, and all of them were included, none of them were excluded, and none of them were lost to follow-up. So the randomization was done for both the groups by a computer-generated randomization sequence. For Macintosh direct laryngoscopy group, and for the video laryngoscope, I had used McGrath video laryngoscope. So the anesthesia protocol for my study was standard general anesthesia, standard ASA2 monitorings for all my patients, and the induction drugs. So the intervention in both the group, the Macintosh group and the McGrath group. So in the Macintosh group, the endotracheal tube was inserted under direct visualization of the vocal cords, and in the McGrath group, it was done under the videoscopic guidance. And all intubations were performed by senior residents, year 3 and above, and consultants. So the outcome measures were total time of intubation starting from the moment the laryngoscope is entered into the mouth of the patient till the appearance of the end-tidal waveform in the capnograph. And timing was measured by using a stopwatch by an independent observer, and mouth-to-mouth distance was measured with a measuring tape in centimeters. So as per the demographics, there was no statistical significance with respect to gender, age, BMI, ASA physical status, and malempathies. The results of my study were, so the time of intubation in both the groups were 33 seconds in Macintosh group with a standard deviation of 4.5 seconds, and 39.2 seconds in the video laryngoscope group with a standard deviation of 5.34 seconds, statistically significant. So this was a difference of about 6.2 seconds between both the tools. In the operator-patient mouth-to-mouth distance measurement, we found that in the Macintosh laryngoscope group, 25.3 centimeters was the distance from the patient while anesthesiologist was intubating, and 34.6 centimeter distance was while the patient was being intubated with McGrath video laryngoscope. And this was also statistically significant with a difference of about 9.6 centimeters. So the conclusion of my study was that a significant increase in operator-patient distance of about 9.6 centimeters with only a 6-second increase in intubation time, making it a potentially safer airway device for patients with airborne transmissible diseases. To validate my results, I looked upon literature. The studies, I found one of the studies that was done in Children's Hospital at Stanford, and it showed that the distance-based dynamic behavior of aerosol particles during aerosol-generating medical procedure, and the study illustrated that there are potential benefits of an increased distance while you're doing any procedure that produces aerosols. Another one of the studies done in the past about aerosol behavior also proved that the ventilation in the room, the type of droplet and aerosol was also mentioned, and the personal protective equipments that the doctors wear. Besides that, they also mentioned that the farther the healthcare worker is away from the patient with a transmissible disease is better. The strengths of my study were that it was a prospective randomized controlled trial. I had an adequate sample size. The results were statistically and clinically significant. Multidisciplinary reference, since intubation is done by a lot of healthcare workers, not just anesthesiologists. Limitation was that it was a single center study. So in the face of invisible threats, distance becomes defense. Video laryngoscopy, farther from the airway, closer to safety. Thank you.
फिर अनाउंस कर देता हूँ. अच्छा, जजेस का कोई अगर सवाल है
yes,
तो पूछ.
I have a question. You use different residents and consultants. How many total people were used, and what about the experience with the video laryngoscopes? How much roughly cases they have done with video laryngoscopes? Because dealing with the laryngoscope, there are some technical issues.
Right.
So to control this bias, what was how was you selected, and how much number were selected as the operators?
Okay, so the population that was intubating were year 3 above residents, the ones who are very good with intubations.
With video laryngoscopes?
With the video laryngoscope
Okay.
as well. So in my institute, we have video laryngoscope available easily, and they are very good ones.
So you think that, what I want to know, how many total number of operators being used in this study, and do you think there were trained?
There isn't a count for the operators that we've used. We've just classified, we had just the years and above. So consultants and residents who were year 3 and above.
Thank you.
Now from the audience, if anyone can, okay.
My question is regarding unanticipated difficult airway patient. If fall in your video laryngoscope area, it will be masked.
Okay,
How,
so
did you unanticipated difficult? You address some kind of these cases in your study?
Okay, so it was one of my exclusion criteria. I made sure that I recruit patients who had no difficult airway. So
Unanticipated. There's some anticipated.
I did not come across any of them. So none of my, in my consort, I did not exclude any of them.
But if the case went to the video laryngoscope group, it will automatically become a normal airway, because video laryngoscope definitely preferred over conventional laryngoscope in difficult airways. No? Then there will be biasness if there is an unanticipated airway.
This is a possibility, but in my study I did not come across any unanticipated one, but this is bias. That's right.
Okay, thank you. We'll move over to the next presentation. This is effect of preoperative carbohydrate loading on perioperative serum lactate levels in patients undergoing donor hepatectomy, a randomized controlled trial. Presenter is Dr. Mia Usman Hamid from Shifa International, Islamabad.
Assalamu alaikum everyone. My name is Dr. Usman and I am a resident in the Department of Anesthesia in Shifa International Hospital, Islamabad. Today I will be presenting a randomized controlled trial examining the effect of preoperative carbohydrate loading and its effect on perioperative serum lactate levels in patients undergoing donor hepatectomy. So donor hepatectomy is a physiologically demanding surgery. There is significant ischemia reperfusion injury. There are significant hemodynamic shifts and the metabolic demand, which is inherent in significant liver dissection, can prone the patient to perioperative lactate accumulation. Prolonged fasting, which may sometimes be unavoidable, it increases insulin resistance, drives catabolic metabolism, which may increase the risk of anaerobic metabolism even before the patient presents to the operating room. So evidence for carbohydrate loading is present in the enhanced recovery after surgery protocols. However, its direct effect on serum lactate levels, especially in living hepatic donors, remains underexplored, and this is the gap that our study aims to address. So our primary objective was quite straightforward. It was to determine the effect of preoperative carbohydrate loading and its effect on the mean perioperative serum lactate levels in patients undergoing donor hepatectomy. Our hypothesis was that the loading will maintain a lower serum lactate level compared to standard fasting group throughout the perioperative period. So there were 5 time points we aimed to measure. One was at induction. The second was right before graft removal. The third was 30 minutes after the graft was removed. The fourth was before extubation. And the final measurement was done in the post-anesthesia care unit. So our study design was a prospective randomized controlled trial. It was done in our Department of Anesthesia. The sample size was calculated to be 70 participants total, with 35 in the intervention arm and 35 in the control group. Simple random sampling was done. All 70 patients were adults from the ages of 18 to 50, and they were all undergoing elective donor hepatectomy. Patients with known metabolic disorders or pre-existing liver dysfunction were excluded because these conditions predisposed to a different pattern of lactate accumulation and may have confounded our result. So our sample size was calculated using OpenAPI, using previous literature that was already explained. A computer-generated randomization sequence was done for randomization. Only single blinding was done where the analysis performed was not informed of which group was the intervention or the control group. And the carbohydrate drink we provided were approximately 2 to 4 hours before the surgery was planned. So all the patients who were assessed for eligibility, none of them were dropped out after randomization. And the analysis was done in 2 arms. Mann-Whitney U was done for exact comparison between 2 groups throughout the time points, and analysis of variance was done to see the rise of lactate throughout the surgery. So before we go on to the results, we have to compare our groups at baseline. So as you can see, age, BMI, and gender had no statistical difference, which confirms the internal validity of our randomization. This also means that any observational changes that we saw during our results was definitely due to our intervention and not because of any baseline differences. So this is our main result. So line chart is made, which shows that there are 2 graphs. The green line shows the intervention arm and the blue line shows the control group. So as you can see, the only time point with a statistically significant lower lactate in intervention group was at induction, which was 1.32 as compared to 1.62 in the intervention in the control group. The second important finding was that there was a progressive rise in both of the graphs. which was also confirmed by our analysis of variance, which was highly significant. And the third important finding was that both of the graphs are parallel to each other. They rose at the same rate approximately. So table 2 shows the exact comparison between the two groups. So induction is significant, at which point there is a lower lactate level, which is significant at a p-value of 0.020. No other subsequent time points had a significant level. However, before extubation, the p-value is 0.055, which is a borderline trend, which does suggest that, as well as visually lower level in each point in the intervention group. So it does show that it may have a near significant difference if we had a larger sample size. So repeated measures ANOVA had 3 significant findings. One was the time, which is that the lactate is rising as the time is proceeding throughout the surgery. So this is an expected rise, especially in a surgery such as donor hepatectomy with significant liver resection. Second is the group effect. There was no statistically different overall difference between the groups. And then there's a time group interaction, which shows the same lactate trajectory, that both of the lactate trends, they rose at the same rate, even though the intervention arm started at a lower lactate point. So small discussion is that significantly lower lactate level at induction was seen, which supports that preoperative carbohydrate loading does reduce catabolic load, and it is also consistent with already established ARAS protocols. However, the effect was not sustained intraoperatively, which suggests that the ischemia, reperfusion injury, the significant hemodynamic shifts, they may have overwhelmed any benefit the preoperative carbohydrate loading may have had. However, there also an important thing was that it was a consistent directional trend. At every point other than induction, the lactate level was still lower, even though it did not reach significance. And the point before extubation, it does show a borderline trend. It may be because it was an underpowered study, and we may have to see with a larger study or a sample size to see whether or not there can be. Thank you. And local relevance, especially in our setting, this is a simple, low-cost intervention that can be easily implemented regardless of resource-limited settings. So our conclusion, it says that preoperative carbohydrate loading, it did reduce serum lactate level at induction, which is evidence of prepared metabolic preparedness. The benefit was not sustained intraoperatively or perioperatively. A significant time effect, which already confirms our previous known fact that lactate levels rise significantly during such a surgery. But because this is a low-cost intervention, we do want and we do advocate for a larger trial, including multicentric studies, which may prove that there may be a sustained benefit intraoperatively as well as postoperatively. Thank you.
Okay, question from the judges. Any questions?
How much volume you have used, carbohydrate volume, and which carbohydrate you have used?
So we used 200 ml. We used a standard Nestle Fruta Vitals apple juice, which is clear. It had 23.8 gram of carbohydrate, simple carbohydrate, approximately 24 gram.
Okay.
What about, did you use this carbohydrate in a patient with gastroesophageal reflux, history of GERD or gastroesophageal reflux disease?
It would suggest that a history of GERD would definitely be or should be an exclusion criteria. However, none of the patients we screened had a problem with reflux in our study.
Or a patient with history of
Dr.
diabetes.
Fazia, can we have a question from the audience, please? Audience, any question? If no question, then we can have another question from the judges. डॉक्टर फजिया आपने दूसरा पूछना है फिर इनको दे दीजिए. अच्छा, okay.
Why did you use simple glucose powder or glucose solution injection?
Because there were two reasons for this. One, that it is easily available, it is inexpensive, and it is easily metabolized for the patients. Second, because the clear liquids we have, this is the one that was easily available, the simple glucose. For complex carbohydrates, we did have an option of using fructose corn syrup. However, that may have not been part of the clear liquid, and that may have predisposed the patient to a longer impure time as well.
Apple juice contained more fructose.
Yes, but the...
what was the exact glucose amount which was infused?
So, in the 200 ml of juice we provided, it was 23.8 grams, approximately 24 grams in each juice.
Okay, in the interest of time, can we move forward, please? Thank you.
Thank you, Dr. Usman.
Thank you, everyone.
Now the fourth presentation is prevalence of post-traumatic stress disorder among anesthesia residents. A study done in the Tertiary Care Teaching Hospital of the Karachi. The presenter is Dr. Ramesh Khan from AKUH.
Assalamu alaikum, everyone. Every anesthesia resident encounters patient death, airway emergencies, and high-stake decision making almost daily. Yet the consequences of this exposure are really discussed in Pakistan. My name is Dr. Mohammad Ramesh Khan, and today I'll be presenting our study, the prevalence of PTSD among the anesthesia residents, done in the Tertiary Teaching Hospitals of Karachi under the supervision of Dr. Khalid Ahsan. The weight of the clinical trauma. Post-traumatic disorder is a defined psychiatric condition following traumatic exposure characterized by intrusions, avoidance, cognition changes, and hyperarousal lasting for at least a month and above. Why did I choose the healthcare workers? Because of the routine exposure to patient deaths, resuscitation, and medical errors, workplace violence, ethical distress, and high-stake decision-making, long duty hours, sleep deprivation, and heavy workload compounding the psychological risks. The international studies report PTSD prevalence to at least 14 to 23% among the residents, and the burden may be even greater in the low and middle income countries like Pakistan due to stigma and limited mental health resources. These were the researches done in the West and the United States, including the surgical residents and the physicians, and some local data done in Pakistan in the surgical residents of Lahore and among the healthcare providers in Karachi in a tertiary hospital. So why did I choose the anesthesia residents? Anesthesia trainees operate at the intersection of critical and high-stake procedural medicine, a uniquely demanding environment. It includes high acuity exposure, daily management of airway crisis, cardiac arrests, intraoperative complications, sudden patient deterioration. It includes the surgical stressors such as prolonged duty hours and chronic sleep deprivations, limited support, of course, due to the lack of structural psychological support systems, and lastly, the knowledge gap. Despite high vulnerability, PTSD among anesthesia residents in Pakistan, particularly Karachi, remains critically scarce. The objective of our study was to determine the prevalence of PTSD among the residents. We conducted a cross-sectional study using a self-administered online questionnaire. The symptoms were assessed using the PTSD checklist. A score of 33 and above was considered positive for probable PTSD. A total of 105 residents completed the questionnaire. Study framework. Cross-sectional study, inclusion criteria, anesthesia residents, year 1 to year 4, willing to perform the informed consent. Exclusion criteria, resident with PTSD, prior psychiatric disorder, and refusal to participate. Data collection was done via anonymously self-administered online questionnaire via Google Forms. Non-probability purposive sampling was adopted and the sample size was 105. Key results, the prevalence and demographics. The striking finding was that every single participant reported exposure to at least one traumatic clinical event. Majority of them were the females. And the most important finding of our study was that 43% of the anesthesia residents were screened positive for PTSD. That means nearly 1 out of 2 residents have significant symptoms of PTSD underlying. This is the pie chart, and this is the distribution of the traumatic events with patient stats and bullying leading the charts. This is the distribution of the participants by the institutes and by the residency years. Now we'll discuss a few numbers. The table shows a univariable analysis comparing PTSD and non-PTSD groups. Age, gender, and residency year were not significantly associated with the PTSD. This includes the traumatic events and the institutes. Now I have summarized the table here for easy understanding. The table shows univariable analysis comparing residents with PTSD and non-PTSDs. Age, gender, and residency year were not significantly associated, whereas the institution variation and type of traumatic events showed significant association, suggesting that workplace environment play an important role in PTSD development among the anesthesia residents. Since the outcome of my study was binary, logistic regression was used to determine which factors independently increased or decreased the likelihood of the PTSD while controlling for the confounders. Therefore, variables significant in univariable analysis were entered into the multivariable logistics, such as the institute and the type of traumatic event. After adjustment using the multivariable logistic regressions, death-related trauma exposure remained the only statistically significant factor associated with PTSD symptoms. This association reached a strong statistically significant with a p-value of 0.006. Death-related trauma was the strongest independent of the PTSD, with significantly lower odds of PTSD after adjustments. This should not be interpreted as a protective effect, but repeated exposure to patient death during the anesthesia training may lead to psychological habituation, emotional desensitization, and development of coping mechanisms. Residents may develop professional emotional distancing as mortality becomes part of their training. Interpersonal stresses such as bullying, lack of support, workplace conflict may produce greater psychological distress due to their unpredictable and personal nature. Findings suggest that type and context of trauma influences PTSD more than the exposure alone. Conclusion: high prevalence. PTSD symptoms were identified in 43% of the residents, a substantial occupational mental health burden exceeding many international benchmarks. Universal trauma exposure. All 105 participants report exposure to traumatic clinical event, underscoring the emotionally demanding nature of the anesthesia training. And trauma type is a key predictor. Although several variables appeared associated on an univariable analysis, after adjustment only trauma type remained independently associated. Strengths and limitations of my study. Multi-center study using of a validated tool, focus specifically on the anesthesia residents, and assessment of multiple workplace-related trauma exposure and associated factors. The limitations: cross-sectional study limits the assessment of causality. Self-reported questionnaire may introduce recall and reporting biasness. Study limited to only tertiary care hospitals of Karachi, and PTSD was screened using PSL-5 and not confirmed through formal psychiatric evaluations. Implications and recommendations. A 43% of prevalence demands structural institution and level action, not individual resilience alone.
1 minute.
Thank you. So, routine screening must be done, followed by psychological support. Residence wellness programs require develop structured wellness curricula, and institutional policies. Hospitals and program directors should formalize mental health frameworks and help seeking. And these are my references, and thank you very much.
Now the questions from the judges side. No question. Dr. Liaquat, mic please.
Regarding your exclusion criteria, you were excluded residents with a certain history.
Yes.
And how many residents you came across with that history, how they were diagnosed, or if there was any number in any hospital? Because you engage in different hospitals.
Yeah, so the questionnaire that was shared initially, it was sent to around 120 residents overall. And the questionnaire had the informed consent that had mentioned specifically that if you have a certain diagnosis or you're taking psychiatric medications, and that basically is a part of the exclusion criteria.
That is my part. That is my question.
Yeah.
Because diagnosis of this problem in anesthesia resident is very unusual. It's not a common thing we diagnose. So if we have not, how can you ensure कि जो आपके जो participants थे उनमें किसी में ये problem नहीं थी? Because this is too much.
Yeah, that is one of the reasons why it includes the biasness, because the residents that opted not to fill the questionnaire were the ones who had those problems. But the ones that actually filled the residence, we could not evaluate them, whether they have those conditions or not.
So there was any resident who said, I am having this problem, and I will not be able to participate in this.
Yes. So the residents who were the part of the.
I think that can be a very good number if you include that in your research. That if you contacted, for suppose 500, and among those 10 residents were already having this problem and being treated like that.
We wanted to keep the results anonymous, so we did not.
Don't disclose the name.
Yeah.
But total numbers in 400 patients.
Yeah, I agree. I agree.
Now the questions from the audience.
Thank you very much, Ramesh, for sharing this excellent study. I think it's a brilliant idea. My first question is, because it's an anonymous survey, and there's such a high number of PTSD among the residents, is there any provision for that individual resident to know their own result? You know why I'm asking? For example, जब आप किसी कोई study करते हैं, कोई आप courses कराते हैं, आप उनसे MCQs कराते हैं, तो आप उनको उनका result individual भेजते हैं. तो अगर जब तक, क्योंकि बहुत से लोग होंगे जिन्होंने भरा होगा, उनको PTSD होगा, मगर उनको खुद नहीं पता होगा कि उनको PTSD है, and ये तो आपको मालूम हो ना, because of certain scoring systems which you had. और कुछ centers के अंदर कोई help होती भी नहीं है, wellness centers नहीं होते या कोई referral होता ही नहीं है. So was there any provision made, embedded in the study कि जिसमें resident को उसका individual score पता चले, so that if the system is not helping them, they can help themselves by seeking, psychiatric referral or going somewhere?
I think that's a brilliant idea, but that was not part of their research program. But this particular thing can be incorporated into the further researches concerning the topic.
Thank you very much.
Thank you. Thank you, Dr. Malik. We'll move over to the next presentation. This is comparative analysis of CMAC video laryngoscopy and Macintosh laryngoscopy for optimal glottic visualization in adult patients undergoing orthopedic surgery. This will be presented by Dr. Mughira bin Saqib from Gurki Trust from Lahore.
Bismillahirrahmanirrahim. The topic of my presentation is comparative analysis of CMAC video laryngoscopy and Macintosh laryngoscopy for optimal glottic visualization in adult patients undergoing orthopedic surgery. I am Dr. Mughira, final year resident from Gurki Trust Teaching Hospital. This is the institute where I work. The background of this study is that effective airway management is essential in anesthesia practice, whether it's whether you are treating the trauma patients or the ICU patients or in the operation theaters. You have to get an airway, secure an airway for patient to further pursue under general anesthesia or to have lesser complications resulting from trauma. Macintosh laryngoscopy has been the traditional gold standard since early 1900s, but the advent of video laryngoscopy has offered improved glottic visualization, and it may improve intubation success rate and reduce complications. The rationale behind doing this study was there was very limited local data available in Punjab or Lahore in patients especially having normal airways. There was comparison between patients with difficult airways between Macintosh laryngoscopy and video laryngoscopy, but there were few available data regarding the normal airway patients. The objective of the study was to compare glottic visualization using Macintosh laryngoscopy and video laryngoscopy, and the comparison was based on Cobb-McLean grading system. which is the grade 1 is the complete visualization of the laryngeal apparatus, including whole of the vocal cords, epiglottis, and the posterior part of the vocal cords. Grade 2 is the partial visualization, and grade 3 is only epiglottis is visible. Grade 4 is no glottic structures are visible. Grade 1 and 2 are labeled as good visualization, while grade 3 and 4 are labeled poor visualization. Is a picture demonstrating the Cormack-Lehan grading system, and there has been a modified system where it has been divided further into 2A, 2B, 3A, and 3B, depending on the structures visualized. This was a randomized controlled trial which was conducted at Ghurki Trust Teaching Hospital between January and March of 2026. We had a sample size of 146 patients, which were divided into 2 equal groups of 73 patients aged 18 to 45 from either gender who were ASA 1 or 2, and they were planned for elective orthopedic surgeries under general anesthesia. They were included, and they had the Mallampati class from 1 to 3. But the patients, including those were excluded were the emergency surgeries and the patients with features of difficult airway or having oropharyngeal or facial trauma. The descriptive statistics, there was no significant difference in the age in either of the groups or the genders, but the results showed that Cormack-Lehan grade 1 and 2 they were more prominent in the video laryngoscopy group as compared to the Macintosh group. In video laryngoscopy group, the grade 2 and grade 1 were the most common visualizations, while as in Macintosh laryngoscopy, grade 3 was the most common visualization. That also implied one thing, that even without features of difficult airway, the unanticipated difficult airway can happen. Overall, good visualization was achieved in 45.2% of the patients in Macintosh group and 87 patients in 87.7 patients in video laryngoscopy group. That was a difference of about 50% in between both groups. This bar chart implies the visualization in Macintosh laryngoscopy. You can see that the good visualization was lesser as compared to the poor visualization. And in video laryngoscopy, the glottic visualization improved from grade 3 to grade 1 or 2. Post-intubation complication, including the use of assistants and devices like bougie or Estilet, they were about 5.5% in Macintosh group, where majority of them were oropharyngeal or dental trauma, and the use of bougie or Estilet and video laryngoscopy group had no complications. So video laryngoscopy demonstrated a superior safety profile in terms of post-intubation complications as well. It significantly improved glottic visualization, which was consistent with previous observations. The parent study from which I calculated the sample size, it showed that Cormack-Lehan grade 3 was 5% in video laryngoscopy group and 18% in Macintosh laryngoscopy group. But my study actually doubled the results almost. The poor visualization in good visualization in Macintosh laryngoscopy group was about 45, while in video laryngoscopy group it was 87. And poor visualization grades were fewer with video laryngoscopy, which are consistent with international literature. And due to better visualization, the intubation time and intubation success rate were greater with the use of video laryngoscopy. It reduced airway trauma and repeated intubation attempts. We concluded that CMAC video laryngoscopy is superior to Macintosh laryngoscopy because it provides better glottic visualization, leading to lesser intubation attempts, improved safety, and lesser trauma. One thing was that overall intubation time due to complicated insertion of the video laryngoscope was more as compared to the Macintosh laryngoscopy. And it can be, video laryngoscope can be and should be considered a preferred airway management tool in routine practice. With the newest DAS guidelines of 2026, they have recommended the use of video laryngoscope first in a difficult airway. There were no conflicts of interest And these are the references which I took. Thank you.
Thank you. Okay.
And questions?
So questions from the judges? Yes. Dr. Liaquat?
आपके जो इंक्लूजन क्राइटेरिया में मैलम्पटी 1, 2, 3 था, आपके रिजल्ट्स में कहीं हमें कोई आपने देखा था कि दोनों ग्रुप्स में मैलम्पटी 1, 2, 3 की क्या डिस्ट्रीब्यूशन है और उसमें फिर डिफिकल्ट एरिया का तो कोई प्रॉब्लम नहीं?
I did not compare those.
Okay. Second is you mentioned there was a significantly more time in video laryngoscope group. So can you share the time?
I did not compare it objectively because that was not the primary objective of my study.
Okay, thank you very much.
And
Thank
one
you.
thing about
Any questions from the audience? If not, then if the judges want to ask another question.
Why you have selected adult population and undergoing orthopedic procedures where most of the cases are being done under neuroaxial block or for lower limb surgery, and is there any?
There is a reason we work in a spine center and we have more patients of for orthopedic and spine surgery. So that is the commoner population in our setting.
Specific surgical procedure where you want to compare?
The specific procedures were the ones where the patient was not giving the consent for neuroaxial block or a young patient where we did not want to perform a neuroaxial block, or the surgeon was unwilling for a neuroaxial block and we had to put the patient under general anesthesia.
Thank you. Okay.
Thank you.
Now the next presenter is Dr. Muhtasim Tariq, and the presentation is anesthetic management of a parturient with extreme pulmonary hypertension and placenta previa, and it is a case report.
Assalamu alaikum. I am Dr. Hafiz Muhammad Muhtasim Tariq, resident anesthesiology, Khan University Hospital, Karachi. I am here to present a high-risk case report on the anesthetic management of a pregnant woman with extremely high pulmonary artery hypertension and placenta previa. I have no conflict of interest to declare. So the pulmonary artery hypertension is a complex and devastating hemodynamic condition which is defined as a mean pulmonary artery pressure of greater than 20 millimeter of mercury at rest. In women of childbearing age, this condition is categorized as WHO class 4, which means that the pregnancy is strictly contraindicated due to an exceptionally high risk of maternal mortality. While advanced therapies and medical optimization have reduced mortality rates to approximately 11 to 25% in specialized health centers, the physiological demands of pregnancy pose a significant threat to cardiovascular stability. Despite of these risks, some patients may present with an undiagnosed condition during gestation or choose to continue a known high-risk pregnancy. This report described the anesthetic management of a parturient with newly diagnosed severe pulmonary artery hypertension who presented for elective termination of pregnancy on medical grounds. The clinical objective described in this case report will be anesthetic management, optimization, real-time hemodynamic tracking, multidisciplinary approach, and outcome focus. Our strategic anesthetic goals were to maintain the systemic vascular resistance to ensure adequate oxygen delivery to the right ventricle and to minimize the pulmonary vascular resistance and avoiding the triggers of the pulmonary that can worsen the pulmonary artery hypertension like hypoxia, hypercarbia, and pain. And our third objective was the euvolemic state to prevent the right heart over distension. And our anesthetic management was CSC to avoid the hemodynamic surge of general anesthesia and intubation. So this is a clinical case presented. We had a young female at 22 weeks of gestation presented with acute exacerbation of the cardiac symptoms including shortness of breath, dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Her medical condition was significant for severe pulmonary artery hypertension and severe tricuspid regurgitation. And antenatal ultrasound confirmed grade 4 placenta previa. That means the internal os was completely covered with placenta. So a multidisciplinary team, including the anesthesia obstetrician and the cardiologist, decided for elective termination of pregnancy via hysterectomy. So these are the biochemical markers which shows the elevated pro-BNP, which is as expected. The ECG shows sinus tachycardia. The echocardiogram done on the same day shows that pulmonary artery systolic pressure at a critically high level of 145 millimeter of mercury, with moderately dilated right atrium and mildly dilated right ventricle, D-shaped left ventricle, and severe tricuspid regurgitation with peak pressure gradient of 140 millimeter of mercury with normal biventricular systolic function. This is a chest X-ray which you can say with a red mark that there is enlarged pulmonary artery, which can be seen on the chest X-ray, and there is bilateral prominent hilar vasculature. These are the investigations which were done. As you can see that most of the investigations are within normal limits except the platelet count, which is on a lower side, and sodium is also on the lower side, could be hypervolemic hypernatremia, and the bicarb is on the lower side, which is as expected as a physiological change in pregnancy. So these were after the high-risk informed consent taken by the husband and the counseling of the patient as well. Standard SA2 monitoring was applied, and the awake left radial arterial line was done, and 2 liters of oxygen was applied by nasal prong to prevent hypoxia-induced increase in pulmonary artery hypertension. The anesthetic techniques included the combined spinal epidural, which was performed by an experienced anesthetist of a 5 years experience. It included low-dose hyperbaric bupivacaine of 3 mg with fentanyl of 20 mics, total volume of 1 ml, and then the incremental boluses of 0.25% isobaric bupivacaine were given 3 ml bolus every 5 minutes till the T7 sensory block was achieved, and the norepinephrine infusion started to maintain the systemic vascular resistance for the right heart the perfusion. This is the clinical vital trend sign. As you can see that most the patient remained hemodynamically stable throughout the procedure except the heart rate, which was on a higher side, which was as expected. So the surgery went into fenestrine incision, the hysterotomy was performed. Total blood loss was 600 ml, which was managed with 500 ml of the colloid and 500 ml of the ringer lactate administered to preserve the preload while avoiding the volume overload. The patient was transferred to the CCU post-op with epidural in situ for the multimodal analgesia, and the post-op echo done on the same day showed the same echocardiographic findings, and the patient subsequently improved clinically and was discharged on post-operative day 3 with advanced pulmonary artery therapy, including the pulmonary vasodilator and the diuretics, and at a 1-week follow-up patient showed tremendous amount of improvement. Now coming to the discussion, systemic hypotension leads to reduced right coronary artery perfusion, causing right ventricle ischemia, further decreasing cardiac output, and this may trigger a cascade of the cardiovascular collapse. So we started the norepinephrine to maintain the systemic vascular resistance and maintain the mean arterial pressure, ensuring coronary perfusion despite the sympathetic block from the regional anesthesia. Avoiding both volume depletion and volume overload was the central management pillar. So the patient unfortunately presented at 22 weeks of gestation, and we had to intervene due to the severe pulmonary artery hypertension, and moreover the grade 4 placenta previa further complicated the management of the patient. So we used the invasive monitoring to titrate the vasopressor and fluid precisely. Coming for the anesthetic management, regional anesthesia generally advocated over general anesthesia to avoid the sympathetic surge of intubation and the negative effects of positive pressure ventilation on the venous return. We utilized a combined spinal epidural technique which allowed for the speed of a spinal block, but with a baby spinal dose of 3 mg bupivacaine to minimize the rapid onset of hypotension and the drop in SVR. This top-up capability via the epidural catheter allowed us to manage the patient. Finally, long-term management of these patients must address the underlying pathophysiology and the future risk as well. So we discharged the patient on the, including the sildenafil and the bosentan, which are the pulmonary vasodilator. We also gave the patient digoxin and the diuretics. And extensive counseling was done of the patient and the husband for the long-term contraception, as pregnancy is absolutely contraindicated in this category by WHO.
1 minute.
So the preferred contraceptives were progestin-only implants, which can be recommended with conjunction of the barrier method, and the estrogens are avoided due to thromboembolism risk. So this is the take-home message, that even in the cases of extreme pulmonary artery hypertension, a placental complication, favorable outcomes are achievable through multidisciplinary approach, as in our case, and meticulous attention to the SVR and the PVR, and right ventricular afterload reduction, titrated regional anesthetic approach. These are the references, and thank you.
Okay. Questions from the judges?
average volume used?
Okay, so the total volume which we used was the 15 ml of 0.25%.
Along with the baby spinal anesthesia.
Yep.
What volume average in your in your patient you used?
Okay, so what we did the spinal, and then after the epidural placement, we gave 3 ml of the 0.25% bupivacaine. Okay, so we gave incremental boluses of 3 ml every 5 minutes. Total volume which was given was around 15 ml the whole procedure, but to achieve the T7 sensitive block, it was 12 ml.
12 ml. Okay, thank you.
Audience.
Are you using this technique regularly in your center?
Yes, in our institute, it is routinely performed the CSC technique in cases of
technique with the baby spinal along with the 0.25%.
Yes.
Okay, thank you.
We use.
My question is what the time you took, because if you are going a full-term patient, what time you will get the full block from the combined spinal epidural to go for the surgery? And one thing I think I did not notice, any pre-management, pulmonary hypertension management was patient was getting?
Yes. So what was done? The patient first came to the OPD. The patient first came at 12 weeks of gestation to the gynecological high-risk OPD. Patient had evaluation, the echo was done, it shows the pulmonary artery hypertension of more than 45 millimeter of mercury at that time, and she was advised the elective termination. But she got lost to follow-up. After 8 weeks, she again visited the OPD with the worsening of the symptoms. So she was admitted to the coronary care unit for the optimization. So on the same day, they started the patient on oxygen, they applied the oxygen, they gave some pulmonary vasodilators IV to minimize the risk, and then they proceeded for the elective termination.
No medical management beforehand? No medical?
Yes, they started some IV medication of, I cannot recall the actual name, but they started, the patient came at, I think, GTN or some infusion, the patients came to the pre-op.
Your time period to maintain a level, what from the dose you have mentioned, total dose 15 ml, but what's the time from the, in case you are going a full-term baby, time is very much important to get an effect. How much
I cannot
how much time to give a spinal to
Sorry,
okay. So the total time duration.
In the interest of time, if you can move forwards and you can discuss it with him afterwards. Thank you.
Thank you.
Thank you. We move to the next presentation. I was initially told that she was not here, but now I've been informed that this presenter is available. So, comparison between the analgesic efficacy of ultrasound-guided transversus abdominis plane block and the direct infiltration of bupivacaine into surgical incision in lower abdominal gynecological surgery. The presentation is by Dr. Bushra Khatoon from Jinnah Hospital, Lahore.
Assalamu alaikum, respected chairperson and dear jury. I am Dr. Bushra Khatoon, postgraduate resident anesthesia, Department of Anaesthesiology, Jinnah Hospital, Lahore, training under the supervision of Professor Dr. Muhammad Ashraf Zia, Head of Anesthesia Department, Jinnah Hospital, Lahore. Today, I am going to present a study on the topic of comparison between the analgesic efficacy of ultrasound-guided transversus abdominis plane block and direct infiltration of bupivacaine into surgical incision in lower abdominal gynecological surgeries. So, starting with the presentation, the lower abdominal gynecological surgeries are associated with significant amount of post-operative pain, which not only delays the recovery process but keeps the patient in the hospital for a longer duration of time. Also, post-operative pain has also been associated with the consumption of larger amount of opioids, which also carries a significant amount of side effects. So, the prime objective of my study is to compare the two regional anesthesia approaches. One is the tab block and other is the local infiltration of the wound site with the local anesthetic agent. So, my study was a randomized controlled trial carried out in Department of Anesthesia, Jinnah Hospital, Lahore during a period of 6 months, during which I calculated a sample size of 60 patients. My inclusion criteria for this study was female patients of age 20 to 60 years with ASA status of 1 to 3 and were scheduled to undergo lower abdominal gynecological surgeries under general anesthesia. My exclusion criteria for this study was patient with liver disease, renal disease, no bleeding disorder and any known allergy to bupivacaine. So, I divided the collected data into two random groups using lottery method by simple random sampling in group A, which carries a total patient of 30. I administered 10 ml of 0.25% bupivacaine under ultrasound guidance just after the induction of general anesthesia before the start of surgical procedure bilaterally with ultrasound guidance. In group B patient, I administered 10 ml of 0.5% bupivacaine directly into the surgical incision site just after the end of the surgical procedure before the reversal of patient and extubation of the patient. So, my both groups were well matched in terms of the baseline demographic and perioperative characteristics, including the age, BMI, operative time, and intraoperative blood loss, showing that the groups were comparable, minimizing the confounding bias. Also, categorical variables were similarly distributed between the groups, supporting the baseline comparability. So the basic study flow of my study is that all the patients were included, and then there were no patients who lost to follow-up or discontinued the intervention. So coming towards the results were assessed basically in terms of time to first rescue analgesia, 24-hour pain scores, and 24-hour opioid consumption. So in group A, that was the tab block group, the time to first rescue analgesia was 367 minutes, while the time to first rescue analgesia in local infiltration group was 250 minutes, showing that tab block extended the analgesia by 2 hours. Similarly, the 24-hour pain scores were significantly less in tab block group when compared to the local infiltration group. Also, the 24-hour opioid consumption was less in tab block when compared to the local infiltration group. All comparisons were statistically significant and the p-value was less than 0.001. So, a comparative data at a glance, simple bar charts showing the comparison of tab block with the local infiltration. Tab block extended the duration of analgesia by 47%, while lowering the pain scores at 24 hours by 49% and 52% reduction in the opioid requirement. So, the basic discussion of my study is that the tab block is superior to the local infiltration of the wound site with local anesthetic that is consistent with the international literature. Also, the tab block performed with ultrasound guidance improved the accuracy of the block placement. Also, it also delays the hospital, it also extended the recovery time, improved the recovery time of the patient and decrease the duration of the hospital stay of the patient. So, just like any other study, this study has also some limitations and future directions. So, the limitation of this study is that is a single center design study that limits the generalizability to other settings. Also, no long-term follow-up was planned for the patient for the chronic pain assessment. Non-opioid analgesic use was not reported in detail, as they may influence the pain scores. Local anesthetic volumes and concentrations were different among two groups. Also, the patient satisfaction and functional recovery was not evaluated. So, the recommendations for future research could be a large multi-center RCTs with larger sample size for great generalizability must be performed, standardized anesthetic protocols across the groups, long-term follow-up to assess the chronic pain development, including the patient satisfaction and functional recoveries as endpoints. Also explore adjuvants like dexamethasone clonidine added to tab block for extended analgesia. Lastly, concluding my study, number 1, tab block ultrasound guided significantly delays time to first rescue analgesia, 367 minutes versus 250 minutes. That gives us the p-value less than 0.001, that is statistically significant. Number 2, tab block reduces the 24-hour pain scores by almost half. Visual analog scale assessment of pain scores in tab block was 3 as compared to the local infiltration group that was 5.9. Then number 3, tab block cuts down the opioid requirement consumption by 52%, 94.5 versus 198 mg. That also proves that the data is statistically significant. Also, the tab block should be integrated into a multimodal analgesia and ERAS pathway for lower abdominal gynecological surgeries. These are the references. Thank you.
Okay, thank you. Questions from the judges. हाँ नहीं डॉक्टर लियाकत, आप लोगों में से जो दोनों ने जजेस ने सवाल नहीं पूछा, कोई पूछना चाहेंगे अभी? नहीं डॉक्टर अमीम आने का, चलें ठीक है डॉक्टर लियाकत, थैंक यू।
आपकी जो डोज सिलेक्शन थी 0.25% बुप्रोफेन 10 ml
जी सर, on each side
जी सर, and local infiltration on 20 ml
sir, 10 ml of 0.5% bupivacaine into directly into surgical site in CN.
So I think there's a difference between the doses
जी sir,
because when in the TAP block you use 20 ml, in local infiltration
yes,
10 ml.
sir.
Was same surgeon or different surgeons? Because infiltration by different people is usually very different effective, my experience.
Sir, it was sir, I assessed the surgical.
जो surgeons जिन्होंने infiltration किया,
जी sir, so that was same.
Same surgeon.
Yes sir.
Okay, that's good. तो क्या reason थी selection आपकी 10 ml की? Because normally around 15 to 20 ml जो है वो TAP block में जो है वो usually देते हैं, वो 10 ml बहुत कम स्टडीज हैं।
Sir, I basically according to analgesic dose that were 0.15% to 0.25%. So that I basically increased the concentration and lowered the volume. So 10 ml of each side of 0.25% bupivacaine I selected on the safer side for as an analgesic technique.
Okay, any questions from the audience? नहीं, if not then judges में से कोई और सवाल पूछना है उनसे? No?
Yes sir, before the start of surgical procedure.
Okay.
Okay, the next presentation is upon the hemodynamic safety of remimazole versus propofol in elderly patients undergoing upper GI endoscopy and colonoscopy, a systematic review and meta-analysis of the randomized control trial. Dr. Umar Iqbal is presenter from Indus Hospital.
Assalamu alaikum, good afternoon everyone. My name is Dr. Umar Iqbal and I am from Anesthesia Department at Indus Hospital, Karachi. Today my topic is systematic review and meta-analysis of randomized control trials. Comparing the hemodynamic safety of remimazolam versus propofol in elderly patients who are undergoing gastrointestinal, endoscopic and colonoscopic procedures. Today we will cover like introduction, methods, results and discussion in this meta-analysis. Coming on to the clinical background, why we choose this topic. Like we already know that elderly patients have reduced cardiovascular reserves and altered drug metabolism, so they are more prone to hypotension and other sedation related adverse events. We commonly use propofol in our daily practices, so that is very commonly causes hypotension and respiratory depression, and more likely 31% in elderly patients. At the same time, the requirement of anesthesia assistance is increasing day by day worldwide. So we used to find a safer strategies that reduce this risk of hypotension and that is hemodynamically stable in patients who are more than 60 years of age. You know, even transient hypotension may be very poorly tolerated in elderly patients with limited physiologic reserves. So why we consider remimazolam? It is a new drug and it is ultra short acting benzodiazepine. It has same mechanism like propofol. It is also a GABA potentiator, but a metabolism is different. It is metabolized by tissue stresses and it is organ independent. All like it is hemodynamically stable, less risk of hypotension, less risk of injection pain and less risk of respiratory depression. But these findings were very inconsistent and show variability between the RCTs. So our pooled analysis was warranted, so we did this meta-analysis. Our primary objective was intraoperative hypotension between two groups. Secondary objectives were bradycardia incidence, respiratory depression, pain while injecting, nausea and vomiting, and time to recovery. Coming on to the methods, we systematically reviewed, two reviewers systematically reviewed the studies across the different databases, and there were 1,291 records identified, and after all this screening process, we fully assessed 16 studies, and after exclusion of 6 studies with a reason, we included 10 high quality RCTs. And throughout this process, any disagreements between the two reviewers were solved by third reviewer arbitration. Our inclusion criteria was very strict. We included only elderly population with broader ASA range, and study design was randomized control trials or cluster RCTs only. Our intervention was Remimazolam, and outcomes we did not include any studies that was not reporting any of the outcome, and we excluded all the studies that was not following our PICO. Also, our study was Prospero registered, and we follow the PRISMA guidelines. Prospero registration is we registered our study at NIH database before the conduction. For a statistical analysis, we use the Raveman software. Random effects model was applied to assess the inter-studies and intra-study variability. We use risk ratio for the dichotomous outcomes and standardized mean difference for the continuous outcomes. P-value where was less than 0.05 was taken statistically significant, and we also did the sensitivity analysis to know the reason of heterogeneity, if any. Also, funnel plot analysis was done to know the publication bias. Here you can appreciate these are the study characteristics and baseline demographics of 10 included studies, with total patients were 1,994 with mean age of 69.1, and male patients percentage were 52.75. Here is the risk of bias assessment. We use the Cochrane collaboration's risk of bias tool, and we can see that there were overall low risk of bias across all 10 domains. That indicates these are high quality evidence based studies that was included in our meta-analysis. Coming on to the mean section results, our primary outcome was hypotension, and Remimazolam was associated with significantly lower incidence of hypotension when compared to propofol across all 10 studies. With risk ratio of 0.48, it was highly statistically significant results. There was moderate heterogeneity, but we did the sensitivity analysis. You can appreciate in this forest plots. The right one is we excluded LEU 2021 study, and our heterogeneity reduced to 36%. So we can appreciate that patients receiving Remimazolam experience nearly half the risk of hypertension when compared to propofol. In our secondary outcomes, bradycardia was 52% lower risk in Remimazolam group. Likewise, respiratory depression 55% lower risk, and also 74% lower risk of injection site pain may be due to the water soluble formation of Remimazolam rather than a lipid emulsion. So there was no significant difference between nausea and vomiting, and all these outcomes were without any delay in recovery. So we can conclude that Remimazolam is associated with improved cardiovascular and respiratory safety without any delay in recovery. Coming on to the comparison with existing literature, we included strictly older populations, not mix the adult and older population due to the biasness. Our study was PRISMA compliant, Prospero registered. We also did the subgroup sensitivity analysis, and we include both inpatient and outpatient. And this shows the better real world applicability. So our findings strengthen both the evidence and supports Remimazolam in elderly population who have cardiovascular limited reserves. Coming on to the clinical applications, it is better hemodynamically stable, reduce respiratory and cardiovascular adverse events without compromising recovery time, and improve patient comfort due to the water soluble formation, and it has a one safety margin of flumazenil reversibility.
1 minute.
If you talk about relevance to Pakistan, propofol still remains most dominant choice due to the familiarity and cost consideration, but Remimazolam could be a valuable alternative for selected high-risk patients in resourceful tertiary care settings and advanced endoscopic settings. These are some strengths and limitations. Our studies include mostly Asian population. That was only a limitation, but we use only RCT evidence-based study. That was our strength, and the population was large. So take-home message is we should consider Remimazolam as a first-line agent for elderly patients who have limited cardiovascular reserves. Thank you. These are some key references. Any questions?
Questions from the judges side?
थैंक यू वेरी मच। जितनी भी आपने स्टडी का एनालिसिस किया उसमें किसी ने एनाल्जीजिया का जिक्र नहीं किया कि एडजुवेंट एनाल्जीजिया भी दिया किसी में कि नहीं?
सर जो हमारे पास RCTs इंक्लूडेड थी उसमें ओपियाइड एडजंक्ट्स यूज हुए थे, एंड दैट मे बी लाइक जो हमारे टाइम टू रिकवरी डिफरेंस था बिटवीन टाइम टू रिकवरी एंड दैट वाज नॉट सिग्निफिकेंट, तो वो मे बी इसी वजह से था कि ओपियाइड एडजंक्ट्स सारी स्टडीज़ में डिफरेंट यूज़ हुए थे, और इसकी वजह से जो है ना हमने, लेकिन हमारा प्राइमरी ऑब्जेक्टिव नहीं था ओपियाइड एडजंक्ट्स का।
लेकिन उसकी रिकवरी पीरियड में आपका क्या ख्याल है कि इन्फ्लुएंस कर सकता है?
यस ऑब्वियसली सर, पब्लिकेशन बायस भी आ सकता है, और उसकी वजह से हमारे पास हेट्रोजिनिटी क्रिएट होती है। हेट्रोजिनिटी जो हमारे पास टाइम टू रिकवरी में आई है वो मे बी डिफरेंट जो क्राइटेरिया हो असेसमेंट के, रिकवरी असेसमेंट के, ओपियाइड एडजंक्ट्स जो हमने यूज़ किए हैं और डिफरेंट प्रोसीजर सेटिंग्स की वजह से जो है ना हेट्रोजिनिटी आ सकती है।
अगर वो इंक्लूड होते तो क्या इसका एनालिसिस बेहतर नहीं हो सकता था?
जी सर, बेहतर हो सकता था, लेकिन उसमें फिर हमारे पास जो RCTs हमने इंक्लूड किए हैं, सब RCTs में डिफरेंट ओपियाइड एडजंक्ट्स यूज़ हुए हैं, तो हम किसी एक ओपियाइड एडजंक्ट को लेके अगर सेम ओपियाइड एडजंक्ट्स होते तो हम उसमें सब ग्रुप एनालिसिस कर सकते थे, लेकिन डिफरेंट के साथ हमारे पास बहुत ज़्यादा बायसनेस और कोई फ़ायदा नहीं होता सर उसका।
I think Dr. Ashraf is pointing towards a limitation of your systematic review, basically.
अभी ऑडियंस से कोई अगर सवाल पूछना चाहे तो, नहीं तो फिर अगर जजेस में से कोई दूसरा क्वेश्चन पूछना चाहे।
Okay. If you have omitted all the analysis which had been used in these researches, systemic analysis, randomized control systemic analysis, so there is no point to compare the recovery time between propofol and remimazole. Is there any significance?
Ma'am, the opioid use in both groups were same. So
you said
in one RCTs, in one RCT, if an opioid maybe like nalbuphine is used with propofol, so same drug is used with remimazolam with same dose.
With same dose.
Yeah.
But if in other group of patients where fentanyl was used or remifentanil was used,
yeah,
then that definitely affects the recovery time, because remifentanil
that's
ultra short acting, fentanyl is the short acting,
yeah,
and nalbuphine has a little bit half-life is more as compared to these two.
It's different opioid adjuncts were used. That's why there is heterogeneity and no significant results in time to recovery, and that was not also our primary outcome.
Okay, thank you. We move to the next presentation, which is efficacy of upper airway angle and glottic height in unanticipated difficult laryngoscopy prediction. Presentation is by Dr. Tasmia Bashir from SIUT.
Okay, Assalamu alaikum. I am Dr. Tasmia Bashir, resident anesthesiologist at Sindh Institute of Urology and Transplantation, Karachi. My paper is on efficacy of upper airway angle and glottic height in unanticipated difficult laryngoscopy prediction. I have no actual or potential conflict of interest in relation to this presentation. Background and rationale. Unanticipated difficult laryngoscopy still occur in up to 17.7% in Pakistan despite the routine assessment. And when failed to predict it, consequences are severe. The traditional bedside tests rely on subjective visual estimation. They suffer from inter-observer variability, which brings us to the gap. We need objective, measurable, reproducible predictor in order to minimize airway-related complication. A study published in Brazilian Journal of Anesthesiology in 2022 introduced 2 new modalities for prediction of difficult laryngoscopy with promising results. So we conducted this study to assess these parameters in our population. Objective anatomical parameters are upper airway angle and glottic height. Upper airway angle is a geometric representation of space available for direct laryngoscopy incorporating mandible and glottic position, taking 60 degrees as a cutoff, less than 60 degrees as difficult laryngoscopy, and more than is easy. And for glottic height, a linear measure reflecting the depth of larynx relative to mandibular baseline, taking less than 3.5 centimeter as an easy laryngoscopy and more than 3.5 centimeter as a difficult. Upper airway angle aligns with radiographic indicator like larynx mandibular angle test. The rationale is based on spatial constraint. Difficult laryngoscopy occur when the oropharyngeal and laryngeal axis cannot be aligned. Upper airway angle and glottic height quantify this constraint. An acute angle restrict alignment, and an high glottic height increase the depth of larynx, making visualization harder. Objective is to determine the diagnostic accuracy of upper airway angle and glottic height to predict the difficult unanticipated endotracheal intubation, taking Cormack-Lehane classification as gold standard. Methodology. This was a prospective cross-sectional study conducted at SIUT over 6 months from August 2025 to January 2026. I used non-probability consecutive sampling of patients scheduled for surgery under general anesthesia. The study was approved by SIUT Ethical Review Committee and CPSP Research Cell. Data collection was done in preoperative holding area and operation theater. We included ASA 1-2 adult, 18 to 80 years of age with adequate mouth opening and modified Mallampati test of 1 and 2, undergoing elective surgery with Macintosh bleed. We excluded patient undergoing rapid sequence induction and patient with altered neck anatomy, trauma, pathology, or condition affecting mouth opening and positioning. After procedure explanation, informed consent was taken in preoperative holding area. Then the patient was taken in supine position, performing an head extension and an upper lip bite test. After making the position, 3 pointers marked: mentum, mandibular angle, and the glottic prominence. After marking, a photograph taken from 30 centimeter away from patient's head, camera positioned at 90 degrees, and the photograph then uploaded in a software where upper airway angle and glottic height was measured. After that, patient moved to OR, underwent normal induction, and after a pre-oxygenation laryngoscopy performed by an anesthetist with minimum 5 years of experience who was blinded to preoperative assessment, and Cormack-Lehane grade was noted. This is how the picture was taken. Note that the pointers were marked after making position. Software which I used was Fiji. You can use any software which can gives you the angle and the length calculation. After uploading in the software, line drawn from mentum to the mandibular angle and from mandibular angle to glottic prominence, giving you an upper airway angle, and for the glottic height, imaginary line drawn taking mandibular angle as a reference, and you draw a perpendicular line till the glottic prominence. Results and discussion. Our study included 150 patients. The population was predominantly middle-aged adult. There were 88 males and 62 females. Regarding ASA, most of the patients were ASA 2. Out of 150 patients, 112 had easy laryngoscopy with Cormack-Lehane grade 1 and 2, and 38 had difficult laryngoscopy with Cormack-Lehane grade 3 and 4. This table compares upper airway angle and glottic height and mandibular length between easy and difficult laryngoscopy group. All 3 variables are statistically significant. For upper airway angle prediction, from 112 patients, 96 patients were correctly predicted as easy laryngoscopy, and out of 38 patients, 28 were correctly predicted as difficult laryngoscopy, showing a negative predictive value of 90.6% and an overall accuracy of 82.7%. For glottic height prediction, from 112 patients, 88 were correctly predicted as easy laryngoscopy, while out of 38, 30 were correctly predicted as a difficult laryngoscopy, giving a negative predictive value of 91.7% and an overall accuracy of 78.7%. A study done in China in 2022, in which they used X-ray to measure laryngomandibular angle test, mimicking the upper airway angle, to predict the difficult laryngoscopy. It shows the sensitivity of 69% and a specificity of 54%, which is less than my study. This shows additional X-rays can be avoided to predict the difficult laryngoscopy, which make my study highly favored in patients whose radiation are contraindicated. Another study done in Iraq in 2021, it investigated traditional bedside tests and their specificity and sensitivity. Although their respective values are more than my upper airway angle and glottic height, but none of them are independent predictor of difficult laryngoscopy.
1 more minute.
Our main limitation are that it's a single center study and the photographic method depends on standardized positioning. The modest positive predictive value means it's best used to rule out difficulty, not to rule it in. To conclude, our photographic measures of upper airway angle and glottic height are non-invasive, easy to perform, can predict difficult laryngoscopy. Both parameters show high negative predictive value. Above 90% means they are useful for ruling out difficulty. I recommend considering these anatomical measurements as an adjunct to standard airway evaluation to improve pre-operative prediction and patient safety. Thank you.
Thank you. Question from the judges?
It's a very good study, and looks like you worked hard to measure for the measurements. My question: how much time did you take to for each patient to assess these measurements? And when you can incorporate your study or this method into your clinical practice, like pre-op assessment and airway assessment in the pre-operative clinic.
Okay, the time was around 2 to 3 minutes if you already know how to assess this software. Like after the practice, it hardly takes 2 to 3 minutes. Like and the measurement, the picture, and if you include the picture and the measurement also, to hardly 5 minutes, not more than that.
5 minutes for each.
Yeah.
Any question from the audience? Right? So if judges has, one of judges has something.
Comparison of your study and the parent study from which you took this idea.
Sorry, sir?
Comparison of results of your study
and
the study in which you took this idea. उनका क्या results उनके भी यहाँ show नहीं हुआ?
Okay, sir, results were comparable. They had for glottic height they had around 99% of sensitivity.
But your was around, I think, 80%.
Yeah, my was around
80%.
Actually, sir, their sample size was larger than mine, and because
what about specificity? They in that study.
It was also high. Both specificity and sensitivity was both high.
Okay, that's good.
In parent study.
Okay, thank you. Okay.
Now the next presentation is comparison of the post-operative analgesic with and without intrathecal dexmedetomidine and bupivacaine subarachnoid block for open reduction in internal fixation of the lower limb fractures at Tertiary Care Hospital, Karachi, a randomized control trial. The presenter is Mohammad Tariq Shamim from the Trauma Center, SMBBIT.
Assalamu alaikum. I am Dr. Mohammad Tariq Shamim from SMBBIT. My study is the comparison of post-operative analgesia with and without intrathecal dexmedetomidine on bupivacaine subarachnoid block for open reduction and internal fixation of lower limb fracture surgery at Tertiary Care Hospital, Karachi. Lumbar subarachnoid anesthesia is used for the open reduction and internal fixation of lower limb fractures. Intrathecal adjuvants like opioids improve anesthesia but have the side effects. Dexmedetomidine is favored for its pain relief and sedative effects. A study showed it provides a better pain relief in femoral fracture surgeries. The rationale of my research is paucity of the local data related to this study. Moreover, it is remain uncertain whether the addition of the low dose dexmedetomidine to bupivacaine could provide satisfactory decrease of pain. This provides me the strong rationale to conduct this study. Furthermore, the result of my study will provide a current and local statistics whether a dexmedetomidine is effective or so can be recommended as a first choice as an adjuvant in bupivacaine subarachnoid block. So, the objective is to compare the post-operative analgesia with and without intrathecal dexmedetomidine or bupivacaine subarachnoid block for open reduction and internal fixation of lower limb fracture surgeries. The study design is randomized controlled trial, and the study was conducted in Shaheed Mohammad Benazir Bhutto Institute of Trauma, Karachi. The duration of surgery is 6 months after approval of IRB, and sampling technique is non-probability sampling. 60 patients was scheduled in this research with 30 in each group fulfilling the inclusion and exclusion criteria. Patient with age of 20 to 60 years with ASA 1 and 2 of either gender coming for the elective surgery or open reduction and internal fixation of lower limb fracture surgeries are included in this research. And the patient with lack of concern, history of inotropic support, and any hypersensitivity to any of the drug in the study used, and contraindication to spinal anesthesia, endocrinological disorders, coagulopathies, patients with the coagulopathies are excluded from this research. Data collection was taken up after approval by the IRB and ethical review committee. Anaesthesiologist was informed, and informed consent was obtained from the patient as well. Patient was preloaded with a 10 to 15 ml per kg saline over 15 minutes before block. 60 patient was divided into 2 groups, 30 in each group. Group D was given 0.5% 3 ml bupivacaine with 7.5 mics dexmedetomidine diluted in 0.3 ml, while the group X was given 0.5% 3 ml hyperbaric bupivacaine with a 0.3 ml normal saline to equivalent the volume. Drug was injected at L3, L4, and L4, L5 levels. The time to achieve the sensory blockade up to the T10 was also noted by the outcome assessor. The patient was briefed about visual analog scale full pain scoring. The visual analog scale score greater than 4 treated with the 5 mg nalbuphine intraoperatively. This is a visual analog scale, and the rescue nalbuphine is used at score 4. SP version 20 is used, and t-test was used to compare the first analgesic requirement between the two groups. P-value of less than 0.05 was taken statistically significant. So this is a demographic characteristic showing the age, weight, sex, and duration of the surgery. And this is a graphical presentation. So the result shows that the time required for first rescue in analgesia in group D was 426.9 minutes, which is much more as compared to the group S, that is 165 minutes. So the p-value is statistically significant, that is 0.001. These are the adverse effect which shows which was seen up to the 12 hour post-operatively. That is, headache is more and less equal in both group, while hypotension, bradycardia and sedation is more in dexmet group. So our studies evaluated the effectiveness of intrathecal dexmedetomidine combined with bupivacaine for postoperative analgesia in lower limb fracture surgery. Result shows that the patient in the dexmet group had a longer time before requesting first analgesia and consumed less total postoperative analgesia compared to the standard group with better patient satisfaction. The finding aligned with the previous researches, which also shows that similar benefit in terms of the sensory and motor duration and time for the first analgesic request. A meta-analysis by the New XY et al. And the study by the Kumar et al. Further confirmed that the dexmedetomidine extends spinal anesthesia and post-operative analgesia with minimal side effect like the hypotension and bradycardia. So, the study has demonstrated that the intrathecal administration of dexmedetomidine combined with the bupivacaine improved the quality of post-operative analgesia, reduced the requirement of post-operative rescue analgesia, and minimal side effects. These are the references. Thank you.
So, questions from the judges side?
इस सारे डाटा में व्हेन यू आर एनालाइजिंग तो किस ग्रुप में हाइपोटेंशन ज़्यादा हुई थी?
जो डेक्समेट वाला सर ग्रुप था उसमें हाइपोटेंशन ज़्यादा हुई थी, ठीक है, एज़ कम्पेयर टू द जो सिंपल हमारा बुपिवाकेन वाला ग्रुप था,
ठीक है,
कंपैरेटिवली. और ये हमारी सेकेंडरी आउटकम था. बेसिकली प्राइमरी जो था वो फर्स्ट रेस्क्यू एनाल्जेसिया था.
पेशेंट मैनेजमेंट तो इम्पॉर्टेंट चीज़ है. क्या आपको हाइपोटेंशन में मैनेज करने के लिए कोई आइनोट्रोपिक सपोर्ट का इन्फ्यूजन देना पड़ा था कि नहीं?
नहीं सर, आइनोट्रोपिक इन्फ्यूजन की नीड नहीं पड़ी थी. बेसिकली इसमें हमने जो है वो फ्लूइड से चैलेंज बोलस दिया था तो उससे ही बेहतर हो गया था पेशेंट.
बट इन आवर पॉपुलेशन देयर इज स्टिल इट नीड्स टू बी स्टडीड. इट काज it needs to be more because the audience may take the message from this. 7.5 microgram cause significant hypotension in the patients.
From the audience, any question? Okay. Dr. Ashok, Mike.
थैंक यू. अच्छा, मेरा ये क्वेश्चन है कि आपने स्टडी में शो किया हुआ है कि आपने नॉर्मल सलाइन यूज़ किया है. एनी स्पेसिफिक रीज़न व्हाई यू हैव यूज्ड नॉर्मल सलाइन इंस्टेड ऑफ रिंगर लैक्टेट? इज देयर एनी इम्पोर्टेंस?
नो सर, बेसिकली क्रिस्टोलाइट हमने यूज़ किया था. क्रिस्टोलाइट में नॉर्मल सलाइन ही हमने यूजुअली प्रेफर किया था पेशेंट में. इसमें बेसिकली रिंगर लैक्टेट है, लेकिन स्टडी में जो हमने नॉर्मली यूज़ किया था वो क्रिस्टोलाइट किया था सर. तो सलाइन मोस्ट फॉर द पेशेंट में मैं सलाइन ही यूज़ किया था मैडम सर. और बाकी सेलेक्टिव जो थे वो उसमें कुछ में हमने रिंगर भी यूज़ किया था. नहीं, क्रिस्टलॉइड यूज़ किया था, प्री लोड किया था हमने उससे.
इनकी स्टडी में नॉर्मल सलाइन यूज़ किया गया है ना?
जी जी सर.
तो कोई स्पेसिफिक रीज़न?
कोई स्पेसिफिक रीज़न नहीं सर.
क्योंकि अब तो ये रिकमेंडेशन है कि आप बैलेंस सॉल्ट सॉल्यूशन यूज़ करें.
जी जी.
तो व्हाई द नॉर्मल सलाइन हैज़ बीन यूज्ड?
इनका कोई स्पेसिफिक रीज़न नहीं था. अल्टीमेटली वो क्रिस्टलॉइड हमने यूज़ किया था.
थैंक यू.
Thank you.
Okay, thank you. We proceed to the next. Thank you. Okay. We proceed to the next presentation. This is evaluating the role of erector spinae plane block in alleviating post-operative pain in laminectomy and discectomy procedures. Dr. Abidur Rahman from Shifa International, Islamabad.
Assalamu alaikum. My name is Dr. Abdur Rahman. I am resident of anesthesia at Shifa International Hospital. Today I am presenting our work on ultrasound guided erector spinae plane block for post-operative pain in patient undergoing laminectomy and discectomy. To begin with the problem, limited lumbar laminectomy and discectomy cause significant post-operative pain. Approximately 1/3 of spinal stenosis patients, and 14% with disc herniation have poorly controlled pain in the first 24 hours. The approach, we are treating the patient post-operatively pain is on opioid-based analgesia, which have drawbacks, meaningful drawbacks, that is dependence, respiratory depression, and constipation. Epidural injection, risk of hematoma and infection, and patient-controlled analgesia, opioid side effect burden. Erector spiny plane block was first described by the Ferrero and colleagues, and it provides the broad paraspinal analgesia by desensitizing primary rami via facial spread of local anesthetic. The gap, however, is that there is no strong RCT evidence in patient with erector spiny plane block undergoing laminectomy and dissectomy. Dissectomy remains limited. That is what our study to set out to address. The objective of my work is to evaluate the effectiveness of ultrasound-guided erector spiny plane block in reducing post-operative pain, rescue analgesia, and opioid consumption in patients undergoing elective lumbar laminectomy and dissectomy compared to IV analgesia alone. The study was randomized controlled trial conducted at Shifa International Hospital from November 2024 to April 2025. And IRB approval was taken. In our study, we enrolled 72 adults, 36 in each group. In group A, the 36 patients received erector spiny plane block with IV standard analgesia. And while in group B, control group, the patient received only IV standard analgesia alone. All the patients were induced by a standard IV anesthetics. For group A, the erector spiny plane block was performed bilaterally after induction and before the surgical incision in the prone position by using a high-frequency linear array ultrasound probe and 100 millimeter needle in plain cephaled to caudal orientation. The target was T12 transverse process. When the bone contact was confirmed, the needle was pulled backward and hydrodissection with normal saline to verify needle placement. And then 20 ml of bupivacaine 0.125% is injected bilaterally. Our primary outcome was the pain score at PACU, first hour, 6 hour, and 24 hour, and secondary outcome was rescue analgesia and opioid consumption and duration of hospital stay. Our study was analyzed by SPSS 27 and T-test and Mann-Whitney test. Before going to the results, both groups were well matched at baseline. There was no statistically significant differences in age, weight, height, BMI, gender, or ASA status. Looking at the pain score, the difference between the groups were consistent and statistically significantly at every point we measured. At first point, the erector spiny plane block group had a mean NRS of 1.39 as compared to group B 3.25, which was increasing consistently, and on 24 hour, the patient receiving erector spiny plane block was having a pain score of 1 as compared to group B having a numeric rating scale pain of 4.53. The rescue analgesia findings are where the difference becomes the most stark. At 1 hour, the total rescue in the patient receiving erector spiny plane block plain block receive a rescue analgesia of 13.9% versus 38.9% in the control group. By 24 hours, only 5.6 of Group A needed rescue analgesia compared to 66.7 in Group B. So overall, 16.7 of erector spiny plain block patients require any rescue analgesia versus 69.4% in controls, a highly significant difference at P equal to 0.005. On total opioid consumption, Group A used a mean of 6.17 milligram analgesia versus 9.6 milligram in Group B, which is not statistically significant. Hospital stay was similar between the two groups, that is 2.5 days in Group A and 2.97 in Group B. So our pain and rescue analgesia findings are consistent with the existing randomized controlled trial literature on erector spiny plain block in lumbar surgery, and our study adds local data to support the evidence base. The 16.7 versus 69.4% rescue analgesia difference is particularly striking and reflects how effectively erector spiny plain block integrates into a multimodal analgesic strategy. On opioids, the numeric reduction in Group A is clinically meaningful, even though statistic significance was not reached, likely due to our sample size. Regarding limitation, our study is single-blinded, and we also did not differentiate the pain in at rest and in a movement position.
1 minute.
So in summary, ultrasound-guided erector spiny plain block significantly reduced postoperative pain and requirement for rescue analgesia in patient undergoing lumbar discectomy and laminectomy. Pain scores were lower at all points. Rescue analgesia was needed by fewer patients in a Group A as compared to Group B. Erector spiny plain block is safe, effective, and reliable addition to multimodal analgesic strategy for spinal surgery, and we believe it merits routine consideration in this patient groups. These are the references I have taken, and thank you.
Thank you. Any questions from the judges?
अच्छा, आपने मेंशन किया कि कोई रेंडमाइज कंट्रोल ट्रायल्स नहीं है. आई थिंक इरेक्टर स्पाइनी पे लैमिनेक्टमी के ऊपर फ्यू रेंडमाइज कंट्रोल ट्रायल्स हैं ऑलरेडी.
जी सर.
दूसरा मेरा पॉइंट था कि जब आपने सेलेक्ट किया ये टॉपिक, आई थिंक वन ऑफ द वंडरफुल टॉपिक एंड very good idea. Giving a control group only nalbuphine as an analgesia and not including NSAIDs or local infiltration.
पैरासीटामोल ऑन इंडक्शन ड्यूरिंग सर्जरी हमने दोनों पेशेंट्स को दिए थे, और आफ्टर उसमें रेस्क्यू एनाल्जेसिया हम लोगों ने नेल्बिन रखी थी.
नहीं, बेसिकली जब आप इस जो सर्जरी जिसमें हाई एनाल्जेसिया रिक्वायर्ड है, पेन बहुत ज़्यादा होती है, तो उसमें मल्टीमोडल के तौर पर आपके NSAIDs भी हैं. उसके बाद फिर जो कंट्रोल ग्रुप है उसमें, क्योंकि उसमें लोकल इन्फिल्ट्रेशन भी नहीं है, तो इसलिए इतना ह्यूज डिफरेंस आ रहा है ग्रुप के साथ. तो अगर आप कुछ बाकी ट्रायल्स देखेंगे तो उसमें मेजॉरिटी में लोकल इन्फिल्ट्रेशन एडेड है व्हेन यू कंपेयर विद इरेक्टर स्पाइन. तो जस्ट एज ए सजेशन कि जब हम ट्रायल करते हैं तो जो कंट्रोल ग्रुप है उसको इतना वीक ना रखें. इट शुड बी स्ट्रॉन्गर कि उसका एनाल्जेसिया इतना रीजनेबल हो कि हम एक्चुअली डिफरेंशिएट कर सकें उसमें. थैंक यू वेरी मच.
Any question from the audience? इधर दीजिएगा.
What was the level at which the laminectomy was performed? Your block was performed at the
lumbar region.
Lumbar region from D12 onwards. All is everything is the lumbar region. Was it L4, L5, L5S1?
स्पेसिफिकली हम लोगों ने L4, L5 नहीं लिया था. L1 से L5 तक जो भी पोजीशन होती हम उस पे लगाते और वो सेफेल्ट से कोडली स्प्रेड होती है.
The difference of analgesia would be stark for rectospinal plane block given at T12 for L1, L2 surgery as compared to L4, L5 surgery?
दोनों में डिफरेंस हमें कोई नहीं महसूस हुई क्योंकि हमने L2, L3 के प्रोसीजर में भी लगाया, L4, L5 पे भी, तो वो हमारा जो एसेसर था वो उनसे पूछने के लिए जाता था। पहले पाकू में होते, फिर फर्स्ट आवर, फिर 6 आवर, 24 आवर, वो उनसे पूछते थे।
Okay.
Okay, thank you.
Now we are moving to the next and last presentation of this session. Topic is effectiveness of different peri-op-analgesic regime on treating post-operative pain after knee arthroplasty at a tertiary care of a low to middle income country. The presenter is Dr. Mohammad Darab.
Assalamu alaikum. This is Dr. Mohammad Darab. I am from Aga Khan University Hospital. So my topic today is perioperative analgesia regimens in total knee arthroplasty patients. This is a quasi-experimental study evaluating multimodal pain management effectiveness at Aga Khan University Hospital. So to begin with, why this study? So there are several studies done on total knee replacement patients, and one recent study showed that these total knee replacement patients do have persistent post-surgical pain. One of the studies done at Aga Khan showed that 15.8% of the patients reported persistent pain 3 months after total knee replacement. So a little bit of background and rationale. So total knee arthroplasty has an 80 to 90% success rate, yet up to 30% of the patients remain dissatisfied, largely due to inadequate post-operative pain control. Effective pain management promotes early recovery, reduces hospital stays, and lowers the readmission rate, and also prevent complications such as DVT and chronic pain. To determine, my study goal was to determine the effectiveness of different perioperative analgesia regimens and lay a foundation for standardized pain management guidelines after total knee arthroplasty in a low to middle income country. So primary objective was to determine the effectiveness of different perioperative analgesia regimens in treating post-operative pain at 24 hours and 48 hours after total knee arthroplasty at tertiary care hospital. And the secondary objective was to determine the relationship between pain scores at 24 and 48 hours and different demographic variables like age, gender, ASA status, hypertension, diabetes, and the laterality of TKR. So the study design was, it was basically a quasi-experimental study in which no intervention was done. We observed around 184 patients. The study was conducted from January to December 2025. Sample size was 184, calculated by WHO. We used different multimodal intraoperative agents, and we actually checked the efficacy of these drugs at 24 hours and 48 hours, determining on the basis of the pain scores. So pain assessment was done on numerical rating scale and it was divided into mild, moderate, and severe, and it was done at 24 hours and 48 hours, and static pain and dynamic pain both were asked from the patients. So a little bit about patient enrollment and exclusion. So we had 184 patients, ASA class 2 and 3 were only taken, and patients from age 18 to 80 were included. Exclusions include redo TKR and patients at the extremes of ASA or like ASA 4 and above, and patients with on the extremes of age were also excluded. So statistical analysis was done using SPSS with chi-square and Fisher test. Demographics include 184 total patients. Out of these, 77.7% were female, 65 was the mean age, and 87% was overweight. Key comorbidities में hypertension 70% लोगों को था, diabetes was around 36.4%, ASA class 2 was predominant, and laterality में अगर हम देखें तो bilateral ज़्यादा common है, 69.6%, and general anesthesia was given to around 95.7% of the patients. So this is a chart showing कि कितने लोगों को जनरल एनेस्थीसिया मिला, और हमारे रीजनल प्योर रीजनल में we had only 2.7% of the patients, and there were some patients who received general plus an epidural, so this was around 1.6%. So mainly general ही है, and then the results are primarily based on general में use हुए हुए जो drugs हैं उन पे. So analgesia regimens पे अगर हम बात करें, so primary drugs were 3. Morphine, nalbuphine, and fentanyl. Around 60% of the patients received morphine, 25% received fentanyl, and 15% received nalbuphine. Secondary were NSAIDs, dexmedetomidine, and acetaminophen. So local infiltration was done in around 75% of the patients. Post-operative core regime included acetaminophen was universal. It was received in all patients. NSAIDs was received in almost 98.4% of the patients. Nalbuphine was continued either as infusion or intermittent nalbuphine boluses, but it was given in around 91% of the patients. It was variable depending upon the surgeon, कि कुछ surgeons चलाते हैं कुछ नहीं, तो हमने वो observe किया and we found that 91% patients nalbuphine receive कर रहे थे. Tramadol 22.3%. Rescue analgesia required in only 37 patients, 20.1%. Most often tramadol use किया गया था rescue में, and rescue का criteria ये था कि जिन patients ने report किया था PACU में moderate pain, तो फिर हम उनको rescue दे रहे थे. Acha, so what were the pain outcomes, static versus dynamic? If we found that static rest pain, 24 hours में around 89% of the patients had mild pain, and 48 hours पे 98.9% had mild pain. And dynamic की अगर हम बात करें तो 24 hours में 83.7% had moderate pain, and this was very much improved at 48 hours. Moderate से वो mild में convert हो गया था at 48 hours. So static pain was consistently well controlled, but dynamic pain was more challenging at 24 hours, but improved markedly by 48 hours, with severe pain resolving completely at 48 hours. 0% ever. Pain trajectory अगर हम देखें तो dynamic pain is the primary challenge. Moderate pain affects 82 to 88% of the patients, and 48 hours में हमें clear improvement मिली. Static pain is nearly resolved and dynamic pain shift हो गया था mild की तरफ. So I'll talk about the intraoperative agent efficacy and significance क्या रही हमारे पास अलग अलग drugs की. So there were a lot of drugs and we had to calculate we had to do a lot of analysis, सबका separate. So what we found out is that fentanyl, those patients who received fentanyl intraoperative had greater element of moderate pain at 24 hours and static pain. यानी 24 hours पे जब उनसे static pain का पूछा गया तो उनमें ज़्यादा pain था as compared to other drugs, morphine and nalbuphine. And nalbuphine पे 24 hours पे dynamic element में अच्छा response था, यानी 0 severe pain cases थे, और इसके साथ साथ जिन पेशेंट्स को इंट्राऑपरेटिव नाल्बुफिन मिली थी एंड नाल्बुफिन कंटिन्यूड रही थी उनको 24 आवर्स पे डायनामिक एलिमेंट में सिग्निफिकेंट पी वैल्यू मिली है.
1 minute.
एनसिड्स में 48 आवर्स में डायनामिक पेन में इम्प्रूवमेंट थी, यानी जिन पेशेंट्स को एनसिड्स कंटिन्यू था उनको इम्प्रूवमेंट मिली. So अगर हम सेकेंडरी की बात करें तो सिग्निफिकेंट फाइंडिंग्स में यूनिलैटरल TKR हैड सिग्निफिकेंट लोअर स्टैटिक पेन एट 24 आवर्स, और जो बाकी वेरिएबल्स थे लाइक जेंडर, एज, ASA, हाइपरटेंशन, दे हैड नो सिग्निफिकेंट एसोसिएशन विद पेन सिवियरिटी एट ईदर पॉइंट. सो स्टैटिक पेन कंट्रोल वाज नियरली यूनिवर्सल अक्रॉस ऑल सब ग्रुप्स. सो व्हाट वी ड्राइव इज, अगर हम मल्टीमोडल अप्रोच की बात करें तो पेसियस एट ऑल फाउंड दैट प्रीएम्प्टिव एसिटामिनोफेन, सालिकॉक्सिबिन, गाबापेंटिन reduce pain scores and opioid requirements, which is consistent with our findings that if we continue with acetaminophen, NSAIDs and nalbuphine, the results are good on our side. Epidural, once a standard for TKA, suffers from delayed ambulation. Multiple RCCs found no significant difference between epidural and peripheral nerve blocks up to 48 hours post surgery, although we did not have any patient for the thing. So I'm just concluding it. So we wanted to have LMIC relevance, where standardized multimodal strategies can enhance recovery and outcomes even in resource limited settings, supporting the guidelines for TKA pain management. Thank you.
Thank you.
Now the questions from the judges side.
Did your patients receive preemptive analgesia?
Yes, all of them had received gabapentin, so I have not added it separately क्योंकि gabapentin सबको ही मिला था, तो वो उससे results में कोई change नहीं आएगा.
In your results, the pain, zero pain on dynamic.
Yes.
On dynamic pain was relieved by King's infusion.
Yes,
Or
either
ventilated
KINS
infusion.
infusion or KINS at intermittent boluses.
Intermittent.
Those who were continued with this had zero pain at dynamic
What was the
element.
dose given during with infusion and per kg body weight
Yes.
or?
So infusion was continued as 1 mg per hour by the primary team. That is the standard practice being done by one consultant at our setup. And the bolus doses were 0.1 mg per kg as the standard bolus.
Okay, question from audience side. Okay.
Okay,
Thank you very much.
Thank you. Okay, with this presentation, we come to the end of this session of residents' presentations. We've had 12 very good presentations, and I must say that the quality of presentations has significantly improved if we see the last couple of years. But I'm just going to point out one thing, especially for the presenters. More than 50% were RCTs, but those who just presented the p-value. None of the presenters gave confidence intervals for their results. And I will tell you that you will have difficulty in your publications if you want to send your studies to international journals. They will not publish it without the confidence intervals. Thank you. So we are going to continue with thank you very much to the 4 judges. We are going to continue with the next session, which is the Faculty Research Showcase. I've just had a shock. I was asked to continue with both of us to continue chairing the session. I was not aware of this, but the judges are going to change. So I'm going to call the judges for this next session. The judges are Dr. Zahid Akhtar Rao from Fazaya Medical College, Dr. Khalid Samad from Aga Khan University, and Dr. Nigat Abbas from LNH. If the judges can come to the front, please.
बैठ जाए बैठ गए
नहीं बस बैठ ही गए हैं बुला मैं कर दूं या आप करेंगे पहला नहीं है शायद
फर्स्ट नहीं है Now we are starting the section from the first presentation, the efficacy of airway pressure release ventilation versus conventional ventilation methods for the acute respiratory distress syndrome. It is a systematic review and meta-analysis which will be presented by Dr. Rabia, Dow University, from Dow University.
Assalamu alaikum. I am Dr. Rabia Kamal from Civil Hospital Karachi, Dow University of Health Sciences. My topic of study is technically an updated meta-analysis and systemic review of randomized controlled trials that compared efficacy of APRV mode versus traditional ventilatory modes. As you can see that ARDS poses a great challenge to intensivists while ventilating the patient, not maintaining saturation, increasing NORAD support, inotropic supports. Here's the data. It's a CDC wonder-based data comprising US population. As you can see, the 2019 and 2020 data that was attributable to COVID-19 patients, there was significant mortality trends for ARDS patients in intensive care unit. It poses a great challenge while ventilating ARDS patient, like there is a mechanical stress due to ventilatory modes, positive pressure ventilation, risk of lung injury, hemodynamic impact as decreased intrathoracic pressure, decreased venous return. In this scenario, airway pressure release ventilation can be a promising mode for ARDS as it ventilates the patient on continuous positive airway pressure ventilation with a brief release of pressure for exhalation of CO2. There are T high time for inspiration and T low and P low. As you can see that, moreover that this mode allows the patient for spontaneous breathing. That can be a better hemodynamic parameter, like it preserves the diaphragmatic tone and decreased sedation requirement. As you can see that. Moreover, the recruitment strategy in APR mode is continuously on a positive airway pressure ventilation, and the inverse ratio is basically 6:1, 4:1, and brief periods of pressure release for CO2 exhalation. So the research question is, does APRV is going to offer a superior clinical and physiological outcomes in ARDS in comparison to the traditional modes? So the study design was RCTs. Initially it was six RCTs till 2019 October, and we had included 4 RCTs that was attributable to COVID-19 patients, ARDS, secondary to COVID-19 patient. So search strategy was in the PubMed, MBES, Cochrane Library, and we included trials till July 2024. Inclusion criteria and the PICA of the study was that we included randomized controlled trials. The intervention was APRV mode, and the control was traditional modes, and the population was ARDS. Outcome I will discuss later. Exclusion, we excluded pediatric population, obstetrics population, all observational studies, abstracts, case reports. Here is the main primary outcome about my study. It was ICU mortality. And rest of the outcomes were oxygenation index, peak airway pressure, ICU length of stay, hospital length of stay. And here you can see that the prisma flow diagrams for my updated meta-analysis. Initial studies were 6, and we updated with the COVID-19 patients with the 4 RCTs. We ended up with the 10 RCTs. Here are the study characteristics. As you can see that baseline parameters of our study, and there are the outcome variables. As you can appreciate, the risk of bias assessment was done with ROB tool for clinical trials, and there was a overall high risk 10% that was attributable to the bias in reported outcomes, and the 40% low overall risk. Regarding analysis, we used Review Manager 5.2, and heterogeneity was defined as greater than 50% and is evaluated with chi-square test, and random effect model was used. As you can see that, sorry, mortality analysis, there was no significant difference between the 2 groups, so there was no survival benefit. Regarding PO2-FiO2 ratio, there was a paradoxical result. In APRV, despite this increased inspiration time, there was decreased PO2-FiO2 ratio, so that needs to be evaluated. P-peak analysis, as you can see that it favors APRV. APRV had a lower P-peak pressures and the P-mean pressures. It's same for the ICU stay length and the number of ventilation days. What we did was, if the heterogeneity was greater than 50%, we evaluated for the cause and did the sensitivity analysis. As you can see, we have mentioned heterogeneity after sensitivity analysis, and it was still significant. This heterogeneity was attributable to the population because ARDS secondary to CABG surgeries or sepsis, ARDS secondary to sepsis or COVID-19 patient. That might be the cause of this heterogeneity. As you can see that there was we assessed for publication bias. There was a slight deviation, so there is a publication bias in our updated meta-analysis. Here are the final results. APRV has reduced peak airway pressure that might be statistically significant but has no role in clinical settings. ICU length of stay was decreased by 0.92 days. That might be related to better turnover, you can say that the better cost-effective solutions. And the mechanical ventilation might be attributable to the spontaneous breathing because it needs lesser muscle relaxation and sedation and the faster weaning. About the oxygenation index, I have told earlier that it has a paradoxical finding that might be statistically significant, but it's not. It has no role in clinical significance because of 6.99% of FiO2 increase FiO2 PO2 FiO2 ratio. Mortality was not significant, and there was no survival benefit. Clinical advantages was APRV mode, there was reduced ventilatory days, decreased hospital stay, but there was no mortality benefit. It can be the reason because mortality is just not attributable to ARDS because there are multi-organ failures and it could be the reason of mortality. But there are better cost-effective solutions in APRV group. Key takeaways. Key takeaways are it decreases mechanical ventilation day, ICU hospital stay, ICU stay, and there is a need to evaluate why this exists despite their increased inspiratory time and continuous positive airway pressure, as the oxygenation index was paradoxically lower in APRV group. As I have told you earlier, there was no survival benefit. Now come towards the main point, what might be the cause of this. Our RCTs had a population that ARDS secondary to sepsis, ARDS secondary to post cardiopulmonary bypass grafting, and ARDS secondary to COVID patients. So further RCTs, randomized controlled trials should homogeneously evaluate this. Long-term outcomes, further trials should evaluate post-ICU outcomes like what is the quality of life about the pulmonary function test. Future protocol optimization.
If you can conclude, please.
Yeah, I'm concluding. So protocol optimization, in all our RCTs, there were different settings of APRV mode. So standardized protocol should be instituted in further trials. Here is my summary of meta-analysis. As you can see that no mortality benefit, but there was significant reduction in ICU and ventilation days. I just want to add one more thing.
Sorry, that is question time. So if you can conclude.
Thank you so much. Any questions would be highly appreciated.
What was the
now questions from the judges side?
What was the percentage of survivors from ICU?
From IC?
Yes. The patients you were treating, what was the percentage of survival?
It was 35% survival in the combined effect. Actually, where we made the forest plot and the mortality was not significant in both groups because the confidence interval was 0.99, something like that.
We will have one question from the judges and one question from the audience.
Now, one question from the audience, if anybody can ask.
If not,
okay, so you have come with the research question. So, what do you think when you are doing this meta-analysis? What comes to your mind? What you want to look at? Because this similar meta-analysis has already been done in 2021 with the similar findings.
Yeah.
So, what did you find different in this?
I updated the 2021 meta-analysis.
Okay.
Okay, so that included October 2019 RCTs, and I included COVID-19 patients. So my analysis is since inception till 2024 July.
Okay. Thank
you. This has a COVID data as well about the ARDS.
Okay. Thank you.
Thank you. Okay, thank you very much. Okay.
Thank you so much.
Our next presentation is the evolution of airway management from bedside clinical assessment to artificial intelligence-driven prediction. The presenter is Dr. Rao Numan from Patel Hospital.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Rao Numan and I am Senior Registrar in Patel Hospital. The topic of my presentation is evolution of airway management from bedside clinical assessment to AI-driven prediction. So this slides represent the overview of my presentation. We know that bedside clinical methods which are used to assess the airway, they are not 100% accurate, and that leads to failure in identifying unanticipated airway, which could be difficult at times. So, and they are also physician dependent. So that can lead to adverse outcome as well. Therefore, there comes the role of the AI, which is a tool that is used as an adjunct, and these algorithms help in assessment and management, identifying and managing the difficult airway. We know the core problem in anesthesia, that these traditional methods, these tools which we use, such as mouth examination, neck examination, they are not 100% accurate, and they are physician dependent, and that can lead to underestimation or overestimation of the airway. Therefore, that reflects the clinical consequence. If we overestimate or underestimate the difficult airway, it can lead to severe adverse outcomes such as unanticipated hypoxemia and permanent CNS damage, and that was reflected in this INTUBE study, which was a multi-central study that was conducted. Therefore, there are strict ASIC guidelines that demand a multimodal appraisal. So what we did a literature research. We conducted an extensive narrative literature review. We analyzed the recent machine learning data, deep learning and computer vision, and we assessed the advanced facial images analytics, and we concluded that AI strongly improves difficult intubation prediction, but it must remain as an adjunct, and it never replaces a physician or an experienced anesthesiologist. So the aim of the study was to evaluate the AI in difficult airway prediction, assess machine learning prognostic accuracy, and identify the practice on isolated clinical judgment and reduce the reliance on isolated clinical judgments. So we searched on PubMed and Scopus and different sources, and we targeted the keywords that were combined in airway. We use the broad airway terms, and we use the AI terms, and we filter out those researches, and we focus on those researches which were recent and within 5 to 6 years. We focus on that data publication, and we evaluated the AI algorithm against the traditional prognostic benchmarks. So the methodology that was used was we deep searched and look out for these machine learning, deep learning, and we combined both of these terms with the airway management and difficult airway, and we examined the recurring limitations in the existing literature, and we evaluated the algorithm against the traditional clinical benchmark. So the results were, जो machine learning performance थी हमारे पास, it dramatically enhances the first pass intubation, and deep learning accurately anticipate the difficult direct laryngoscopy, and the algorithm combination elevate the prediction in the thyroid patients. और ये जो मशीन लर्निंग हमारे पास टूल है, इसमें अच्छी बात ये है कि कैन एक्सट्रैक्ट द हेट्रोजेनस मल्टीमोडल डाटा सेट्स, जो बहुत सारी आप इंफॉर्मेशन कंबाइन करके दें, उसमें से उस इंफॉर्मेशन को एक्सट्रैक्ट करने की इसमें बहुत अच्छी जो है वो सलाहियत मौजूद है. Similarly, we analyzed the facial image prediction, in which different photographs of patients were taken in perioperative period. It offers a rapid, non-invasive airway screening outside the OR, and deep learning successfully anticipate the difficult video laryngoscopy. Similarly, we can use the imaging, the POCUS, ultrasound, and computer vision. It automates precise dynamic vocal fold movement tracking, and it evaluates detailed dynamic airway related structure. And these processes those variables which are vastly beyond human bedside capability. So it is a highly effective for identifying complex patient anatomies. So this leads us to combine the superiority of the AI synthesis. What we emphasize is that there should be a AI synthesizer framework in which there should be a combination of clinical demographic, the preoperative photographs, and high resolution imaging, and all of that combined in the perioperative period to increase the chances of successful intubation. So the multimodal shifts render single source tool insufficient. It fuses the symptomatological evolution with morphological analysis. It produces significantly stronger and unified prediction, and it identifies risk pattern invisible during standard physical examinations. So AI has been used in X-ray for difficult airway assessment, such as Harris et al. He made a machine learning model which localized the ETT and can identify using this tool the malposition and how much tube should be placed so that it could be in the exact position and there is less chances of endobronchial intubation. Similarly, AI can be used in CT identification. Han et al. Use a 3D dimensional model for reconstruction of difficult airway that was tailored to a patient's airway characteristic. Similarly, Graham et al. जो है उन्होंने difficult airway को predict किया in nasal intubation, and the author found that a nasal diameter of less than 6.3 millimeter can indicate nasal intubation difficulty. Similarly, by using MRI scan of cervical vertebra, AI can predict difficult laryngoscopy and the anatomical position of the vocal cord. And the facial imaging that was discussed earlier, that taking photographs of the patient the perioperative period from different angles, it helps the AI to automate the method for difficult airway prediction. But here comes the limitation of the AI. It is a black box problem that we don't know. It is not actually a transparent data. We don't know the data which we are feeding in, how the AI is actually evaluating that, and how it is labeling the airway as a difficult airway. So there should be transparency and explainable AI, so that it would be questioned and it could be made more efficient by learning that which algorithm and which data it is being used by the AI to label the patient's airway as a difficult
One
airway.
more minute.
Similarly, the limitations more that there are limited data available, the ethnicity, the globalization, the labeling of the data, these are all the concerns and all the limitations in these studies. Similarly, the clinical implication for Pakistan, if we can introduce this method, these AI tool for the assessment of airway in the Pakistani healthcare system, it could be a crucial preoperative tool for high-risk head and neck surgeries, predict extubation failure beyond standard clinical judgment, but it requires a training and a good integrated system that could be introduced in our IT and hospital care systems. So this summarizes the limitation and the barriers of the AI. The studies that were included, most of them were retrospective, sample size was small, there was non-standardization imaging protocol. Similarly, how would we introduce this to the IT system, and data privacy is also very important in terms of that. So in conclusion, artificial intelligence analyzes, integrate multimodal airway data to reveal invisible risk pattern, augmenting but never replacing the clinical expertise, significantly elevates patient safety in high-risk setting, and demand robust clinical validation before routine deployment. These are the references which were analyzed for this study.
Thank you. Question from the judges?
Thank you very much. To evaluate using AI,
yes,
you have to feed back all these imaging, X-ray, CT scan and MRI.
Yes, sir.
It is very difficult to provide all these things in, how will you manage
इसमें सब बेसिकली जो स्टडीज़ हुई हुई हैं उसके अंदर ये कि डिफरेंट टूल्स को यूज़ किया है डिफरेंट लोगों ने डिफरेंट स्टडीज़ में. किसी ने CT स्कैन को यूज़ किया है, किसी ने एक्सरे को यूज़ किया है, किसी ने MRI को यूज़ किया है, किसी ने सिर्फ विजुअल फोटोग्राफी को यूज़ किया है. जी सर, फिर वो स्टडी करके उसको डाटा फीड करके बेसिकली मशीन लर्निंग का प्रोसेस है कि आप जो डाटा फीड करते हैं और फिर मशीन विद द पैसेज ऑफ टाइम उसको लर्न करती है, और फिर हमारे डेमोग्राफिक, हमारे एथनिसिटी, डिपेंडिंग ऑन द एरिया वी आर ऑपरेटिंग इन, उसके हिसाब से फिर AI जो है वो मॉडल प्रेजेंट कर दिए कि ये डिफ़िकल्टी हो सकती है. तो ये काम को
मेरा क्वेश्चन ये है कि आपको हर पेशेंट का, उस पर्टिकुलर पेशेंट का ये डाटा सारा
इनिशियली डाटा डालना पड़ेगा सर. एग्जैक्टली, इनिशियली डालना पड़ेगा. बाद में जब एल्गोरिथम इस्टेब्लिश हो जाए तो फिर काम हमारे लिए आसान हो जाएगा कि डाटा इतना जब अमाउंट में फीड हो जाएगा कि मशीन के पास ये एबिलिटी है कि वो बाद में जो है.
पूछना चाह रहे हैं रिसोर्स लिमिटेड सेटिंग में, जहाँ पे रिसोर्स लिमिटेड है, जहाँ पे MRI CT स्कैन इज वेरी एक्सपेंसिव, पेशेंट को पे करना पड़ता है, उस सेटिंग में हाउ इट इज़ एप्लीकेबल एक्चुअली?
सर जैसे ऑलरेडी यहाँ पे रिसर्चेज हो रही हैं, अगर एल्गोरिथम बाहर इस्टेब्लिश हो जाते हैं, लेकिन जो बाहर भी एल्गोरिथम इस्टेब्लिश हुए हैं उनको हम यहाँ पे अपने हिसाब से यूज़ नहीं कर सकते. जैसे हमारे यहाँ जो एथनिसिटी है और हमारे यहाँ जो डेमोग्राफिक डाटा है वो डिफरेंट एज़ कम्पेयर टू यूरोपियन साइड या वर्ल्ड वाइड, जिसको आप कंपेयर करें. तो यही लिमिटेशन यहाँ पे नज़र आ रही है कि वहाँ के BMI, वहाँ के पेशेंट का जो स्ट्रक्चर है वो डिफरेंट हो सकता है, एयरवे इन टर्म्स ऑफ ओबेसिटी लेवल डिफरेंट हो सकता है, हमारे उसमें डिफरेंट हो सकता है. तो अगर हम यहाँ पे वर्कअप करें, इसके ऊपर टेक्नोलॉजी को इंटीग्रेट करने की कोशिश करें और अपने सिस्टम को बिल्डअप करें, तो ये एक जो है वो वे फॉरवर्ड हो सकता है.
In the interest of time, we'll move forward. Thank you very much.
Thank you so much.
Now we are proceeding to the next presentation. Topic is enhancing the fiber optic intubation training with innovative, cost-effective simulation in a developing country. Dr. Faisal Shamim will present.
Thank you so much, PSA Organizing Committee and Scientific Committee, for giving me this opportunity. Not a research, just an innovative solution for the training of fiber optic intubation. So, no conflicts to declare. We all know that fiber optic intubation is gold standard in airway management, and the ability to perform this procedure competently is basically essential for patient safety and anesthetic management. Now, the important is that this needs a mastery of the technique, and it requires the integration of complex psychomotor skills, which includes precise manipulation of the flexible bronchoscope, effective visuospatial orientation within the airway, coordinated hand-eye control while interpreting a two-dimensional video display to execute accurate three-dimensional movements. Now, in the developing world, in the developed world, there are now doing a VR training. They have already a very famous ORSIM bronchoscopy simulator, which is very good for training of fiber optic intubation. But these are called high fidelity simulators, and there are low fidelity simulators in which there are inbuilt solutions like making the anesthetic circuits, different joints, and then do the Oxford box, which has been made by the Oxford Department of Anesthesia way in about early 2000. So we all know that simulation based training has therefore become an important for teaching fiber optic intubation. The problem and the challenge is, again, as we are lying in this part of the world, the low and middle income country, the high fidelity simulators are often expensive and require specialized infrastructure, limiting availability, where financial constraints and logical barriers restrict access to simulation based airway teaching. So solution is to develop a low cost task trainer, and it is inspired by the Oxford fiber optic teaching box. So from the Department of Anaesthesiology and the team from the Center of Innovation in Medical Education, we give this concept to the team in CIME, and then we assess and how we can develop a low-cost trainer to assess the utility of a low-cost simulator in helping anesthesiology residents achieve the psychomotor skills required for fiber optic intubation, and to determine the technical precision and educational efficacy for skill acquisition. So for the material and methods, or for the development process, we have first concept, literature review, design and development framework, then we jot down the intended use, definition of user requirements, conceptual design and digital modeling, detailed design and fabrication, component verification and iterative testing, user acceptance testing, and cost and production analysis. So the development process is about modified V model for systematic design, testing, and user verification. The material used is acrylic tensile strength, and the benefit is robust, lightweight, and it has a resistant versus glass. So this is the iterative design and user feedback. We did process multiple prototyping cycles with the anesthesia faculty. Then feedback focus is hole size, shape, plate spacing, and clinical realism. Outcome is the unique hole patterns for novice to expert training, enhanced usability. So, verification and testing of this fiber optic intubation simulator component, acrylic navigation plates with drilled holes, then sequential plate configuration, then color coded plate system, transparent acrylic walls, scope entry port, structured ability of simulator box, integrated navigation task, and then user acceptance during pilot workshop. So this is the final product which we have made. We in parallel to, or like the Oxford intubation box, which has been termed as a low fidelity simulator. So we did in 2 fiber optic workshops in 2024 and 25, 13 anesthesiology residents have been attended a 2-hour workshop training session on fiber optic intubation, and in which our low-cost simulator was pilot tested. The trainee feedback, we did survey and we take feedback. We provided them a feedback form, and in which they real life resemblance, hand-eye coordination, and overall experience is above 4. So in conclusion, the IntuBox or the fiber optic IntuBox represents a low-cost, purpose-driven fiber optic intubation training simulator developed using a structured design framework. Such innovations may help expand access to procedural training and support safer clinical practice. The Oxford intubation box is currently not very much available, but when it was available and when we designed, it was about 550 to 600 pounds. And what we did, we developed this in 80 pounds, like 30,000 Pak rupees. So that's the huge difference. This is the low fidelity simulator. As we are moving forward, we are advancing towards high fidelity simulators. I am sure in the coming era, we will be having some high fidelity simulators in our country as well. Thank you so much.
Questions from the judges' side?
So basically, this is a simulation जो कि आप directly सिखा रहे हैं the technique.
Exactly.
But in real time, there are other multiple factors which are involved.
Multiple factors
which are involved. So how you will incorporate these into this system?
So
if you are just doing the
what one plan we can do is that we can put this box in our operating room complex, and before actual fiber optic intubation on a patient, we can ask our trainee to do a simulation or to do a hand-eye coordination, and a main thing which you require is a manipulation in the airway. So the box, so they can do a simulation on the box, and then they can be given a real hands-on or real fiber optic intubation on a patient, and we can then compare that how did they perform after performing on the box, and then how did they perform actual fiber optic intubation in a patient who is a predicted difficult airway.
Question from the audience? Okay. Mike.
The training you did on this simulator, that the level of the trainees, they are either they are practicing fiber optic or they are the novice trainees.
So this workshop has been, we are doing a fiber optic intubation workshop for our year 4 and year 3 residents. So every year they have this is a mandatory curriculum based design workshop in which this simulator, we use 4 simulators, different kind of simulators. One is we have a bronchoscopy simulator, one is this IntuBox, one is intubation on a mannequin, and other is also a low fidelity simulator. So they are the level of R3 and R4. Trainee 3 and trainee 4 for FCPS level.
Their real-time experience is their pre-hand fiber optic.
They are also doing in their ENT rotations. Second year is doing an ENT rotation in which they will get 1 or 2 experience, and then in the year 3 and year 4 they are doing under the supervision of consultant, they are doing fiber optic intubations at our institute.
Okay, thank you. We move to the next presentation, which is clinical efficacy of humidified nasal high flow oxygen in patients undergoing ERCP under sedation or anesthesia. Presenter is Dr. Anila from SIAG.
Assalamu alaikum. I am Dr. Anila from SIAG. The topic of my research was high flow oxygen therapy in patients undergoing ERCP under sedation or anesthesia. There were 2 objectives of my study. The primary was to assess the efficacy and safety of oxygenation supplementation achieved through nasal high flow oxygen during ERCP in a cohort of adult patients. And the second objective was to describe the frequency of adverse events, if any, related to nasal high flow oxygenation and airway management during sedation of adult patients undergoing ERCP. Introduction. In advanced hypoxemia during procedures with IV sedation has implications for endoscopy efficacy and for the patient safety. In adults, analysis of case report of 8,000 procedural sedation indicates the incidence of hypoxemia are as high as 60%. Other studies suggest a occurrence of rate of hypoxemia in adults between 26 to 85%, where procedures are performed under sedation. One new method has been described as an alternative to conventional oxygen delivery method due to several advantageous features. This new method is described as nasal high flow therapy system with delivery of heated and humidified gases at flow rate matching peak inspiratory flow, thereby allow a non-inspired fraction of oxygen via nasal cannula. There are multiple benefits of nasal high flow cannula, including heating and humidification of the flow. It facilitates the tolerability by the patients, washout of nasopharyngeal and upper airway dead space, reduction of inspiratory resistance, reduced work of breathing and provision of flow-dependent positive airway pressures which increases an expiratory lung volume and further improves oxygenation. There are certain limitations of high flow therapy, including completely fails to clear carbon dioxide, cannot protect the airway from aspiration, so it's a tool to delay desaturation, not a replacement for mechanical ventilation. This diagram shows a device of high flow cannula. It has a stand having humidifier that controls the temperature. There is a bag attached in which we have to fill the water for humidification. It has a nasal cannula that is softer. It can be easily tolerated by the patients. The study was a single center prospective cohort study. That was an observational study. The study was planned for a duration of 6 months. The total number of patients were 509. Patients included in my study were aged more than 18 years, require ERCP procedure with IV sedation. Patients who were excluded from the study was aged less than 18 years, contraindicated for nasal high flow therapy, including raised intracranial pressure, known basal skull fracture or orbital or facial fractures, or patients with active nasal bleed, severe cardiorespiratory compromise, or any other indication that necessitates the procedure to be done under endotracheal intubation. Method: standard monitors applied, including continuous electrocardiogram, blood pressure that measured after 3 minutes, pulse oximetry. The procedure was done in either lateral or prone position. Pre-oxygenation with a gas flow of 20 liters per minute with 100% FiO2 was applied at least 3 minutes before anesthesia induction by using this device. The flow was gradually increased after administration of sedative agents and was maintained at 40 to 50 liters per minute during the procedure. Flow tapered off as procedure ended. The result was, this study included the age group 20 to 30 years, 137 patients, from 30 to 50 years, 180 patients, 51 to 70 years, 155 patients, and the patient more than 70 years were 37. There was slight difference in gender, having female patients 269 and where the males were 229. The mean saturation at 5 minutes after the start of procedure was 98%, 85%, with most readings ranging from 99 to 100%. It means it remains same throughout the procedure in most of the cases. The mean saturation at 45 minutes post-procedure was 98.8%, indicating sustained oxygenation. Only 6 patients experienced desaturation, that was less than 92%, and indicating 0.91% of the total number of cases, sample size, representing a very small proportion of total cases. Post-procedure vital signs remain hemodynamically stable in majority of patients. Patients with more than one comorbs were 182. Common comorbidities include hypertension, diabetes, and COPD sepsis aged more than 60 years. Number of patients with any complication were 87 out of 509. Most frequent complications noted were hypotension, hypertension, tachycardia, brady, hypoxemia, and little airway secretions. Management of complications: all complications were managed clinically with no major adverse event. There was minimal impact on procedure workflow. Airway complications were managed with minor airway maneuvers. Intubation was not required in any case. The high flow oxygen therapy, particularly high flow nasal cannula, has emerged as a significant agent in the respiratory support during endoscopic procedures. This technique delivers heated, humidified oxygen at high flow rate, which can enhance patient safety by reducing the incidence of hypoxemia. The evidence suggests that high flow is particularly beneficial during gastrointestinal endoscopy and other sedation-related procedures, although its cost-effective remains a topic of discussion. This device has known a marked reduction in desaturation events compared to conventional oxygen therapy. For instance, desaturation occurred in only 5.2 patients, while versus patients that received conventional therapy 27.2. And according to Karen et al., in non-obese patients, desaturation rate was significantly lower. That was 2.2 versus 25.2%. According to Karen et al., high flow has also resulted in few rescue maneuvers and procedure interruptions, indicating a smoother endoscopic experience. So the conclusion is the procedure demonstrated excellent oxygenation maintenance and overall hemodynamic stability across a study population. Incidence of hypoxemia was minimal, indicating a high level of procedural safety. The overall finding demonstrated that the procedure were conducted with a high level of safety and efficacy. Most complications were minor and manageable. No major adverse outcome were observed, and the procedure workflow was minimally effective. These observations highlight the effective peri-procedural monitoring, timely interventions, and well-maintained patient safety throughout the procedure. Thank you.
Questions from the judges?
It was a nice presentation. What analgesia you were using in these patients?
Madam, we are using opioids.
Which opioid?
KINS, nalbuphine.
Nalbuphine. According to the weight?
No, sir. No, madam. With minimal dose, 2 to 3 mg.
Was that okay for the patients?
Yes,
it
ma'am.
was not according to the weight?
No, madam. As the endoscopic procedures are minimally invasive, the patients are not suffering from the much pain, and we are also using paracetamol in case patients needed pain, feels pain.
Okay. Were you using capnograph in these patients?
Madam, not yet. We haven't used this.
Okay. Thank you.
Any questions? Yeah, audience.
You said that you used paracetamol. Paracetamol you used before preoperatively or during the
We are not using it regularly. In case patient is having pain post procedure, then we have to give paracetamol. Otherwise, we are using just nalbuphine in very low dose.
As we know, paracetamol takes 30 minutes to affect. Procedure is 10 to 15 minutes.
That's why we are not using it regularly.
Okay. Thank you.
Okay, thank you. We move to the next presentation.
We are moving to the last presentation of this session. Comparison of the hemodynamic effects of the dexmedetomidine versus placebo in the patients undergoing intubation at Tertiary Care Hospital, Karachi. Dr. Khadija Anwar from Rutfau Civil Hospital, Karachi, present the topic.
Okay, Assalamu alaikum everybody. This is Dr. Khadija, and I am a faculty researcher and senior registrar at Dog University of Health Sciences. The topic that I am presenting today is the hemodynamic response of dexmedetomidine versus placebo in patients undergoing intubation. So the clinical challenges that were presented were laryngoscopy creates a significant, profound sympathetic adrenal response, which creates morbid consequences like arrhythmias, ischemia, pulmonary edema, increased intracranial pressure in vulnerable groups. Various techniques although have been implemented like opioids and sympathetic blockers, but each with its own set of hazards. And therefore to introduce a non-invasive, effective, receptive and a tolerable technique in a high volume, low resource setting was my main motivation to do this trial. The purpose was this study was to serve as a baseline for development of management guidelines and to create an effective method to be implied in a low resource, high volume setup that can easily be implied. The objective of my study was to compare the hemodynamic effects of dexmedetomidine versus placebo in patients undergoing intubation. My sample size was These were the material and methods. This was a randomized controlled trial in setting of the tertiary care hospital, duration of 6 months and sample size 88, which I calculated via the computerized software. The sampling was non-probability consecutive sampling. Inclusion criteria was ASA 1 and 2, Malampatti 1 and 2, age between 30 and 80 years, elective surgical procedures, and those who had consented for the trial. Okay, so ethical considerations. Now, each patient that we underwent the trial, a complete informed consent was obtained, and the procedure was explained. Potential benefits of the study was explained to them, and only when they agreed, we included them in the trial. Approval from the clinical trial unit and the ethical review committee was taken. In my methodology, I used 1 microgram per kg of dexmedetomidine. This dosage I decided, keep bearing in mind the clinical efficacy as well as the safety of the patient. And the vitals were noted 10 minutes post-intubation. This was an intergroup comparative study, and the mean arterial pressure was my primary metric. Okay, so 2 groups based on basic randomization through computerized randomization and open envelope method were put into 2 groups. One received 5 ml of nebulized dexmedetomidine, 1 microgram per kg, and the other received 5 ml of normal saline. So this is my sample distribution according to gender and ASA status. The reason that I am mentioning this separately is because these were further found to have a potential influence on the results. And therefore, I have stratified my result according to the gender and the ASA status. So as you can see, the testing group has a preponderance of female gender, and the ASA status is comparable in both the groups. Similarly, I have also stratified the data according to the physiology, according to the comorbidities, that is diabetes and hypertension, because these are known influencers of hemodynamic response and autonomic response. Okay, so the drug that we used in this trial was dexmedetomidine. Dexmedetomidine is an alpha-2 agonist. It is FDA approved for sedation in ICU and perioperatively. However, its non-approved uses extend to as adjunct for general anesthesia, for local regional anesthesia, for central neuraxial blockade, as well as to fight alcohol withdrawal for alcohol withdrawal and for surgeries which involve awakening mid-procedure. So it has 65% bioavailability via the nasal and 82% bioavailability via the buccal route. It is these pharmacokinetics which we have used to our benefit in this trial. So my research hypothesis was nebulized dexmedetomidine mitigates the hemodynamic response compared to saline placebo. This is a summary of my continuous variables. And the baseline variables and the physiological parameters were comparable in both the groups. These are the results of my test. Amongst the prime focus is the mean arterial pressure. As you can see, the testing group had a mean arterial pressure which was different from the placebo group, nearly 10 millimeter Hg, and a p-value of 0.03, which proves statistically significant. Okay, so further I stratified my data according to biological stratification. So those who were in younger age group had a better mitigation of hemodynamic response when exposed to dexmedetomidine. Female gender had a better mitigation of hemodynamic response, and mild systemic illness had a better mitigation of hemodynamic response. Similarly, according to my medical stratification, those who were diabetics and those who were hypertensive had a better mitigation of hemodynamic response according to my results. The limitations of my study was that it was a single center study and a small sample size. An interval, post-nebulization interval should have been fixed in order to match the maximum noxious stimulus and the peak bioavailability of dexmedetomidine. There was varied levels of clinical experience of the anesthetist performing laryngoscopy, and no objective monitor was used to rule out the effect of anesthetic agent. So In case I need to make the improvements, I'll make improvements on these lines only. I will fix the post-nebulization time. I will use a BIS monitor, larger sampler size, multi-center study, and the intubator with an identical level of experience. So my conclusion is that the mean arterial pressure in placebo group was significantly increased, and it supports my research hypothesis and rejects the null hypothesis that dexmedetomidine successfully, nebulized dexmedetomidine successfully mitigates the hemodynamic response to laryngoscopy. My final remarks are that dexmedetomidine provides superior stability to standard saline placebo and can be used as a routine utility. It has improved safety as compared to IV, intranasal, and IM routes. And our nasal mucosa is a large surface area and largely vascularized, and therefore we can successfully use it to obtund the cardiovascular response. And thank you.
So, question from the judges.
So, you took both hypertensive, non-hypertensive patient and diabetic and non-diabetic patient in your study. So, do you think this may affect your result and final recommendations?
It did. It did. So those who were hypertensive, because there was a difference of physiology and response of these patients, and what we found out that those who had mild systemic illness, for instance diabetes and hypertension, controlled diabetes and hypertension, responded in a better way to nebulized dexmedetomidine.
Question from the audience? No question? Okay, madam.
Thank you.
So, thank you very much. Our first presenter who was not here, I was told, but he's here now, so we have another 10 minutes to go. I'm going to call Dr. Ibrahim from Sir Syed Hospital, and he's going to present perioperative determinants of mortality in older adults undergoing hip fracture surgery, a systematic review and meta-analysis.
Assalamu alaikum. I'm Dr. Mohammed Ibrahim, Senior Registrar from Sir Syed Hospital, Karachi. Today I will be presenting my meta-analysis and systematic review on the determinants of the mortality after hip fracture surgery in older adults, influence of the surgical, anesthetic and radiological factors. It's a systematic review and a meta-analysis. This study evaluates the major perioperative factors influencing mortality following the hip fracture in elderly. So hip fractures represent a major global health burden, particularly in the older adults. With increasing life expectancy, the incidence of hip fractures are continuously rising worldwide. So these injuries are associated with a significant morbidity and mortality and functional decline also. Reported mortalities of are approximately 5 to 10% at 30 days and can reach up to 30% in 1 year. So main objective of this study will be to understand the modifiable factors which can improve survival and post-operative outcomes. The aim of this systematic review and meta-analysis was to evaluate the impact of surgical timing, anesthetic technique, transfusion, and radiological factors on mortality following the hip fracture following fracture surgery in older adults. So the study design of the methodology that were used were according to the PRISMA 2020 guidelines. Database that were searched for PubMed, Embase, Scopus, Web of Science, and Cochrane Library. Search terms included hip fracture, time to surgery, anesthesia, transfusion, and mortality. The inclusion criteria were the adults with surgically managed hip fractures, adults greater than 60 years of age, reported post-operative mortality, and has been evaluated at least one of the determinants. And exclusion criteria was non-operative management, elective arthroplasty, pathological fractures, and non-English studies without translation. So the data extracted were on the basis of a study characteristic, patient demographics, surgical timing, anesthesia type, whether it is GA or spinal, transfusion data, and radiological findings. A random effect meta-analysis was done. Heterogeneity using I-square statistics, and sensitivity analysis was done. For the risk of bias, Newcastle-Ottawa scale was used, and for the evidence of certainty grade framework were used. So total number of studies that were included were 9, which was a mix of registry-based studies and single center cohorts. The sample size varied from 400 to 1 lakh patients, and most of the studies reported 30-day mortality as a primary outcome. 3 studies evaluated the effect of delayed surgery beyond 48 hours. The pooled analysis demonstrated an odd ratio of 1.42 with 95% confidence interval of 1.20 to 1.68. This indicates a statistically significant increase in mortality associated with delayed surgery. So the causes of the delayed surgery were mostly pneumonia, thromboembolism, pressure ulcers, cardiovascular instability, and this can be due to prolonged immobilization also. Early surgery improves the outcome. 3 studies compared general anesthesia with spinal anesthesia or regional anesthesia. The pooled estimate showed no statistically significant mortality difference with an odds ratio of 0.98. The findings suggest that anesthetic modality alone may not significantly influence survival. Instead, factors such as hemodynamic stability, perioperative optimization, and postoperative care were more, and choice of anesthesia should be individualized. So blood transfusion result, the main analysis was the risk ratio of 1.53% and 95% confidence interval 1.10 to 2.12, which likely interprets that higher mortality in transfused patient is likely reflects the severe anemia, greater blood loss, and frailty. Transfusion may be the marker of severity rather than a direct cause. Radiological determinants were assessed qualitatively due to heterogeneity in reporting. More complex fractures patterns such as subtrochanteric fractures appeared associated with worse outcomes. However, inconsistent classification systems and variable reporting limited the quantitative synthesis. So the key findings were the strongest modifiable factor is early surgery within the 48 hours. No significant effect or type of the anesthesia on mortality. Transfusion reflects patient severity and fertility, and radiological factors may be promising but insufficient to standardize. So clinical implications, our aim should be to improve system efficiency by giving faster surgical pathways, orthogeriatric co-management, optimize perioperative care using hemodynamic monitoring, delirium prevention, and pain control. Patient blood management should be to restrictive transfusion strategies and minimize intraoperative blood loss. The strength of this study is there is a PRISMA guided methodology, meta-analysis was performed and focus on clinically actionable factors, and limitation. Mostly observational studies were used rather than RCTs, residual confounding, and limited radiological standardization, and small number of studies per determinant.
1 minute.
So in conclusion, early surgery reduces mortality. Anesthesia technique does not significantly affect survival. Transfusion reflects underlying patient risk. Radiological factors require further study. So the final takeaway is efficient multidisciplinary hip fracture care is essential to improve outcome in older adults.
Thank you. Okay.
Thank you for your attention.
Question from the judges?
तो ये सारा जो आपने कंक्लूजन निकाला इसमें तो एक ही फैक्टर टाइम ड्यूरेशन का सिर्फ फर्क है, बाकी तो किसी का भी इफेक्ट नहीं आया.
टाइम ड्यूरेशन का सबसे मेजर इम्पैक्ट ये आता है क्योंकि मोस्टली हमारे पास ओल्डर एडल्ट्स होते हैं, तो ओल्डर एडल्ट्स को फिर ये होता है कि जो हम ट्रीट करते हैं कि उसके नॉन मॉडिफाइड फैक्टर्स के ऊपर इतना ज़्यादा ध्यान दिया जाता है कि जो टाइम हुआ, जो एसेंशियल टाइम 48 आवर्स के दौरान करने का, वो डिलेड हो जाता है. तो आउटकम जो ये है कि जो नॉन मॉडिफाइबल फैक्टर्स को जो इन्वेस्टिगेशन में डिले करने के बजाय,
ये तो गाइडलाइन ही ये है ना कि आप जितना अर्ली कर सकते हैं करें विद इन 48 आवर्स. इसमें कोई नई चीज़ तो नहीं निकली.
Any question from the audience?
Suggested time that they say that it should be, it should be dealt with within 6 hours. तो वो 6 hours वाला literature नहीं था या तुमने उसको देखा नहीं है?
My observational study was focused on the first 48 hours.
वैसे अच्छी useful thing है मेरे ख्याल से that you have done.
Thank you.
Okay, thank you very much. We come to the end of this session of Faculty Research Showcase. I would like to thank all the presenters and our 3 judges. Thank you very much. And the chairpersons for being here for 3 hours.
Special gratitude to both Dr. Fozia and Dr. Masood for chairing this session. Thank you to the audience, to the presenters, to the judges. We would now be moving to the next session, the business session, and I'll be inviting Dr. Talal on the stage to proceed with this.
Thank you so much, Abdullah. Thank you so much, judges. Thank you. We're going to announce the winners of the resident research papers in e-posters after the business session. So to start with the business session, I would like to invite Professor Syed Tipu Sultan on the stage. Sir. He'll be announcing the cabinet of the next year. जी सर बोलो पास. जी आओ इधर, चेयर्स रखो.
सब लोग अंदर आ जाइए. ये छोटा इवेंट है, इसके बाद बड़ा इवेंट प्रोफेसर नूर साहब कंडक्ट करेंगे जो कि मोस्ट इंटरेस्टिंग है. दिस इज़ माय प्लेजेंट ड्यूटी एज ए पैट्रन टू अनाउंस द नेक्स्ट ऑफिस बेयरर who will be managing and conducting such a beautiful anesthesia congress. I am grateful to the present cabinet which organized this well-attended congress since last 2-3 days. Now today, I'm just going to announce the next office bearers and I will request them to come on the stage. So there are 2 patrons for Society of Anesthesia in Sindh, Karachi, the center and Karachi, myself as a patron of PSA Center, Dr. Saida Haider as a patron of Karachi, and Professor Shahida, she is the patron of PSA Lahore. She has just left for Lahore flight. The next office bearers of the PSA of Karachi will be as follows. President Dr. Farjad Sultan. He was president-elect, so he is now president. President-elect is Dr. Asma Abdus Salam. Very hardworking, talented. Vice President Dr. Suhaib. General Secretary Dr. Talal Ahmad to continue. Traditionally, the General Secretary continues for 2 years and the rest of the people active 2 years and the rest of the persons they are changed. Joint Secretary Dr. Nasir Khoso. And Treasurer is Dr. Sidra Javed. So these are the new office bearers. They will manage the next year of Society of Anesthesia monthly meeting and all the academic and non-academic activity, that is different picnics, outdoor activities. Executive members of the next year will be, is a huge list because again, they are all very eminent persons. Executive committee members are Dr. Akhtar Wahid Khan, Dr. Akhtar Aziz Khan, Fauzia Anis Khan, Fazal Hamid, Amin Khwaja, Gauhar Afsha, Nikat Abbas, Nurul Haq, Samina Ismail, Alia Ahmed, Muhammad Hamid, Shabbir Jumani, Zahid Salod, Amin Suleiman, Zia Akhtar, Hamid Ali, Mirza Ali Azhar, Dr. Nasir Ali Rahim, Dr. Ashok Pachani, Dr. Madiha Abbas, Dr. Huba Ahmed, Dr. Abdul Nisar, Dr. Suraj Kumar, Dr. Asma Sharik, Dr. Aqsa Aman Khato. So these are the people who are executive members and see all the activities of the next 1 year. We have got 2 committees which I am announcing. Website committee, Dr. Safia Zafar Siddiqui, Dr. Azhar Rahman. Hai idhar? Good. Newsletter committee, Dr. Zahid Akhtar Rao and Dr. Mohsin Nazir Butt. They have been publishing excellent newsletter. Overseas coordinator, Dr. Vinod Kumar. यहाँ पर है या दुबई में? दुबई में. He is stationed in Dubai. So traditionally, my job is finished here, but again, to continue some sort of tradition, I would like to invite the new president, Dr. Farjad Sultan, to come here and tell few words that how he is going to manage the next year. Farjad. अच्छा ये हाँ yes outgoing sorry एक कुर्सी और चाहिए. Yes, I forgot. Is my apologies. The outgoing president, Dr. Dillu Raja, I would like to request you to say a few words, and then the new president will say a few words.
बहुत बहुत शुक्रिया सब लोगों का, ख़ास करके जितने लोगों ने मुझे सपोर्ट किया, प्रोफेसर टीपू सुल्तान, डॉक्टर सईदा हैदर, डॉक्टर नूरुल हक, बाकी जितने भी सीनियर्स हैं, डॉक्टर फौजिया अनीस खान, और जो भी मेरे साथ कैबिनेट में थे, उन्होंने वाकई दे रियली वर्क हार्ड. और जिस तरह की ये हमारी कॉन्फ्रेंस गुजरी है, वेल अटेंडेड, और तो आप सब लोगों का शुक्रिया. थैंक यू.
Now the new president, Dr. Farjad.
अस्सलाम वालेकुम, थैंक यू वेरी मच. सो फ्यू वर्ड्स तो नहीं होंगे, जैसे कल गवर्नर साहब ने कहा कि ज़्यादा बोलना है तो बस बोलना है, थोड़ा सा फ्यू वर्ड से थोड़ा ज़्यादा होगा. दिस हैज़ टू बी अ फॉर्मल स्पीच. सो अस्सलाम वालेकुम, respected seniors, distinguished colleagues, honored guests and dear friends. It is with deep gratitude and humility that I stand before you today and accept this post of President, the newly elected President of the Pakistan Society of Anesthesia, Karachi chapter. I want to thank all of you for placing your trust and confidence in me. And this honor is not just a personal achievement, but it is a responsibility that I accept with commitment, sincerity, and great respect, and hope to continue the remarkable legacy of this society. Anesthesia today is far more than just the operating room specialty. We are physicians of perioperative medicine, critical care, pain management, and so much more. And our specialty continues to evolve every day. As the new president, I want to focus on three things. The first is education and professional development. I am hoping that all of you will accept this new initiative of forming special interest groups for the Pakistan Society of Anesthesia Karachi chapter. These will be in the area of needs. And what we're hoping is that the SIGs will encourage academic collaboration, faculty development, research activities, and skill enhancement with lifelong learning, which functions within the vision, policies, and governance of PSA. We're going to start with 3 SIGs: simulation-based, education, regional anesthesia training, and airway management. Each SIG will have office bearers, a chair, secretary, PSA members who volunteer to be part of the SIG, provincial representatives, and trainees. I believe that our trainees, our younger colleagues, my younger colleagues, with all their energy, should be involved in all academic activities. The second will be unity and collaboration between private sector, public sector, large hospitals, small hospitals, and other specialties to help in forming policies for better patient care. The third will be advocacy and recognition of our specialty and different activities that we do. With this, I hope that I can live up to the expectations. Thank you very much.
थैंक यू डॉक्टर फरजाद। इसके बाद तो 2 आदमियों की मुसीबत आई, एक जनरल सेक्रेटरी की टू कोप विद दिस प्रेसिडेंट फॉर द नेक्स्ट 1 ईयर, और उसके बाद मुसीबत आई डॉक्टर आसमा अब्दुल सलाम की कि शी इज़ द प्रेसिडेंट एलेक्ट। तो तुम्हारा क्या होगा? कि may I request Talal for his little speech, please.
Thank you so much, sir. Thank you so much, Patron PSA Karachi, Professor Saeeda Haider. And thank you for bearing me for the last 2 years, and apologies to bear me for the next 1 year. I hope I'll continue to work much more and harder this time and live up to the expectations as per my new president. So thank you once again. Thank you.
बहुत ज़रूरी अनाउंसमेंट है। डॉक्टर शहाब, जनरल शहाब यहाँ बैठे हुए हैं, 1 मिनट आ जाएंगे आप। बहुत ही इम्पॉर्टेंट कांग्रेस हो रही है 9, 10, 11 अक्टूबर को बुरबन में। बुरबन में ट्रेडिशनली हम लोग हर 2 साल में कांग्रेस करते थे और शहाब साहब ऑर्गेनाइज करते थे। बहरहाल जालिमों ने इनको रिटायर कर दिया, तो फिर और दूसरे काम में लग गए। अब इस साल फिर ये कांग्रेस ऑर्गेनाइज हो रही है। मैं आप सबों से रिक्वेस्ट करूँगा कि बाय सम मैकेनिज़्म चलें सब लोग वहाँ, इसलिए कि वंडरफुल कांग्रेस होती है ऑन अ वेरी नाइस साइट। और शहाब साहब को बुलाने का मकसद यहाँ ये है कि आप सबको एक ब्रीफली बता दें बिफोर वी डिस्पर्स फ्रॉम दिस साइड, क्योंकि आप लोग को डिस्पर्स होने की ज़रूरत नहीं। अभी नूर साहब आ रहे हैं जो कि रंगारंग प्रोग्राम यहाँ ज़बरदस्त करेंगे इस वक्त। तो शहाब साहब, आप ज़रा क्विकली बता दीजिए रिगार्डिंग दिस प्रोग्राम।
थैंक यू सो मच सर।
I'm really grateful to the our patron Professor Tipu Sultan, जिन्होंने मुझे ये मोटिवेट किया कि दोबारा से आप इसको शुरू करें। और हम लोगों ने ये कॉन्फ्रेंस ऑल्टरनेट ईयर्स पे हम करते थे बुरबन में एपीकॉन के नाम से, एनेस्थीसिया पेन एंड इंटेंसिव केयर कॉन्फ्रेंस। तो इससे पहले हमने 14 कॉन्फ्रेंसेस की थी, तो फिर बीच में गैप आ गया, कुछ कोविड की वजह से आया, कुछ फिर बाद में हमारी सुस्ती हो गई, तो फिर वो डिले होता गया। तो इस दफ़ा सर ने बहुत ज़्यादा मुझे कहा, मोटिवेट किया कि नहीं आप दोबारा शुरू करें, वो एक अच्छी गैदरिंग हो जाती है वहाँ पे। तो सो दिस ईयर वी आर डूइंग इट फ्रॉम 9th to 11th of October, और आप लोग सारे आएँ, जितने ज़्यादा लोग आएंगे उतना अच्छा है। और ख़ास तौर पे यंगस्टर्स, क्योंकि यंगस्टर्स के लिए वैसे तो खैर एक गैदरिंग और लर्निंग तो है ही, उसके अलावा हमने जो सेशंस रखे हैं, फॉर एग्जांपल यंग प्रेजेंटर अवार्ड, उसमें हम उनको अवार्ड देते हैं अबाउट 100,000 रुपीज़ का इस दफ़ा हमने सोचा देने का। उसके अलावा जो हमारे पोस्टर सेशंस हैं इलेक्ट्रॉनिक के, उसमें हमारा ख्याल है कि रजिस्ट्रेशन उनको यूरो एनेस्थीसिया कॉन्फ्रेंस की करा के देंगे, जो बेस्ट स्पीकर होगा उसको, एट दैट कॉस्ट अबाउट 400 pounds और सो। तो वो ये 2 अवार्ड्स हम देंगे। उसके अलावा जो बाकी रूटीन की एक्टिविटीज़ हैं, वो अगर कुछ ना कुछ आप वेबसाइट ज़रूर जाके देखें एक दफ़ा, और वो सिर्फ epiconofficial.com.pk के नाम से है, और वो हमने ग्रुप्स पे शेयर भी की हुई है, उसको ज़रूर विज़िट करें, क्योंकि वो बिल्कुल लाइव है, रजिस्ट्रेशन वहाँ से हो सकती है, उसके ऊपर नंबर दिया हुआ है, उसके अकाउंट नंबर भी दिया हुआ है, अगर रजिस्ट्रेशन कराना चाहें वो भी वहाँ से करा सकते हैं। तो और बाकी वट एवर इंफॉर्मेशन यू लाइक टू हैव वहाँ से आपको मिल जाएगी, और नहीं हो तो फिर जो टेलीफोन नंबर्स हैं उन पर रब्ता करके बाकी भी किया जा सकता है। सो सी यू इन बुरबन दिस ईयर, एंड थैंक यू सो मच फॉर लिसनिंग। एकदम सही बात है। सी यू इन बुरबन 9 to 11 October. Before I ask this new cabinet to go away, I will request the patron of Karachi PSA यहाँ आएँ, तशरीफ़ लाएँ, इनके सर पर हाथ रखें, इनको आशीर्वाद दें, क्योंकि अब ये इनका राइट बनता है। Now they are all directly under you, Dr. Saida, patron of Karachi PSA. You take over.
थैंक यू वेरी मच। चढ़ना उतरना इतना मुश्किल है मेरे ख्याल से, दैट वी कुड हैव डन विदाउट मी। कंग्रेचुलेशंस फरजाद, अस्मा, सिद्रा, तलाल, सुहेब, नासिर एंड द आउटगोइंग प्रेसिडेंट। आई थिंक दिस कैबिनेट हैज़ जस्ट वर्कड ब्यूटिफुली। आई थिंक अजहर शुड ऑल्सो हैव बीन हियर बिकॉज अजहर हैज़ वर्कड वेरी हार्ड। द होल साइंटिफिक प्रोग्राम वॉज designed by him and he has done a wonderful job of it. I think you introduced certain new things and I think they fared very well. जो भी तुमने जो नए 2-3 parliamentary debates and there was something else. Jeopardy quiz. Yes, the quiz, I think that was wonderful. Abdullah Nisar ने इतना अच्छा, it was a wonderful thing. And I mean, इतनी मुझे खुशी हो रही है, एक्चुअली मुझे थोड़ी सी जेलसी होती थी लाहौर वालों से कि लाहौर के नए नए बच्चे काफ़ी आगे आ रहे थे और मुझे लग रहा था हमारे यहाँ थोड़ी सी कमी थी in the youngsters, and I'm so happy that some girls and boys have really sort of popped up, not from nowhere, but and now they are so interested and they're doing it. And I think Asma and Talal and Farjad and all have been active, and inshallah Sidra itna अच्छा काम करती है. All of them work so well, and I'm so happy that इस दफ़ा हर दफ़ा जब कैबिनेट सोचते हैं नॉमिनेट तो किसको बनाएं, इस दफ़ा बिल्कुल प्रॉब्लम नहीं हुआ, बहुत आराम से सारे नाम मिल गए, बिकॉज वी डू ट्राई कि सारे इंस्टीट्यूशंस इसका हिस्सा बने. एंड ये कोई एक इंस्टीट्यूशन का या कोई एक ग्रुप का ये वो ना हो रिप्रेजेंटेटिव, इट शुड रिप्रेजेंट एवरीबडी, ऑल द एनेस्थीसियोलॉजिस्ट्स ऑफ कराची. एंड आई एम सो हैप्पी दैट वी हैव गॉट सच ए ब्यूटिफुल case mix over here. So best of luck and Happy New Year for all of you. Thank you very much. And I think I'll invite Noor now for...
Madam, मैं ये ना प्राइज अनाउंस करूँगा जो पोस्टर्स और पेपर वाले.
अच्छा, इससे पहले मेरे ख्याल से अजहर should do it.
Yeah.
Azhar, come and announce the results.
This is free.
Assalamu alaikum. So first of all, residents free paper.
Resident free.
According to you people, who is the winner? What do you think? Any guess? Okay. So Dr. Mia Usman stood third in the free paper resident competition. Could you please come?
Dr. Tipu को बुला लो.
Dr. Tipu.
Shifa International Hospital, Islamabad.
Dr. Tipu. Sir, please come on the stage.
जी सर.
कौन है मुजरिम कौन है?
पैसे हैं इसमें?
पैसे भी हैं, लिफाफा भी है. Thank you so much, sir.
So second is Dr. Ramis Khan from AKUH. And now the first one. Dr. Azhar Rahman. In 2011, I received gold medal from sir. So the first one is Nazia Shamim from AQH. Now the resident e-poster.
E-poster.
Okay. Third is Dr. Naila Nadeem from SIUT.
इसके बाद फैकल्टी रेडी रखी. जी सर पैसे हैं सर आप जाए.
Second is Dr. Motasim Tariq from AQH.
Faculty.
And first one is Dr. Sadaf Arshad. Dr. Sadaf Arshad?
Jinnah Hospital, Lahore.
Jinnah Hospital, Lahore. Now the faculty free paper, third position obtained by Dr. Khatija Anwar from Civil Hospital. Second is Dr. Anila from SIAG. And the first position, on first position, we have Dr. Faisal Chamim from AKUH. Thank you.
Thank you so much, Dr. Azhar. I would request the rest of the participants of the free paper and the e-posters so kindly contact to Dr. Hoba after this session for your certificates, because there were so many of the participants and we were running late of time. Now I would like to invite Professor Nurul Haq to conduct the further session of this business session.
वेलकम, थैंक यू। असूका पहले सामने आ जाए। असूका पाकिस्तान। असूका पाकिस्तान ने जो है अपने स्टॉल पे 10 क्वेश्चंस किए थे और उसमें से जिन लोगों ने स्कोर किया है वो गूगल पे सारा वो हुआ है, तो इट्स ऑल क्लियर। इसमें से पास तो 33 लोग हुए हैं, बट वी विल बी एबल टू गिव प्रेजेंट टू 10% ओनली, 9%। अच्छा, सबसे पहले जो आ रहे हैं डॉक्टर नैयर इमरान हैदर फ्रॉम गुजरानवाला। डॉक्टर जाहिद अख्तर राव, प्लीज़ कम ऑन द स्टेज टू। नैयर इमरान हैदर फ्रॉम गुजरानवाला नहीं है तो सॉरी, जो नहीं है तो डॉक्टर लुबना नाज फ्रॉम पेशावर। लुबना नाज फ्रॉम पेशावर, इज शी हियर? चले गए, अच्छा जी। डॉक्टर सकीब फ्रॉम नवाबशाह है? नवाबशाह है। डॉक्टर नीता देवी फ्रॉम गम्बट। डॉक्टर नीता देवी फ्रॉम गम्बट, इज शी हियर? चल है, पहला है, पहला है। डॉक्टर नज़ीर हुसैन फ्रॉम कराची सिविल हॉस्पिटल। नज़ीर हुसैन आए वो? डॉक्टर कमलेश फ्रॉम कराची सिविल हॉस्पिटल कराची। सैयद अंबर बतूल फ्रॉम कराची है? ऐसा नहीं, जो हमारे पास 33 लोगों की लिस्ट है उसमें से मिलेगा। बतूल, अंबर बतूल। लव कुमार फ्रॉम SIUT। मोहब्बत कुमार आ जाइए। है? डॉक्टर जिब्रान शकील फ्रॉम कराची SIUT। डॉक्टर सुमेरा फ्रॉम कराची। Dr. Alina from JPMC. Dr. Alina from JPMC. Alina नहीं है? Dr. Sidra from Hamdard University Hospital. Dr. Shoaib from NICVD. Dr. Haneen from Indus Hospital. Dr. Haneen. Dr. Sanjeet Kumar from LUMS. Dr. Abdullah Nisar from AKU. Dr. Huba from DIMC. Dr. Huba. Dr. Noman Aqil from Ziauddin. बस हो गया, बंद कर दो। Dr. Haris from Hamdard University Hospital. हो गया। थैंक यू अशोका। ये वो लोग जिन लोगों ने गूगल पे टेस्ट दिया था और पास हुए थे उनको इनाम मिला है। बाकी लोग रह गए, कुछ लोग आए नहीं। इनका रह गया, एक रह गया, एक हो गया। अच्छा हो गया, चले आप इंतज़ार करें, दूसरा आप थैंक यू। थैंक यू। डॉक्टर हारिस है, लिख लिया मैंने नाम। डॉक्टर दिलीप राजा प्लीज कम ऑन द स्टेज फॉर गिविंग दी। ये भी लकी ड्रॉ था फॉर सीनियर्स जो हमने FDL के स्टेज पे करा लिया था। डॉक्टर सईद साहब को भी बुला लेते, आ जाएं सईद साहब द स्टेज प्लीज फॉर FDL। आए। डॉक्टर अशरफ ज़िया प्लीज कम ऑन द स्टेज। नहीं कैसे चले गए, अभी तो थे। लक्की ड्रॉ में डॉक्टर निदा शाहिद। गुलमख खान। डॉक्टर सैयद अब्दुल्ला।
डॉक्टर सैयद अब्दुल्ला ने मुझे कहा था मैं उनको भिजवा दूंगा। ठीक
है, भिजवा दीजिए। अच्छा, ये विनर हैं जो क्विज विनर थे, उनको भी क्विज विनर थे। डॉक्टर रमला, डॉक्टर सारा अहमद। डॉक्टर रमला, डॉक्टर सारा अहमद प्लीज कम ऑन द स्टेज फास्ट। डॉक्टर आयशा फर्रुख और डॉक्टर सज्जाद आगा खान। रमला ने बहुत काम किया। ठीक है। अच्छा, ये जो है लकी ड्रॉ वहाँ हुआ था स्टेज पे, उनके काउंटर पे ही, और वहाँ के उन्होंने नाम जो दिए हैं, डॉक्टर सूरज फ्रॉम इंडस हॉस्पिटल, ब्रिगेडियर जाहिद राव फ्रॉम PF, डॉक्टर तल्लाल फ्रॉम इंडस हॉस्पिटल, उधर आगे से प्रोफेसर सईदा हैदर,
ओके डॉक्टर सईद।
ये भी एक ही चीज़ है, सब एक में वज़न कम है, एक में ज़्यादा है। डॉक्टर सफ़िया ज़फ़र, ऊपर आना ज़रूरी है। डॉक्टर हामिद अली, डॉक्टर हामिद अली प्लीज़ कम ऑन द स्टेज। डॉक्टर आसमा अब्दुल सलाम and Dr. Mohammad Hamid from AKU. डॉक्टर आसमा अब्दुल सलाम उठा लेंगी ना? अजहर है, अजहर को बुला लेते। डॉक्टर मोहम्मद हामिद, सर दे दूँ।
जी सर।
डॉक्टर अशरफ ज़िया, ये हर साल आते हैं। वी आर वेरी थैंकफुल टू हिम एंड ही नॉट ओनली कम्स अलोन बट विथ ऑल हिज फैमिलीज। डॉक्टर अक्सा अमान कट्टो, अक्सा अमान है? अच्छा, जो चली गई तो उनका नुकसान है। सिद्रा जावेद, सिद्रा जावेद, जाहिद सिलोड, अच्छा, हुबा DIMC, डॉक्टर हुबा इज हियर। डॉक्टर अजहर रहमान फ्रॉम AKU, डॉक्टर अब्दुल्ला निसार, अब्दुल्ला निसार, डॉक्टर मोहसिन नज़ीर, डॉक्टर फरजाद, डॉक्टर निघत अब्बास, हो गया लास्ट ये लास्ट, हाँ निघत अब्बास। और तो नहीं कुछ,
एक बस ही रह गया,
एक और रह गया। ये एक जो रह गया है वो बच्चा रह गया था, अभी इसको आ जाके ले रिसीव कर ले। है ना? हारिस, अच्छा अब जो है अगला लक्की ड्रॉ जो है वो हॉस्पी केयर की तरफ से है। प्लीज़ हॉस्पी केयर कम ऑन द स्टेज प्लीज़। हाँ करता हूँ आफ्ताब लाइव। हॉस्पी केयर प्लीज़। इन्होंने भी लक्की ड्रॉ अपने काउंटर पे किया था। मेरे पास जो नाम आया है डॉक्टर शब्बीर जुमानी।
मुझे रुकना
नहीं अभी आपको। डॉक्टर तल्लाल प्लीज़ कम ऑन द स्टेज प्लीज़ कम ऑन एंड गिव द प्रेजेंट। कितने हैं तुम्हारे पास? अच्छा, मैं थोड़ा सा अपना पावर इस्तेमाल करते हुए मरियम जमाल को भी दे रहा हूँ, जिसने बहुत काम किया है। मरियम जमाल, मरियम इज हियर।
जी जी सर, आ रही है।
सदफ जहरा एंड आसमा शारिक जूनियर है। जूनियर नहीं, ये
नहीं आप
सदफ जहरा है। अच्छा, तुम आसमा, हाँ तुम आसमा। सदफ कहाँ रह गई? डॉक्टर सदफ आ जाए। डॉक्टर प्रदीप मनाक्मी, पता नहीं क्या है, हाँ मकलानी। तुमने रात भर काम किया, मुझे पता है। हाँ ख़त्म हो गया, लास्ट है ये। अच्छा, देयर इज 10 लक्की ड्रॉ फ्रॉम उस्मान को। तो ऑल उस्मान को प्लीज़ कम फ्रंट, कम ऑन द स्टेज। उस्मान को प्लीज़ कम ऑन द स्टेज। उस्मान को कहाँ है? उस्मान को नहीं पहुँचे यहाँ। अच्छा चलें यार, कोई आदमी ऐसे जाकर के बुला सकता है उस्मान को वालों को? एनीवन कैन गो? तलाल उस्मान को वालों को थोड़ा कर। अच्छा, आफ्ताब लाइफ केयर प्लीज़ कम ऑन द स्टेज प्लीज़। प्लीज़ एक आदमी, अमीन सुलेमान प्लीज़ कम ऑन द स्टेज फॉर द लकी ड्रॉ। दो बड़े निकालो भाई, अमीन दो बड़े निकाल के। डॉक्टर काशिफ फ्रॉम हैदराबाद। डॉक्टर अमीन सुलेमान, ये गलत हो गया। अमीन, हाँ आपका निकला है, मैं आपको दूंगा। कभी भी गलत निकल जाता है। अच्छा, दो और, अब दो दे दो। डॉक्टर संदीप फ्रॉम NMC LRBT है यहाँ पे। डॉक्टर अब्दुल गनी निसार, डॉक्टर अब्दुल गनी निसार, अब्दुल गनी निसार है? निकाल दूसरा। डॉक्टर सऊद फ्रॉम हमदर्द, डॉक्टर सऊद नहीं है? बताइए। अच्छा अच्छा अच्छा, ये हो गया। अब रह गए उस्मान को। उसके बाद फार्माटेक्स का है, उनके 10 इनाम हैं, सब लोग घर लेके जाएंगे इनाम। अच्छा, उस्मान को ने लकी ड्रॉ किया था, उसमें जो पहला नाम है वो दिल्लू राजा फ्रॉम तब्बा हॉस्पिटल। डॉक्टर सईदा प्लीज कम ऑन द स्टेज फॉर अख्तर अजीज, आप आ जाइए, आप आ जाइए। हाँ, दिल्लू राजा प्लीज कम ऑन द स्टेज।
इनको मैंने दिया, ये मुझे
दिल्ली को देना है।
डॉक्टर तल्लाल फ्रॉम इंडस हॉस्पिटल एंड डॉक्टर सदफ फ्रॉम तब्बा। डॉक्टर सदफ आइए। रूल ख़त्म हो गया। डॉक्टर सादिया फ्रॉम NICVD। डॉक्टर सादिया, डॉक्टर सादिया हुआ। है नहीं, डबल नहीं है भाई, ये आपकी लिस्ट है। डॉक्टर महविश फ्रॉम HUH। डॉक्टर महविश, कितने हैं ये टोटल? 2 2 4। डॉक्टर एहसन आलम, डॉक्टर नईम पाशा, डॉक्टर एहसन आलम, डॉक्टर नईम पाशा दोनों नहीं है। डॉक्टर दनेश फ्रॉम शहीद मुतरबा बेनज़ीर भुट्टो। डॉक्टर उमर फ्रॉम इंडस हॉस्पिटल। डॉक्टर सबूर फ्रॉम इंडस हॉस्पिटल। डॉक्टर अहमद शहजाद फ्रॉम कतर हॉस्पिटल। कितने रह गए? आप आ जाए, निकल गया नाम आपका। मुकेश का, हाँ हाँ हाँ, मुकेश का, मुकेश के पड़ोस में मौलवी साहब का। अबे तुम्हारा भी निकल सकता है कभी कभी गलती से। आ जाओ आ जाओ आ जाओ आ जाओ, पता है मुझे नाम रशीद है। हाँ ले ले। चलिए, थैंक यू। फार्मेटिक्स लैब प्लीज कम ऑन द स्टेज। अभी करते हैं ना, पहले काम तो ये कर लें, उसके सबको 5000 दे देंगे आज। बस 10 रह गए और लास्ट है। अच्छा, आप ठीक है, ओके। आपका यही नाम है? अरसलान जाकिर, NMC। जाहिद, हाँ, फ्रॉम NMC आए हैं वो। डॉक्टर मुकेश फ्रॉम, डॉक्टर मुकेश आइए, निकल आया आपका। डॉक्टर नासिर खोसो प्लीज। डॉक्टर सबूर इंडस है? डॉक्टर संजीत कुमार फ्रॉम एलम्स। डॉक्टर निदा फ्रॉम हमदर्द। डॉक्टर नईम पाशा।
मैं रिक्वेस्ट कर रहा था कि जिनके फ्री पेपर और पोस्टर्स थे, जो पार्टिसिपेशन वाले सर्टिफिकेट्स, प्लीज़ यहाँ से रिसीव कर लें अपने, प्लीज़। थैंक यू।
सदब जहरा ने ले लिया? आसमा शारिक। डॉक्टर सिदरा जावेद। अच्छा, अब लास्ट जो है वर्टेक्स ड्रैगर वालों की तरफ से ये है कि उन्होंने ये देखा है कि ये कॉन्फ्रेंस किसने कंडक्ट की है और कौन सीनियर लोगों ने जो है इसको मतलब यहाँ तक पहुँचाया। उनके लिए उन्होंने एक शील्ड तैयार की है। फॉर दैट आई विल आस्क डॉक्टर, हमारे डॉक्टर जनरल शहाब जावेद, प्लीज़ कम ऑन द स्टेज फॉर द डिस्ट्रीब्यूशन ऑफ। हाँ, शहाब नकवी, सॉरी, शहाब यूरोलॉजिस्ट मुझे याद आ रहे थे। वर्टेक्स प्लीज़ कम ऑन द स्टेज। पहला जो शील्ड है जाहिर है पैटर्न को मिलेगा, पैटर्न ऑफ पाकिस्तान, प्रोफेसर टीपू सुल्तान। लो बच्चा, जल्दी जल्दी लेकर सब साथ लेकर आ जाओ, सब ये एक साथ ले आओ यहाँ पे। प्रोफेसर सईदा हैदर। दलाल।
Thank you so much. Thank you very much.
डॉक्टर अजहर रहमान, जिन्होंने साइंटिफिक प्रोग्राम वो किया था इस दफ़ा। फरजाद सुल्तान, जो हमारे नए रहनुमा बने हैं फॉर्म 47 के ज़रिए। भाई जस्ट जोक, इट्स नॉट ट्रू। फरजाद डॉक्टर तल्लाल, जिन्होंने बहुत मेहनत किया है और थर्ड टाइम इनको लिया गया है। ये अमीन ख्वाजा, डॉक्टर अमीन ख्वाजा, प्लीज़ कम ऑन द स्टेज। सुनो इधर, उसको रोको ज़रा। सो दिल्लू राजा। इसने मुझे 4 नाम दिए नहीं दिए। मैं भी रिसीव, मेरा भी नाम है, क्या मैं रिसीव कर सकता हूं? अच्छा, 4 नाम और रह गए हैं, लेकिन इत्तेफाक से वो लड़के नहीं आए हैं, तो हम उनको घर पहुंचा देंगे। मिल गए नाम? मुमताज़ अली और मरियम जमाल। मुमताज़ अली, प्लीज कम ऑन द स्टेज। हाँ सर, दे दीजिए। लो भाई, दे दो। कहाँ है वो लोग?
सर्टिफिकेट
2 और अभी रुक जाओ। डॉक्टर मकसूद फ्रॉम सक्खर।
एक आपका जो दिन चाह रहा है जिससे।
अच्छा ठीक है भाई, तुम्हारा नाम भी निकला हुआ है, तो मैं क्या कर सकता हूँ? किसका है? किसका है?
अच्छा, डॉक्टर मकसूद का एक Dr. Maqsood was the chairperson also for the last session. So I would also, I would request Dr. Maqsood to receive this certificate from you, sir. टीपू साहब से दिलवा दे। आ जाए सर, वो उनको टीपू साहब से लेना
है। क्यों?
सर आप भी आ जाए सर।
ये किसका है?
वो कह रहे हैं ये रखें। Dr. Liaquat Ali also, he was also the jury member in the research paper. सर वो दे देते हैं।
ये भी ले जाओ।
सर वो एक और डॉक्टर लियाकत अली।
भाई लियाकत अली को, ये आपका नहीं है भाई।
नहीं सर, वो लियाकत अली की सर्टिफिकेट थी ना उनकी।
थैंक यू वेरी मच। नाउ इट्स एंड द सेशन। इंशाल्लाह नेक्स्ट डे मुलाकात होगी। थैंक यू।
Thank you everyone. Thank you so much. I would request all the senior members to please head to the Henna Hall and request all the rest of the members, delegates to please show your lunch coupons before entering into the lunch ballroom area B. Thank you once again. See you next year inshallah.